Hello. Shall we? Shall we start? Good morning, dear colleagues. Good morning, ladies and gentlemen. Welcome to the second day of our second annual EOS conference. It's my pleasure to start with the first session today, which is about pancreatic cancer. And it's my pleasure also to introduce Dr. Robert Wolf. Dr. Wolf is a professor of medicine in the Department of GI Medical Oncology at MD Anderson Cancer Center. He is also the Deputy Division Head, Clinical Educational Affairs in the Division of Cancer Medicine and serves as the Program Director for the Hematology Oncology Fellowship. Dr. Wolf graduated from Albany Medical College in Albany, New York, and completed his residency and fellowship training in hematology oncology at Duke University Medical Center. He joined the faculty of MD Anderson Cancer Center in 1997, where his research has focused on the treatment of pancreatic cancer. He has been a collaborator with surgical oncologists, radiation oncologists, and laboratory researchers in trying to understand the causes of pancreatic cancer and to design better treatment strategies for resectable, locally advanced, and metastatic pancreatic cancer. Please join me in welcoming Dr. Wolf, and the stage is yours. Thank you very much. Wish you a nice day.
Thank you, Professor. I'd like to thank the organizers of this year's conference for inviting me. It's a great pleasure and honor to join you. And I would like to just extend my warm wishes to all my friends in the Emirates and those who are watching this program from around the world. So today I'm going to talk to you about pancreatic cancer and to touch on some emerging efforts in early detection. We'll touch briefly on standard therapies and then talk a little about precision medicine. So here's my agenda to talk about the epidemiology, discuss risk factors and prevention, and emerging efforts at early detection. We're going to talk briefly actually about diagnosis and staging, and then complete the talk with a discussion of precision medicine and pancreatic cancer. So in the United States, pancreatic cancer represents only 3% of cancer cases for both men and women. And you can see the different cancers ranking above them, but it's highly lethal tumor, and it represents 8% of all cancer deaths. You can see trends in mortality are changing for both men and women. We see drops in mortality in lung cancer, prostate cancer, colorectal cancer, but unfortunately, pancreatic cancer is flat or actually rising in its mortality. The same is true with women, although now the list includes lung, breast, and colorectal, again, with pancreatic cancer gradually becoming more of a death sentence because the other cancers are improving with their mortality. I've looked at data from the United Arab Emirates. You would say from the top line that there's a distinct difference between the United States and the UAE in terms of pancreatic cancer being much more common in the US than in United Arab Emirates. But that's where the differences remain, because if we look, it's quite similar. 3% of all our cancer cases, 2% of yours, 8% of our cancer deaths, 7% of yours. We currently have it as the third leading cause of cancer death for men and women. Yours is 7th. And I think this trend is going to continue because in the US, pancreatic cancer will be the #2 cancer killer by 2030. And I would see a similar trend developing in the UAE as well. So this is a cancer essentially of older individuals. Peak incidence is between 60 and 70 years of age, but we are seeing increasing numbers of patients with pancreatic cancer diagnosed before the age of 60 and often before the age of 50. Men and women are afflicted in similar incidents, but we do see changes depending on ethnicity, with African Americans having a 40% higher incidence of pancreatic cancer compared to whites and Latinos. Now, this is actually not a data-driven slide, in the sense that this was my perception of what was happening in terms of risk factors for pancreatic cancer over the course of my career. So in the 1950s, a lot of pancreatic cancer was driven by smoking, followed by obesity, with a small number of proportion of patients having what I describe as genetically driven pancreatic cancer, BRCA, ATM, PALB2, etc. Now, in the current era, we see that smoking rates are in fact declining, but obesity rates are rising. And the overall numbers of patients with pancreatic cancer is also increasing. So if we look at smoking rates in the UAE, as I predicted some years ago, we can see it dropping from about 20% down to less than that, about 18% now. But we see a fairly impressive rise in obesity rates in the United Arab Emirates, about 20%, 2007, and by 2016, it was about 30% of your population. And so if we go back to this graph, what we can say is it's estimated that at least 25 to 30% of pancreatic adenocarcinomas are preventable. It is critical for everyone to stop smoking or never start. Weight control is critical because higher weight increases insulin resistance, hyperglycemia, and increased risk for pancreatic cancer. Physical activity seems to be protective, and the intake of fresh fruits and vegetables also seems to be protective. So hopefully, as my career comes to a close, what we will see is not just a continued decline in smoking, but a more dramatic drop in obesity rates. And then pancreatic cancer will become a genetic disease, which is something we can work with surveillance studies, earlier detection, and hopefully the cure rate for pancreatic cancer will start to increase dramatically as we see these shifts occur over time. So moving on to early detection, what we know from data from some time ago is screening in the general population is truly ineffective. Samsung Medical Center in Seoul, South Korea screened over 70,000 patients with CA19-9 levels and an abdominal ultrasound. From that very large population, they found only 4 cases of pancreatic cancer. 2 had localized disease. 1 had a distal pancreatectomy with curative intent. This is 0.0001% of the people they screened. Very expensive and not effective. So what people talk about now is not really screening for pancreatic cancer, but surveillance for pancreatic cancer. Screening is testing in the setting of an asymptomatic general population. Surveillance is testing in an asymptomatic high-risk population. And then diagnostic evaluation takes place, testing for pancreatic cancer in people with symptoms, jaundice, pain, weight loss, etc. So we now see 3 high-risk groups emerging: those with genetic syndromes or a strong family history of pancreatic cancer, those with incidentally discovered pancreatic cysts, and patients with new onset diabetes. So let's talk about genetic syndromes. These known genetic syndromes put patients at varying risks for pancreatic cancer. CDKN2A puts people at fairly high risk for developing pancreatic cancer in their lifetime, almost 40-fold compared to the general population. We know about BRCA, 1 and 2. This increases your risk, but not as dramatically. FAP, Lindstrom, Peutz-Jeghers puts people at extremely high risk for this. The genes are known for this: hereditary pancreatitis, Li-Fraumeni, and ataxia telangiectasia. And so now, as the general population is starting to look at their own genetics, mostly around their heritage, et cetera, and then these clinically relevant genetic testing groups are allowing us to identify more and more people with genetic, germline genetic mutations that put them at risk. Here's somebody who does not have a known mutation, but was part of a strong, of a kindred of people with a strong family history of pancreatic cancer. They had 3 first-degree relatives with it. Here you see a small cystic lesion here. This was decided to be sufficiently concerning with mural nodularity to resect it. And they found islands of invasive adenocarcinoma within the specimen. So at MD Anderson, we've also developed a high-risk clinic for pancreatic cancer run by my colleague, Florencia McAllister. And she has been following NCCN guidelines. So what are the surveillance recommendations for high-risk individuals? Well, it's usually an annual contrast-enhanced MRI or MRCP with or without EOS. EOS can substitute in some populations. And then importantly, when do you start doing surveillance work? For STK11, Peutz-Jeghers, it's at 30 years old. For the familial atypical mole and melanoma, it's at 40, hereditary pancreatitis 40. And then for other mutations, either at 50 years of age or 10 years prior to the earliest pancreatic cancer diagnosis in the family. Now, as part of her clinic, she's also doing discovery platform, looking at serial blood, stool specimens for biomarker discovery among her patient population. The next group that we know can be at higher risk for pancreatic cancer are those with pancreatic cysts. In the US, every year, 22 million Americans have an abdominal CT scan, with about 2.6% of these patients found to have a pancreatic cyst. And so we're identifying about 500,000 people each year with pancreatic cysts. And a subset of these will be intraductal papillary mucinous neoplasms. These are a premalignant precursor, and a subset of these patients will go on to develop invasive adenocarcinoma. So we also have a pancreatic cyst clinic run by my colleague, Dr. Michael Kim from Surgical Oncology. And we've identified patients with pancreatic cysts, predominantly IPMNs. We follow them serially with imaging frequency varying, typically MRI, sometimes EUS. And we're looking for increases in cyst size, muronodularity, and that may prompt EUS-guided FNA or an actual recommendation for surgery. So here's an example of one of my patients. Here he has cysts in the tail of his pancreas, one in the pancreatic neck, and he first came to us in 2016. He was advised to come back the next year, but he was lost to follow-up. 4 years later, in the summer of 2020, he had a PE. This prompted further workup, and he was found to have a CA19-9 level of 2,500. It's very subtle here, but here is the cyst, and then next to it is this more solid area. This was actually where his adenocarcinoma was, but sadly by that point, he had developed a liver metastases. So if we do the math here, we have about 54,000 new cases of pancreatic cancer each year, and about 8,000 arise in the background of cystic lesions. As I mentioned, IPMNs are the most frequent. Lastly, we have new onset diabetics. So here's data out of the group in the Mayo Clinic. And what can be seen is they looked at 219 cases of pancreatic cancer and had been tracking their sugars over time. And you could see hyperglycemia started to occur up to 3 years before their actual diagnosis of pancreatic cancer. In the control, who had low risk of pancreatic cancer, they did not see this. So diabetes certainly puts you at increased risk as a harbinger of pancreatic cancer. So if we look for all subjects greater than 50 years of age, the incidence of pancreatic cancer is 111 to 100,000. But if you look at new onset diabetics greater than 50 years old, look at that. That's an 8-fold difference. And so this is a high risk population. So in a collaborative effort by the Early Detective Initiative for Pancreatic Cancer, the NCI, and the Pancreatic Cancer Action Network, also known as PanCan, we are participating in a trial looking at new onset hyperglycemia and new onset diabetes. This will randomize 12,500 patients. They'll all have blood collected for biomarker assays. And for half the patients, imaging will be part of the intervention to see if we can start to detect pancreatic cancer at an earlier stage. So to summarize, screening for pancreatic cancer in an asymptomatic general population is not effective and very costly. We are now identifying high-risk populations to undergo surveillance, those with known genetic syndromes or a strong family history of pancreatic cancer, those with cysts in their pancreas discovered on cross-sectional imaging, and those with new onset diabetes. In the future, a combination of blood biomarkers and serial CT, MR, or endoscopic ultrasound will hopefully allow for improved detection of pancreatic neoplasms in localized stage, amenable to surgical intervention. Moving on to diagnostic studies. This really relies heavily on computed tomography or MR, MRCP. These studies demonstrate the pancreas in good detail, and it can also reveal the presence of metastatic disease on initial presentation. ERCP has a limited role in diagnosing pancreatic cancer, but the cholangiogram can show a beaded appearance or a strictured appearance, very concerning for malignancy. Brushings can also be obtained at the time of ERCP. These can be variable in terms of yielding a diagnosis of adenocarcinoma. We rely very heavily on image-guided biopsies when there's a metastatic site available, and on EOS for patients with localized disease. To stage our patients, we use thin-cut CT scans, helps us demonstrate the relationship of the tumor to the portal vein, the SMV, and the SMA. Again, we can see metastatic disease to the liver or peritoneum, and we at least image the lung bases. EOS is good when a tumor mass is not evident, but somebody has a biliary stricture. We generally do CT imaging of the chest as part of our staging workup. Laparoscopy is not routinely done in our patients with localized disease. Similarly, we don't rely very much on PET-CT. We will do one if somebody has a very high tumor marker with no CT or MR evidence of metastatic disease. I find it quite useful for patients who've had surgery, have a rising marker, and you're suspicious of locally recurrent disease. So here's a patient of mine from a few years ago. We couldn't see evidence of metastatic disease. The surgical bed looks just fibrosis, fibrotic, et cetera, but PET-CT clearly showed the local recurrence this patient experienced. So in my initial evaluation, once pancreatic cancer is diagnosed, I take a lot of time to decide the performance status of the patient. Are they PS0? Are they a 0 going to a PS1? Are they a 1 going to a PS2 because of pain, weight loss, fatigue, et cetera? Comorbidities are an important thing to evaluate particularly diabetes, any cardiac problems, renal insufficiency, and neuropathy, because these may change your recommendations for treatment. Just to decide if they are somebody who has a obesity / diabetic metabolic syndrome, we ask about maximal lifetime body weight, smoking, alcohol history, and importantly, family history. So most of our management for pancreatic cancer is based on clinical staging, not on pathologic staging. And we now basically agree there are 4 stages of pancreatic cancer. Those with resectable pancreatic cancer, they can be managed with either upfront surgery and adjuvant therapy, or increasingly people are interested in studying neoadjuvant therapy and surgery. Borderline resectable pancreatic cancer, virtually everybody agrees these folks should undergo neoadjuvant therapy with chemo, possibly with chemoradiation, followed by surgery as opposed to upfront surgery. Locally advanced tumors are typically managed with systemic therapy. We often will do induction chemotherapy, and for those patients without progression, we try to do chemoradiation on clinical trials. For metastatic disease, we rely almost exclusively on systemic therapy. So just to give some CT images, this is a patient who presented with painless jaundice, and they have a relatively small resectable tumor in the head of the pancreas. Here's their plastic endobiliary stent. The SMA is free. The tumor is just kissing the SMD, but we consider this resectable. Here's a borderline resectable tumor where the tumor is abutting one aspect of the superior mesenteric artery, but it's not fully encased. Here's a patient with clearly locally advanced disease. This is the celiac axis completely encased with low density tumor. Lastly, here's a patient with metastatic disease starting in the tail. There's a lot of real estate out here for a tumor to grow before somebody develops symptoms. And by that time, patients with tail lesions are usually present with metastatic disease. Now, if we look at the data for adjuvant therapy over time, we can see we have made some improvements with our treatments. One of the things I like to point out is back in 2007, gemcitabine as adjuvant therapy gave a median survival of 22 months. In the more recent era, 2017, 2018, gemcitabine as the control arm gave median survivals of 25 months or 35 months. This is purely a selection issue. These patients are distinctly different than these patients in terms of criteria for going on studies, lower 19.9, restaging studies, et cetera. And so what we have now is 2 standard regimens as adjuvant therapy. Both gemcitabine and capecitabine has been proven to be modestly superior to gemcitabine alone for adjuvant therapy. And FOLFIRINOX, quite strikingly, is superior to gemcitabine as adjuvant therapy. This is a highly select group of patients, had a near normal CA19-9 postoperatively. Now, we've at our institution have had a lot of interest in neoadjuvant therapy, both for resectable patients and borderline resectable patients, but very few randomized trials have been conducted to date. This is the PREOPANC trial performed out of the Netherlands and Europe. This took a group of patients with resectable or borderline resectable adenocarcinoma, sufficiently fit for surgery, randomized patients to either upfront surgery followed by gemcitabine-based adjuvant therapy or gemcitabine-based neoadjuvant therapy followed by surgery. If you look at the intent to treat population, there was no difference in overall survival between preoperative therapy and immediate therapy. But the curves did start to separate later on for disease-free survival in favor of pre-op, local failure-free interval favoring pre-op, and a distant metastatic free interval, also some slight improvement with preoperative therapy. So if we look at patients in this trial with resectable disease, there was really no difference between those who received neoadjuvant therapy and those who had upfront surgery. But for the borderline resectable group, the median survival was clearly improved using neoadjuvant therapy. And then other evidence would suggest neoadjuvant therapy is superior. The R0 resection rate was 40% with upfront surgery, 72% with neoadjuvant therapy. Lymph node positivity, much lower with neoadjuvant therapy. Perineural invasion, much lower. So there's clear treatment effect using neoadjuvant therapy. And again, this is based on gemcitabine monotherapy. Now with gemcitabine, nab-paclitaxel, FOLFIRINOX as components of neoadjuvant therapy, these differences in survival should become greater, both for resectable and borderline resectable patients. For locally advanced disease, years ago, we used to give chemoradiation as initial therapy, followed by chemotherapy, followed by chemotherapy. Then there was a shift to induction chemotherapy, and for those patients with stable or responding disease, to deliver consolidating chemoradiation. Now, however, the data is quite strong that systemic therapy only is appropriate for locally advanced disease. Just touching briefly on the LAP-07 trial, this was a population of patients given gemcitabine for 2 months and restaged. Progressing patients fell off the trial. Another 2 months of gemcitabine was given. Patients were restaged. And about 30% of patients had progressed by this point in time. At that juncture, they had a population they identified that they thought had better tumor biology, and then they were randomized to capecitabine-based chemoradiation or continued gemcitabine. And there was no difference in survival between the patients who went on to consolidating chemoradiation compared to those patients who continued chemotherapy. There was a slight difference in the progression-free survival, however, in favor of chemoradiation for patients who randomized to chemoradiation after 4 months of gemcitabine. So for locally advanced disease, systemic therapy alone is appropriate. It should be pointed out that the addition of chemoradiation to chemotherapy improves PFS, but not overall survival. And as a general rule, capecitabine is a superior radiation sensitizer compared to gemcitabine when chemoradiation is delivered. Okay, so moving on to metastatic pancreatic cancer, we're not going to talk about this in great detail. The point I'd like to make with this slide is as response rate shifted from about 10% up to 22%, and then with FOLFIRINOX 30%, we started to see a distinct shift in median survival and 1-year survival rate. So you really have to get over the 20% response rate hurdle to start to see movement in the overall survival and 1-year survival. What's, I think, more important is how much performance status matters in pancreatic cancer, particularly those with advanced disease. If you look, this is data from the IMPACT trial, randomizing patients to gemcitabine or gemcitabine plus nab-paclitaxel. This is the median survival for gemcitabine plus nab-paclitaxel. If your KPS was 70% going into the trial, 4 months. At 100%, 12.6 months. A 3-fold difference in survival dependent on performance status. And moving on to targeted therapies, virtually none of these prior efforts at targeted therapy, to include bevacizumab, cetuximab, erlotinib, and bevacizumab, the only positive trial was a very limited survival advantage using gemcitabine plus erlotinib over gemcitabine alone. That gave you 14 days of extra life on this trial. So to summarize with where we are with therapies for patients with localized disease, and I put in that category those with resectable, borderline resectable, and locally advanced disease, resection rates are variable. Right now, there's no clear survival advantage of neoadjuvant therapy over upfront surgery, and resection rates in truly resectable patients is 75 to 80%. For borderline resectable disease, these patients can go on to have surgery with curative intent 40 to 60% of the time, and even a small number of locally advanced patients can undergo surgery about 20 to 25% of the time with aggressive multi-agent chemotherapy and chemoradiation. But these two populations require neoadjuvant therapy. As I mentioned before, Karnofsky performance status, or ECOG performance status, is a major predictor of survival, irrespective of treatment arms these patients go on. And you can see the clear differences in survival marching from 70 to 80 to 90 to 100% with your KPS. Okay, moving on to precision medicine. Precision medicine has been defined as medical care designed to optimize efficiency or therapeutic benefit for particular groups of patients, especially by using genetic or molecular profiling. And precision medicine is increasingly used in treatment of malignant diseases. Now, you might be surprised, but in pancreatic cancer, we're thinking of using imaging as an actual biomarker, as both prognostic and perhaps predictive of therapeutic outcome. Obviously, patients with germline mutations, BRCA1 and 2, PALB2, ATM, and others, these are important in terms of what the treatments are increasingly. Those with somatic mutations, RNA expression, we may be able to use some of this data to help us with precision medicine. And then just doing immunohistochemistry and finding MSI high patients, tumors responsive to immunotherapy is very important. So talking about imaging biomarkers, or what we call radiomics, one of the challenges with localized pancreatic cancer is that it's difficult to get sufficient tissue to perform reliable analysis and do next generation sequencing. So a lot of patients with resectable, borderline resectable, or locally advanced disease only undergo a fine needle biopsy aspirate, and that's often insufficient for next generation sequencing. So our radiation oncology group has found that imaging may help identify pancreatic cancer subsets. And right now we divide people into one of two categories. They have a low delta tumor, where the tumor here is not much different in terms of its signal characteristics compared to the surrounding normal pancreas, this crescent here with the stent there. High delta tumors there's a distinct difference between normal pancreas here and the very low density mass here. These are stromal poor, and they're epithelial rich tumors, and we call them high delta tumors. And so what we found is when patients present with localized disease that's low delta, and they go on to have surgery either upfront or after neoadjuvant therapy, their survival is clearly superior to patients with high delta tumors. These are epithelial rich, they have a poor stromal background, and their survival is clearly inferior. Now, these biomarkers may actually be predictive. So if we look at low delta tumors, there's no difference in survival if they get standard dose radiation or escalated dose radiation as a component of preoperative therapy. And that's true with distant metastatic failure-free survival, and importantly, overall survival. However, with the high delta tumors, higher doses of radiation seem to improve survival somewhat. This is retrospective data compared to standard dose radiation for those tumors. So again, We may use our imaging on our routine preoperative imaging to determine what is the treatment we're going to give. These patients may benefit either from more prolonged courses of systemic therapy and perhaps escalated doses of radiation. Now, moving on to some of the germline mutations we know are relevant as part of precision medicine. The most obvious one is BRCA1 and 2. So this is a trial that was performed through Memorial, a randomized trial of gemcitabine with cisplatin, with or without a PARP inhibitor, volaparib, for patients with previously untreated metastatic pancreatic cancer harboring a BRCA1, BRCA2, or PALB2 mutation. There was a high response adding the PARP inhibitor, but the response rates for all patients with gemcitabine plus cisplatin was between 65 and 75%. That's very outstanding compared to FOLFIRINOX with a response rate of about 32%. Median survivals for both arms ranged between 15 and 16 months. Again, 3 to 4 months better, 4 to 5 months better than what is expected with FOLFIRINOX. So gemcitabine plus cisplatin should be considered an excellent frontline treatment for BRCA mutated patients with advanced pancreatic cancer. This likely also applies to things like PALB2 and other DNA damage repair genetic defects. And then we also know that we can use this data about BRCA1 and BRCA2 for maintenance therapy after platinum therapy. So the POLO trial, published in the New England Journal a couple of years ago, took patients with BRCA1 and BRCA2 mutations who were stable or responding to frontline platinum-based therapy for at least 4 months. And then they randomized them 3 to 2 to maintenance therapy with olaparib versus maintenance therapy with a placebo. Progression-free survival was doubled using olaparib compared to the placebo arm. Thus far, there's been no difference in overall survival, but longer-term follow-up is needed to see if there is going to be a difference over time. You can see there's more of a shoulder in survival for those patients who randomize to olaparib. Now, there may be other ways to determine subtypes of pancreatic cancer. One of them is RNA sequencing, and this has helped us identify 2 broad subtypes of pancreatic cancer, what's called classical pancreatic cancer and basal-like. And these contain squamous type tumors, particularly adenosquamous tumors often fit into this basal-like subclass. This is about 80% of cases. This is about 20% of cases. These basal tumors have been found to have loss of GATA6 expression. This is a transcription factor. They're associated with worse survival. And they're not very responsive to FOLFIRINOX. This data is not sufficiently mature yet to help us with precision medicine. But I think over time, if we identify people as having these basal-like tumors, we will likely choose a gemcitabine-based regimen for them over FOLFIRINOX as frontline therapy. And it may open the door somehow to targeting these patients with different therapeutic strategy compared to routine cytotoxic therapy. We've known for years that KRAS is a major driver of pancreatic cancer, but for a long time, efforts to inhibit constitutive KRAS activation have failed. A number of drugs have been tried, all are dismal failures. But now we're starting to recognize there are different KRAS subspecies. You may be familiar with KRAS G12C, there's G12V, G12R, etc., G12D. So at MD Anderson, we have currently going on a phase 1 trial of an inhibitory RNA containing exosome against KRAS G12D, and we're using this in previously treated patients. There's now a second generation KRAS G12C oral inhibitor that's undergoing phase 1 trial for patients who harbor KRAS G12C mutated pancreatic cancer. And we know of other KRAS mutations, G12V, G12R, and I have no doubt that pharma will develop inhibitors to these as soon as they can. So this is a patient of mine that absolutely astounded me just in the last few weeks. This is a lady with metastatic pancreatic cancer, developed rapidly after surgical resection of her primary tumor. She failed gemcitabine plus nab-paclitaxel as frontline therapy. NGS discovered a G12C mutation in her tumor. And after about 6 weeks of therapy, 7 weeks of therapy, you can see the clear response to treatment. This stuff is not the easiest. There was quite a bit of change in her taste buds, some nausea and fatigue, but she was, with dose reduction, she's tolerating it better, and this therapy is continuing. I have never seen this in the 20 years I've taken care of pancreatic cancer patients, to use a targeted therapy and as a single agent to see activity like this. We all know the MSI high story. Unfortunately, there are a rare subset of patients with pancreatic cancer, only about 1% to 2% of our patients. But you can have an MSI tumor without identifying a specific mutation. And so doing immunohistochemical stains for loss of the DNA repair proteins is important to your population of patients. So here's a lady who, again, she underwent surgery, and within months, 2 months of having her surgery, she had relapsing disease, biopsy-proven periaortic adenopathy. After just 3 months of pembrolizumab, she had a complete response to therapy. This has been durable. It's still durable. I didn't give you a more updated scan, but she remains without evidence of disease after early relapse from surgery. Lastly, we know these NTRK fusion events are occurring for about 0.5% of patients with pancreatic cancer. This is a patient of Dr. Eileen O'Reilly's, heavily pretreated with other agents. This is their pretreatment PET-CT obtained before larotrectinib, and they had about a 6-month interval of good response, virtually complete response, lasting about 6 months, and then the patient went on to progress. But again, this is amazing to see these responses using single agents of targeted therapy. So where we are now is basically we have data to support treatments against MSI high tumors, NTRK tumors, BRCA tumors. We hope that some of the PARP inhibitors will also have impact in other DNA damage repair genes such as PALB2, ATM, etc. I'm certainly hopeful that we'll see expansion of drugs available for KRAS subspecies. We may do precision medicine around GATA6 expression and other biomarkers yet to be identified. So to summarize, there are multiple biomarkers of potential utility in patients with pancreatic cancer for those with localized disease. Biomics, radiomics may help us looking at high stromal tumors versus low stromal tumors. Obviously, next generation sequencing, RNA-seq, and even immunohistochemical stains may help identify subsets of patients who will benefit from precision medicine. So precision medicine in pancreatic cancer is in its early phase, but I think it's certain to expand in the near future in clinical practice. So thank you very much for your attention. I'm happy to take any questions.
Good morning again. Thank you very much, Dr. Wolf, for this very interesting topic, early morning today, especially about the precision medicine. I believe we do have 5 to 10 minutes if anybody would like to ask any questions. We would appreciate. Dr. Ghazal, please go on.
Yes, hi, good morning. Thanks for this comprehensive talk on pancreatic cancer. My first question, do you have any experience with the recently talked about blood test from Gallery from Illumina, detecting, early cancer just from blood test? And I believe it may get approval soon in the US. Do you think that will be an additional tool for screening?
We have no personal experience with that. We've been trying for years, particularly with our proteomics group, to look for specific biomarkers, protein-based biomarkers. It's always been combined with CA19-9, which I personally believe limits its utility. Now, I'm not familiar with the Illumina platform in terms of the biomarkers they've developed. We are exploring circulating tumor DNA as a component of our strategy, particularly for patients who've had surgery and we're following longitudinally. And we do think that in the future we will have proof of principle clinical trials where patients, even before there's any radiographic evidence of cancer, if they have a ctDNA that's positive for a KRAS mutation of one form or another, we think those patients should be eligible for clinical trials, particularly for targeted agents, perhaps an immunotherapy approach, etc. So I think these blood-based biomarkers will have utility in the near future. How sensitive and specific they are for early detection, I think it's too early to say.
Thank you.
Second question.
My other question, in the BRCA population, you talked about the cisplatin. Do you think we can extrapolate to oxaliplatin having similar efficacy in patients who cannot tolerate cisplatin?
This is a great question, and it's one that I've wondered about, because I've actually had patients that I've given both oxaliplatin to and cisplatin, and I actually believe that cisplatin may be somewhat more potent. There's a paper in Nature that talks about different mechanisms of action for oxaliplatin and for cisplatin. Cisplatin is truly a DNA damaging agent. It's not clear that oxaliplatin works through that mechanism, but certainly patients who receive FOLFIRINOX who are BRCA mutated will respond to the drug. There's no question about that. But whether it's superior to gemcitabine plus cisplatin, or even FOLFIRI plus cisplatin, which I've used in some of my patients. In one patient, he developed an oxaliplatin setting the known BRCA1 mutation. He had a phenomenal and more durable response using the cisplatin. It was quite striking to me. So these differences, I think we can say.
Most oncologists use modified FOLFIRINOX, and there was one sub-analysis one time, if I recall, more from the nab-paclitaxel folks, that showed if you don't use the full doses, your survival actually will be more down in the 8 to 9 months. And have you experienced that? And do you give full doses?
We do not generally give full dose therapy. It's a great question, and what I would argue is if full dose oxali provides a survival advantage, I am certain it's quite modest. And when you are developing peripheral neuropathy quite quickly, and the higher doses, more fatigue, more nausea, etc., I personally shaved my doses. The average patient gets about 75 milligrams per meter squared of oxaliplatin. Now, the exception is exactly as you've said. For our patients where we suspect they may have a DNA damage repair deficiency, whether we can find it in a genetic test or not, I will give those patients full dose oxaliplatin, because I do think it is important for efficacy for that subset of patients. And those are patients who don't have obesity, they don't smoke, they're thin, active patients. They don't necessarily have a family history, but they have a different, smell to them compared to somebody who's overweight, has insulin resistance or full-blown diabetes. Those patients, I'll usually give lower doses of oxaliplatin.
And one last one on the adjuvant setting. You didn't mention the nab-paclitaxel GEM versus GEM combination. Any comments why the study did not meet its endpoints, where we know in the metastatic setting it's different?
This is another great question. It's just a matter of how much difference you would need to see. I think you'd need a study of probably 600 or 700 patients to see a small difference in survival. I really do believe that FOLFIRINOX is a synergistic combination. I think gemcitabine plus nab-paclitaxel is more of an additive combination. And just as FOLFIRI was not good as adjuvant therapy in colon cancer, I think it's also true that if the combination is more additive than synergistic, you're just not going to see that difference in an adjuvant trial.
Then maybe I have one clinical situation. So a 70-year-old lady with a pancreatic cyst, if you have done EOS, let's say, and you've done aspiration and everything looking benign, how do you follow this patient? She's an ex-smoker.
So that's a good question. Part of the criteria is size. So anything over 3 centimeters is concerning for increasing the risk of invasive malignancy. Nodularity, as we've talked about. But we would typically follow that patient with an MRI probably yearly for a couple of years, and if there's no movement, just spread out the interval for those things. The other thing we're starting to look at is GNAS mutations. When we do an aspirate, we are doing ctDNA for GNAS mutations on that specimen. Because that seems to be an early harbinger of invasive disease. But it's mostly size and signal characteristics of the cyst itself. And if the cyst is stable for a couple of years, we'll start to spread out the interval of MRI, MRCP for patients like that.
Thank you.
Thank you, doctor. I believe we have couple of questions. I will try to take one from the online questions from our colleagues. Would you predict obesity-related pancreatic carcinoma will decline with the era of bariatric surgery? This is one of our colleagues asking.
That's a great question. I think it will, because what bariatric surgery does is it reduces your insulin resistance substantially. And a lot of patients who undergo that procedure will drop their risk. Now, the biggest issue is how long the patient has suffered with obesity, particularly morbid obesity, prior to bariatric surgery. I think earlier age they do it, the less time they have high insulin levels, which is promoting a pancreatic cancer progression, I think the better. So I think if we have a lot of young people who undergo bariatric surgery, we're going to see more impact on not just pancreatic cancer, renal cell carcinoma, gastric and esophageal cancer, et cetera, breast cancer, by using that. Hopefully we can get people to do this with more lifestyle changes and just a better diet and more exercise. But I do think bariatric surgery can play a role here, but I think it has to be an earlier intervention. If too much time has passed with high insulin levels, I think the drivers leading to invasive cancer have already been established.
Okay. Thank you very much, Professor Wolf. I believe we are a few minutes only behind the schedule. So let me please introduce quickly my dear colleague who will be the moderator of the second session, Dr. Dina Hamza. She's a senior clinical oncologist working in Dubai since 2008. She is also a consultant of clinical oncology, MOH Egypt, postgraduate clinical researcher, Ulm University, Germany. Dr. Dina earned a baccalaureate degree in medical school with high honors at Cairo University, Egypt. She therefore completed her medical training at the University of Medicine, Al-Qasr Al-Aini. She worked at various hospitals in Egypt, Saudi Arabia, United Arab Emirates, has published journal articles on various topics. Please, let's welcome Dr. Dina. Thank you.
Thank you, Dr. Tarek, for your nice presentation, and good morning to everyone. I think we have very interesting topics for the day, and in continuation of these topics, without further delay, our next presentation is going to be role of sequencing beyond second line in management of metastatic colorectal carcinoma. And I'm honored to present our professor, his Professor Gerald Prager, who is an associate professor of medicine, board certified in internal medicine, hematology, and oncology. He is the director of the gastrointestinal cancer program of the Department of Medical Oncology at the Medical University of Vienna and Comprehensive Cancer Center in Vienna. He leads the unit for precision medicine in cancer. The main research interest of Dr. Prager is on transitional research, tumor angiogenesis, and he is honored by 20 international awards. He is a well-known member of the scientific committee of the European Society of Medical Oncology. Professor Gerald, the floor is yours. Thank you, and we wish next time we might have you on site. But as per now, we're going to listen to your lecture virtually. Please, the floor is yours.
Thank you, Dr. Hamza, for the very nice introduction. I will directly go into the topic, how can we sequence the treatment of metastatic colorectal cancer beyond first and second line? So if you look on a classical case today, we have different lines of treatment options available for the metastatic setting of colorectal cancer. So first line, eventually we can go into maintenance treatment or chemotherapy for intervals. Eventually we have to reintroduce first line treatment. We can switch to second line. Then we have third line treatment options as a standard available. And some patients go to fourth or fifth line treatment. And the median overall survival in the metastatic setting is now more than 30 months, not only in clinical trials, but more and more also in patients in the daily clinical setting. So if you look in the most updated ESMO guidelines, these were published as the Asia consensus guidelines in 2018, you can clearly see that one treatment aim for the fit patients is the site reduction. And in my personal experience, the fit patients, we should aim probably to go for tumor shrinkage in those patients, because if we have a good tumor shrinkage in first line, this might also be prognostic, so predictive for long overall survival. We all know that we should somehow stratify the treatment of our patients according to the RAS and BRAF mutational status. And there's a clear recommendation that for at least the left-sided primary tumors and RAS wild type, you should go for anti-EGFR plus chemotherapy doublet. And for the right-sided, you can go to chemotherapy triplet or doublet and should use bevacizumab, the same as for the mutated and potentially also for the BRAF mutated tumors. So the question is, if we have a first-line treatment according to the RAS, the mutational status, sidedness of the tumor, and then we have maintenance treatment available, but what do we do next after failure of first-line treatment or progression upon first-line treatment of metastatic colorectal cancer? So I think there are very consistent data showing that anti-VEGF or anti-VEGF-R antibody treatment in combinations with chemo is a very good option in second line. And this is important to say, this is independent whether the patients were treated in first line with bevacizumab, yes or no, because the TML in the all patients were pre-treated with bevacizumab, but continuation of bevacizumab beyond progression led to a significant improvement in the overall survival. But the E3200 trial showed that also patients had the same benefit of addition of bevacizumab if the patients were not pre-treated with bevacizumab in first line. You might consider aflibercept, which is a VEGF trap, and both in bevacizumab pre-treated and non-pre-treated patients, the addition of aflibercept led to a significant improvement in the overall survival. Or you block with an VEGF receptor 2 antibody, ramucirumab, and again, very consistently, we see a significant improvement in second line when it comes to overall survival, which is an important endpoint, not only in clinical trials, but of course in our patients. However, we have to consider that not every patient who starts with first-line treatment goes to a second line. It's a bit more than 2/3 of our patients, however, go to second-line treatment. Approximately half of our patients go to a third-line treatment. We see consistently that while in first line we can expect a tumor shrinkage, in second and further line of treatment, tumor shrinkage is unlikely, but we might achieve a stabilization of the disease control, and then have to improve the prognosis of our patients. So this brings me to the third line setting. What options do we have available in the third line? We can, of course, again, look into guidelines, and we clearly can see consistently that independent of the RAS mutational status in third line, we might have the option to use regorafenib or trifluantiprazole. Both drugs have been shown in clinical phase 3 trials to be efficient, and they met the primary endpoint to prolong the prognosis of our patients. However, if you look in those guidelines, you might see also other treatment options. However, anti-EGFR antibodies are only recommended if not used previously, so in earlier lines of treatment. Immunotherapy is only an option for patients who have an MSI high or mismatch repair deficient tumor. And then there is also a small subgroup of HER2 amplifier. And in those HER2 amplifier, you might use anti-HER drugs like trastuzumab, pertuzumab, or lapatinib, trastuzumab, or other anti-HER drugs if available. So the majority of patients going into a third-line treatment, however, you should choose between trifluridine-tipiracil or regorafenib, or those patients who had not been pre-treated before with anti-EGFR antibody with an anti-EGFR antibody. And only those small subgroup of patients, MSI high or mismatch repair deficient, who had not been pre-treated in first line with an immunotherapy, you might consider beyond second line to do so. But this is a small subgroup of patients. And I think now the recommendation for those patients is much more to use a pembrolizumab in first line and not in later line of treatment, although it might also work there. So let me first talk about trifluantipiracil. Trifluantipiracil, you might be aware of, has been shown very consistently in 3 prospective randomized trials to be efficient beyond second line of treatment. So this drug was first shown in the JOO3 trial, which was a clinical phase 2 trial in Asia, to be efficient in leading to an improvement in the overall survival. However, the RECOS trial, which led to the label of the drug, was an international intercontinental phase 3 trial, and the TERRA trial was an Asian trial, also randomized in all these trials very consistently in a 2-to-1 randomization design. In all trials, the drug was applied at 35 milligrams per square meters, day 1 to 5 and 8 to 12 in a 4-week cycle. These trials were all placebo-controlled with the primary endpoint of overall survival. The only slight difference you might see beside the origin or the countries where the trials were performed was that ECOG-2 patients were allowed in the JOO3 trial. Very consistently, you can see the hazard ratio for overall survival, which was 0.56 to 0.79, but all were statistically significant, showing an improvement in the prognosis of the patients treated with trifluridine. So what is the characteristic of a patient being eligible for trifluridine? Of course, there should be a lack of IV treatment options. So this is in label. So patients should be pre-treated with oxaliplatin, irinotecan, 5-FU, anti-VEGF drugs, and in case of the RAS wild type, also with anti-GFR drugs. The patient should be in a very good to fair performance status, so ECOG 0 to 2. They should be compliant and understand how to take the pill, because it's a day 1 to 5 and 8 to 12 intake. So you should focus on educating your patients how they should take the drugs. What we do in our center, we do testing of the blood cell count in the first cycle already on day 21, because this is the nadir, so that we get a feeling how the nadir looks like in the individual patient. We should proactively discuss potential adverse events like nausea, abdominal pain, and fatigue. So as I mentioned, we are monitoring our patients. At least they should do a blood cell count on day 1 of each cycle. So what we do in our center, we also do an extra blood cell count in the first 1 or 2 cycles on day 21. And you might consider a dose delay if there is a too low blood cell count on day 1 of a new cycle. It's important, if you look on the subgroup analysis, that trifluridine is indeed working independently of the performance status. There are no defined sidedness analysis. However, we can see that it works in rectal cancer the same as in colon cancer, independently of the lines of previous treatments, independently whether regorafenib was used or not, and also in patients which all patients were treated with fluoropyrimidines. Also, if you look in the geographical region sub-analysis, we can see that this drug combination, trifluridine, works independently of the geographic regions, whether Japan, Europe, or USA, with an benefit in the overall survival, but also the secondary endpoint progression-free survival. It's always important, if we talk about a later line of treatment, how does the performance status of our patients look like? Because if we treat patients, it's an important endpoint to prolong the prognosis, so the overall survival, but we also want to maintain the performance status of our patients. And in the RECOS trial, it was clearly shown that 84% of the patients from the start of the treatment until the end of the treatment maintained their performance status ECOG 0 or 1. So there is a very good signal that the performance status of our patients treated with trifluridine is maintained until the end of the treatment. even the time to deterioration of the performance status is significantly prolonged. If you look here in the records data, 5.7 versus 4 months until deterioration of the performance status in the patients in the benefit of trifluridine. And if you look on the pre-connect, which is a clinical phase 3P trial, we can see that the time to deterioration of quality of life was even longer. So while it was in a records trial, 5.7 months, in the pre-connect trial, which is much closer to the daily clinical life, the time to deterioration of the quality of life was 8.7 months. So much longer when we compare it to the randomized clinical phase 3 trial. So this gives us a very positive signal that trifluridine is indeed maintaining the performance status also in the clinical life setting. What's about neutropenia? We all know that trifluridine is very well tolerated, but might lead to neutropenia like other chemotherapies. And indeed, there are some signals that neutropenia is associated as a predictive factor for a better outcome of patients. So if there is a neutropenia grade 3 plus in the first, second, or later cycle, the median overall survival was much better than in the ITT population, or whether in the population who did not experience neutropenia. So I think we as medical oncologists are very well trained to handle neutropenia. We should put the focus on it, and especially in the time of pandemic, we might use GCSF. But if indeed is neutropenia and adverse events observed, this might be predictive in terms of a better outcome of our patients. So we should look this as a positive signal for a better outcome of our patients. And for instance, we in our center, we are using the pegylated GCSF on day 13 in those patients who experience neutropenia, and this works pretty nice. So the day after the last pill intake per cycle. So let me summarize the RECOS trial. The RECOS trial did demonstrate trifluridine to improve the overall survival with a reduction in the risk of death by 32%. The 1-year survival rate did also significantly improve to 27 versus 18%. The PFS as a secondary endpoint also lead to a 52% reduction in the risk of progression. Disease control rate did improve, and the quality or the performance status was significantly longer when compared to the placebo. It's also important that in the very same trial, they did a subgroup analysis on prognostic factors. There was a good prognostic patients, about half of the patients with only 1 or 2 metastatic sites, and the best prognostic subgroup of patients with no liver mets, and the other patients were subgrouped as a poor prognostic factor. You can see that in all subgroups, the poor prognostic patients, the good and the best prognostic patients, the addition of trifluridine led to a significant improvement in the overall survival. This is the very important message. So even in the poor prognostic patients, but it's good to see that the best prognostic subgroup, they experienced a median overall survival of 16 versus 8 months. And so this is very impressive to see that there is a subgroup of patients with a good prognostic factors, but also trifluridine could numerically double up the numbers in months of the overall survival. What's about the other treatment options? If we look, for instance, on regorafenib, we can see this was a randomized trial, which a very good also level of evidence. And then we have now discussed trifluridine, and then there are the options of re-challenging cetuximab in those patients RAS wild type, but the level of evidence is much lower. I will discuss in a second. Let's first focus on regorafenib. Regorafenib was also shown in CORRECT and the CONQUER clinical phase 3 trial to be an option leading to an improvement in the overall survival. Regorafenib in these trials was randomized 2-to-1, a placebo-controlled trial, and you are aware that this led to an improvement in the overall survival. However, the patient selection criteria of regorafenib might be a bit different because, again, to use regorafenib, there should be no other IV treatment options available. They seem like trifluridine. However, I would put much more focus in a good or very good performance status of the patients. So EQ2 patients are for sure not the right patients for regorafenib. They should preferably be less heavily pre-treated. They need to understand how to handle adverse events, and they need to be compliant. If you consider regorafenib in your patients, you should really focus on adverse events before there is the onset of these events. So you should emphasize skin toxicity, hand-foot skin reaction. The patients have to remove the calluses. They have to use urea-based keratolytic creams and discuss fatigue. You should focus very much on patient monitoring. So what we do, we see in the first 2 cycles on a weekly basis our patients. So you need the resources in your centers to handle this drug. When it comes to efficacy, propensity score analysis suggests that there's the same efficacy of regorafenib when compared to trifluridine when it comes in overall survival and progression-free survival. So both drugs are acting totally differently on the biological perspective. However, on the clinical perspective, we see more or less the same efficacy of these 2 drugs. However, the toxicity profile is totally different. While we can see here trifluridine might lead in some patients to hematotoxicity, regorafenib leads more to toxicity, to liver toxicity, hypertension, GI toxicity, and the hand-foot skin reaction. So toxicity profiles are totally different. So the efficacy seems to be the same between regorafenib and trifluridine. However, the subjective toxicity is in favor of trifluridine because for the patients, it's a better tolerable drug. So you have to consider this. And if you decide to go for regorafenib, you should really focus on the toxicity management. So what should we do in a later line of treatment? So normally the conventional lines of therapy is going first line to second line to third line. But we know that some patients have a first line and treatment break, go to second line, or we do a stop and go strategy before we go to second line. And we know in the clinical practice that re-challenging is very popular. However, and we have to be aware of this, the SEER database suggests that we should use as much as different treatment options as possible because this is improving the overall survival of our patients. So use as many treatment options as possible because then the prognosis of your patients is better. However, once again, reintroduction, re-challenging is very often used in the daily clinical practice. By definition, reintroduction means that there was no progression during the treatment, of the treatment, and you used the very same treatment later on. And re-challenging means the patient was progressing during the treatment or shortly after you stopped the treatment, and you give the very same treatment in the later line again. There was a lot of discussion recently in ESCO and ESMO meetings about a strategy of re-challenging. So this means you have in first line, let's say an anti-EGFR antibody. Red cells means they're sensitive clones. You shrink the tumor with the anti-EGFR treatment. Eventually, the tumor becomes resistant. You go to second line treatment with no anti-EGFR. And in third line, you use anti-EGFR again. So this is a very, let's say, attractive approach, how you might treat your patients. But you should be aware that we are here in an experimental setting. So if we look on all these trials which have been performed on rechallenging, these trials were non-randomized trials. So these were just clinical phase 1b or phase 2 trials with a small number of patients. And all these trials have in common that they were non-randomized trials. So the level of evidence to do rechallenging is at the moment much lower than you go to a classical third-line treatment like regorafenib or trifluridine. Even in the cricket study, where the same rechallenging approach was used, where you have cetuximab in first line, you go in second line with a bevacizumab-based treatment, and you use cetuximab plus irinotecan again, you can see that there was a good disease control rate in these patients. However, you have to be aware that this was a non-randomized trial design. The attractive approach in this cricket study, however, was that they were collecting ctDNA in the patients to see the percentage of patients indeed being still RAS and BRAF wild type when you start the rechallenging approach. And you can see that those who still were in the liquid biopsy RAS wild type, they were more likely to have had a good response when you were doing the rechallenging with cetuximab, when compared to those which had a mutation in the ctDNA detected. So in conclusion, I think it's an experimental approach. And if you go for this experimental rechallenging approach, you should use the ctDNA. So look again on the guidelines. The guidelines are very consistent in saying in third line you should use trifluridine or regorafenib. And if you use chemotherapy plus anti-GFR in third line, the guidelines are saying, yeah, you can do so, but only if anti-GFR inhibitors were not given previously. So they're not talking about rechallenging. So you should adhere to guidelines. This is what a study of the NCCN guidelines attachment was saying. If you treat patients according to guidelines, they have a better prognosis, or in other words, if you are not attached to guidelines, they have a higher increase in the risk of death. So guidelines are important. Of course, guidelines are not a rule. They should guiding you in treating your patients. But this analysis clearly shows that if you adhere to treatment guidelines, your patients have a better prognosis. So what's about anti-GFR again in second or third line treatment in anti-GFR naive patients? We know it's effective in leading to response rate in improving the progression-free survival. But you should also be aware that all these trials with anti-GFR in third line were negative when it came to the improvement of the overall survival. So it seems not so attractive in terms of level of evidence and in terms of efficacy to use anti-GFR in third line if you look in these on all these studies when compared to trifluridine or regorafenib. And finally, and these are my last slides, we have now a bunch of different molecular subtypes which might also lead to treatment options in third and fourth line of our patients. I only want to highlight the HER2 approach because we know that HER2 amplification is rare in patients, especially with RAS wild-type status. However, those patients who do overexpress HER2 might have an additional treatment option by targeting her. And there have been now a bunch of clinical trials showing that in this case, the Heracles trial, they were using trastuzumab, lapatinib. There are other approaches with pertuzumab, trastuzumab. We have new anti-HER2 agents like the deruxtecan. But all in common is that patients RAS wild-type, HER2 overexpressing, amplifying, they indeed seem to have an additional treatment options by adding an anti-HER2 drugs to those patients. And what we see in those patients is that seems to have a good response in later line of treatment, or at least a good chance of control of their disease, although in all these trials, the patients were heavily pre-treated. And this is stimulating that we should do a molecular profile in time to know the treatment options of our patients before we start a first and second line, especially third and fourth line treatment. So do the molecular profile to get a good strategy in your patients. Let me sum up in third line. I think it's very consistent for the ECOG 1 and 0 patients. Trifluridine and regorafenib are very good treatment options. Re-challenging or going for something experimental is a good option, in my opinion, for fourth line, because just the level of evidence is a bit lower than for trifluridine or regorafenib. I think for ECOG 2, the best third-line treatment option, in my opinion, is trifluridine. And for the ECOG 3 patients, best supportive care alone, I think it's a fair strategy to handle our patients. So if you want to look up in the summary, we recently were publishing beyond second-line treatment options in the Annals of Oncology, where we did do a systematic review. And what we found was the only support of approved agents such as trifluridine or regorafenib beyond second line is the best way to treat our patients, better than all the other options which we also discussed in this systematic review. In the end, I want to give you a perspective. At the moment, there is the Sunlight trial studying trifluridine plus bevacizumab versus trifluridine alone as a third-line option. This is an international intercontinental phase 3 trial, and we hope that this trial will be positive and proving what we have found in this phase 2 trial, which is demonstrated here, that the addition of bevacizumab to trifluridine will improve the prognosis of our patients in third line. So thank you very much now for your attention.
Professor, thank you very much for the very comprehensive, interesting topic and lecture. Do you have any questions? Dr. Ghazal, good morning.
Good morning. Thank you for this comprehensive talk, certainly. I just have a few points to mention. Do you look at KRAS in your choice in your third line? The reason I'm asking, because Rego has somewhat inferior data in the KRAS mutant, not so with the Lonsurf. Have you seen that, or do you use that strategy?
Yeah, that's a very interesting point. What we see is that RAS mutated patients, they have all in common a little bit of worse prognosis than the RAS wild-type patients. This is, of course, they have limited treatment option when we compare it to the RAS wild-type, but it's also somehow a driver mutation of the RAS MEG pathway. And I think this we should put in focus. So when we go for a third-line treatment option decision, a RAS mutation is, in my opinion, not the key driver in doing the treatment decision. But I think it's good if you consider also the RAS mutation in your experience, and that you then decide to go for a drug like trifluridine if this gives you more confidence in having a better treatment option.
And then the other point, more the regorafenib folks bring up the sequencing question, that there was one study showing, Rego followed by Lonsurf appears to be better than the other way around. But do you buy into the argument that regorafenib will be in your system longer, and it has been shown to maybe decrease when you start Lonsurf, decrease the availability or the action from Lonsurf in the first few weeks?
Yeah, so I think the key problem is that not every patient treated in third line will go to fourth line. So this is the key point. So if you lose, let's say, half of your patients from line to line, so if you have, let's say, 100 patients treated in third line, only 50 will go to fourth line. So the question is, in third line, you have more the fitter patients. Why should you, let's say, give the more toxic drug into third line if you do not reach everybody in fourth line? That's why I prefer to give trifluridine in third line, because then I reach with an efficient and well-tolerable drug more patients. And we have really clearly seen in the records data that almost 84% of the patients will keep in the ECOG 0 or 1 and will be fit enough for regorafenib in fourth line. So this can be an argument. If you do it the other way around, I think it's not wrong. We did do the analysis also in our center to start with regorafenib or trifluridine. We did not see a significant difference if we go for one or the other first. But the biggest challenge is that we lose patients from third to fourth line. And so then you have the decision, what do you do in third line where you have more patients to treat with an efficient drug, and what is the toxicity profile of the drug you're using?
So let me ask you, in your second line anti-VEGF choice, do you stick with the bevacizumab, or are you impressed with the other aflibercept, for example, argument that their population were more higher risk, they had more shorter duration of response to first line? Do you buy into that?
Yeah, it's a very good question. So patients who are doing very good with bevacizumab in first line, I go beyond progression. Patients who are, let's say, more rapid progressing through first line, we try also to switch the antibody and we'll go for aflibercept. If you do the crossover comparison between the TML trial and the VELO trial, aflibercept is a bit more toxic when it comes to GI toxicity, a bit more hematotoxicity. I think there is not a big difference in the efficacy of the drug, because even a subgroup or post hoc analysis from the VELO trial did show that the rapid progressor in first line did not do so well with aflibercept in second line. So I think it's a bit more like your preference of treatment. But what I do in my center is that those patients who are doing well in first line, I stay with bevacizumab beyond progression and go to second line.
And the last point, in the Lonsurf-Bev combination, did it matter if the patient had Bev in first line and second line? Do you think there would be additional benefit in the third line situation?
That's a very interesting question we cannot answer yet. I think we will see the data, hopefully from the Sunlight trial, to see what is the sequence of previous lines of treatment. The idea is, if you do anti-angiogenic treatment in first line, second line, then also third line, you are preventing something we might consider as a rebound effect when you stop an anti-angiogenic treatment approach. However, this is more theoretically, we cannot give you a clear answer yet. I'm happy that we have a phase 3 trial ongoing right now with many patients, international, intercontinental data, and we hope that we can answer these questions soon, but I think it's a really very important, interesting question you're raising.
Thank you, Dr. Hassan. One more question from me. Since the topic is sequencing, and since you mentioned at the end of the very nice presentation the role of the molecular profiling, so what about patients whom we have the molecular profiling results from the beginning, and they are very small cohort of patients who are MSI high or MMR deficient, and there is a role of the immunotherapy? Do we use the immunotherapy here in the sequencing at the first line, or we keep them for further line after failure on chemo?
No, I think now we have the Keynote 177 data, and the MSI high mismatch repair deficient should be considered in first line for immunotherapy. The most solid data are from the Keynote 177 with pembrolizumab. I think they're very intriguing data also with the combination of ipilimumab, nivolumab, but these are phase 2 data, so far non-randomized yet. But first line, I would go for pembrolizumab. If you have a patient coming to your office pre-treated already with chemotherapy and you need a response, you might go for nivo-ipi according to the checkmate data. But I think if you have a freshly diagnosed patient in your office, MSI high or mismatch repair deficient, you should go in first line for immunotherapy just because you have a high level of evidence and you have very good data from the Keynote study.
But what about further lines? If we know this data later on, usually we send at the beginning for the rest testing, we might know later after failure on chemos that they can benefit from immuno. Is there any data to support that, to give them in further lines after failure on chemo?
Yeah, of course. So we have the data, we have checkmate data that you can give immunotherapy in second or third line as well if they have not pre-treated with immunotherapy before. Okay. So this is working. We have the best data with low dose ipilimumab plus nivolumab. This is something you might consider in second or third line treatment in the MSI high patients population. So you can do that, absolutely. So you should provide your patients immunotherapy if they are MSI high or mismatch repair deficient, yes.
Professor Prager, thank you very much for the very nice presentation. I have you have a wonderful day in Austria, and my dear colleagues and audience, thank you for your attendance. Now we're going to have a 10 minutes break, and we'll see you back at 11 o'clock. Thank you very much.
Thank you for inviting me. Bye-bye.
Good morning, everyone. My name is Dr. Faraz Khan. I'm consultant hematologist at the American Hospital. On behalf of the Emeritus Oncology Society, I welcome all of you, and especially on behalf of the Emeritus Society of Hematology as well. So this is a hematology session, and we have the pleasure of having Professor Mohammed Mohty, who's a very well-known figure. He's a professor of hematology and head of the hematology and cellular therapy program at Saint Honore Hospital and Sorbonne Hospital, University Hospital in France, which is one of the largest centers in France and Europe. He has strong expertise in the field of leukemias, stem cell therapy, and over 10 years experience in the development of some key treatment paradigms in the field of leukemia. He's a worldwide, he also has a large network of collaboration in hematology. He was the past president of the European Society of Blood and Bone Marrow Transplantation and current chair of the Acute Leukemia Working Party of EBMT, as well as founder and chairman of the International Academy for Clinical Hematology, and he also serves as a board member on the IFM group. With that, it's a pleasure to invite him, and he will be discussing CAR T cells in hematological malignancies and what we have new, an update. Professor Mohty.
Dr. Faraz, for the kind introduction. Good morning, everybody. Assalamu alaikum. It is really a great pleasure to be part of this great, fantastic event. Thanks to all the colleagues in the United Arab Emirates for the great work you're doing. I would have preferred to be in person with you this morning, but unfortunately, hopefully we will be able to see each other after this pandemic. So I've been asked for this morning to speak about, to give you an update about CAR T cells, and this is a truly revolution ongoing in hematology. These are my disclosures. Let me start first before going into the details, the clinical details of CAR T cell therapy, to just give a brief overview about the anti-tumor immune responses and what makes the success of CAR T cells. I think we all know that the immune-mediated cytotoxicity and responses is likely the most powerful anti-cancer tool. And this is quite well established now since many years. However, we also know that cancer cells in general, whether solid tumors or hematologic malignancies, have developed different tools to escape or avoid the immune recognition. This can be about the low immunogenicity, tumor being treated as self-antigens, the antigenic modulation, the immune suppression induced by the tumor, or the tumor-induced privileged site. And obviously, you can see tumors are very smart in avoiding the power of the immune system. This is why the immune therapy story has been really very fascinating adventure. Here I have mentioned some timelines since the 50s, but actually this has been ongoing since more than 100 years, actually, with little success in the beginning. But then things started moving, especially with the introduction from a cellular therapy perspective of the donor lymphocyte infusions in the setting of allogenic bone marrow transplant, but also, of course, the widespread use of antibodies. And of course, the most famous one is the anti-CD20 antibody, which is definitely curing a patient with non-Hodgkin lymphoma. So today, and this is exactly what you have seen in this wonderful meeting since yesterday, we are living a strong paradigm shift in oncology, where traditionally we aim to target the tumor with chemotherapy, monoclonal antibodies. We have tools to target the host, modulate the immune system, and this is the big success of checkpoint inhibitors. But now I think more and more we will be able to target both the tumor and the host. And this is where we have CAR T-cell therapy, which is now proving a very successful treatment modality. But you need to be aware that also we're talking about CAR T-cell therapy since maybe 4 or 5 years. The first approval in the US was from 2017. Actually, this story has been ongoing now since 30 years. So it takes some time actually to develop these sophisticated tools, although now in the recent years we've seen lots of acceleration, and actually the COVID-19 pandemic is a very, very good example on how you can accelerate research and development and deliver effective anti-COVID-19 vaccines, for instance. So hopefully we will be able to see all this, and you can appreciate now it's a flourishing field. You know, when you look to the cellular therapy landscape, it is quite amazing. Despite the pandemic, for instance, the number of CAR T-cell trials have almost doubled actually between 2019 and 2021. So clearly, this is an amazing and fascinating era. So I know this is broad meetings with hematologists, oncologists, pharmacists, and different stakeholders. So this is why I do apologize if these things can appear very basics, but I thought maybe to cover in a quite broad fashion the CAR T-cell field. So how CAR T-cell therapy works? So first, this is the name given to what we call chimeric antigen receptors. These are cellular therapies, but these are genetically modified T-cells that are designed to recognize a very specific antigen, 1 or 2 or more, on the tumor cells. And once they recognize, they can activate these cells and they can proliferate. And of course, this will lead, hopefully, to a significant and durable killing of the malignant cells. These are now considered as living drugs. So they are meant to be infused, but also to persist, to proliferate. And you will see this is one of the weaknesses, because obviously some patient will continue to relapse. The other important information is that for the time being, we are working almost exclusively with autologous CAR T cells. So the cells are generated from the patient's own blood cells, but there are lots of development now to develop allogenic off-the-shelf CAR T cells. So the process is relatively straightforward, where you would like to, through apheresis, you collect the autologous T cells. They are engineered in vitro to express the cause and to be modified to target a specific antigen. Then they are grown and expanded in culture, and then they are brought back and infused to the patient. So logistically, this process can take a few weeks. So again, this is an important piece of information because obviously this cannot be a sort of an urgent treatment for today or for tomorrow when you decide to give CAR T cells. And you can see the structure of these CAR T cells when, you know, when they are engineered, manufactured. This CAR enables a T cell to recognize the tumor cell antigen. And of course, the CAR T cells, when they meet with the tumor cell, they can multiply, they can release cytokines, and this will lead to the tumor cell apoptosis. So this is the structure of a CAR T cell. You can see we have two major parts, the antigen binding domain and the activation domains. And one important issue, and this can create differences between the different CAR T cell product, is the choice of the co-stimulatory domain. The most popular ones are, for the time being, the CD28 or the 4-1BB. So, and with this kind of structure or combinations, you can imagine that you can create a huge number of different CAR T cell products, because then you can play with all of these combinations. And this is why if you play with these combinations, you can influence the CAR design, the CAR target, the transgene which is co-expressed with CAR. For instance, while you can target an antigen, you can co-express whatever transgene which allow to secrete some cytokines or chemokine receptor. So the T cell growth conditions can vary, the viral transduction techniques, but also in order to get these CAR T cells in, you need to do some lymphodepletion. So you need to create space and to create a favorable environment to allow these cells to grow. So it's a multi-step procedure. If today you would like to decide and create a CAR T cell product, manufacture it, you have to identify the specific tumor antigen for your relevant malignant cell. You need to produce a high affinity antibody, genotype this antibody, transduce the autologous or whatever allogeneic lymphocyte in case you're doing allogeneic CAR T cells. Efficacy needs to be tested in vitro and in vivo. And one important aspect, and this is why it's very complicated in some diseases to develop CAR T cells, because in terms of safety, you need to make sure that there are no cross reactions against normal tissues. So this is crucial, because otherwise, and this is what you will see why it's difficult to develop CAR T cells, for instance, in myeloid diseases, in acute myeloid leukemia or myelodysplasia, because the myeloid antigens would actually lead to the destruction of the full hematopoietic system. And this is obviously not a good thing. So today, actually, CAR T cells, you will see we have products approved in acute lymphoblastic leukemia, non-Hodgkin lymphoma, and very recently in multiple myeloma. And I will walk you through these three indications and give you an update about the recent results. And we'll conclude with some perspectives. In ALL, the first product to be approved in young adults and children was this CTL019, the Tisa-cel, or commercially called Kymriah. This was based on a phase 2 trial, the so-called Eliana trial, Only 63 patients, so you can see a sort of a very rapid, quick development. But these were patients who were unfortunately in a very desperate situation. 10% had primary refractory disease. 48% have received or failed one prior stem cell transplantation. And actually 8% failed 2 prior stem cell transplantation. And what's really impressive, you have a CR rate more than 80%. So very, very amazing results. And when you put together all of the currently available results, whether from UPenn, the Ileana, from CIBMTR, from Seattle, NIH, Memorial Sloan Kettering in New York, you can see here they have been summarized in a review in press by Dr. Gauthier. You can appreciate that actually the results in children and young adults, so young adults goes up to age 25 in general, are very consistent in terms of CAR T-cell response and MRD negativity between 60 to 80%. So this is a very, very high level of response. More recently, we had the data in the adult population, and this can go in very advanced age. Several trials, the ZUMA-3, the Rocket trial, Fred Hutch, UPenn. And again, similar to children and young adults, you can see more than 60% MRD negative CR by flow cytometry. And these are patients who are really highly refractory. As I mentioned in my introduction, obviously these different CAR T-cell products are different in terms of construct, in terms of co-stimulatory domain, in terms of dosage, but still, despite these differences, the results are quite consistent. And when you compare the children and young adults and adults in both, actually, the results are quite comparable. So, and these are really highly refractory disease. They have failed every available option. That's the good news in terms of response rate. The bad news, in my opinion, is that only around 30% of these patients are going to enjoy a long-term response. So the other 2/3 are unfortunately either will continue to be refractory or they will relapse. So it's not 100% success, but obviously you're treating a highly refractory advanced patient, so you would not expect 100% cure. And when you look to the long-term results here from Fred Hutch, actually the best results are the one achieved in the MRD negative patient. The other, I would say, challenge when it comes to CAR T cells is about the toxicities. And this is particularly true in ALL. And we have a new spectrum, I would say, of toxicities, namely the cytokine release syndrome and the neurotoxicities. And because of the high tumor burden you have in ALL, actually, you would expect up to 40 or 50% of CRS and some severe CRS. And this can be life-threatening. This is why the delivery and the management of these patients with CAR T cells is actually performed in highly specialized centers and requires some expertise. This is also true for the severe neurotoxicity. And this is actually consistent whether you consider the adult or young population, but also whether you consider the different co-stimulatory domains and so on. So for the time being, we don't have a clear picture or a clear to say, well, this clear idea to say this CAR T cell product is safer or less toxic, etc. So the profile of toxicity is relatively comparable. So this is the start of the adventure in ALL. And of course, how can we improve results? We want to improve response durability. There is a debate whether you should do allotransplant after CAR T cells to consolidate. And of course, these CAR T cells are targeting CD19, for instance, and the question how to prevent CD19 relative negative relapses. Our approach in my center is that we would recommend to use allo if there is a donor available, and of course the patient can tolerate this. So that was a summary for the story in ALL. Let me walk you through now the other big indication for CAR T cells, and actually the numbers are much higher because the disease is much more frequent. This is the use of CAR T cells in lymphomas. And if you look carefully to the different approved product, actually we have already 4 products approved, the what we call axi-cell, Tisa-cell, Maralo-cell, and Auto-cell. And you can see their indications here. These are in B-cell lymphomas. The most, the older, I would say, from 2017, 18 are these ones, the axi-cell and Tisa-cell in relapse refractory DLBCL, transformed follicular lymphoma. More recently, we had the mantle cell lymphoma indication. And you can see again, the construct are different from one product to another, the dosage, the lymphodepletion regimen used before CAR T cells. The DLBCL approval and development came from 3 major trials, the so-called Zuma-1, Juliet, and the Transcend trial. Again, similar to ALL, these are only single-arm phase 2 or phase 1 trials. The number of patients are much higher, of course, because the disease is much more frequent, but they are adults with relapse refractory DL, diffuse large B-cell lymphoma. The good news, you have a CR rate between 40 to 50%, and these patients have failed, in theory, other options. You can see the OS and the PFS, and similar to the ALL story, it looks like that we have 1/3 of the patients, around 30%, who are going to enjoy a sort of a plateau progression-free survival. So this is clearly a huge advance in very high-risk population. Side effects, similar to ALL, we can face CRS, cytokine release syndrome. Maybe the incidence is slightly lower compared to ALL, 50, 60 to up to 90% in one trial. And we have also the neurotoxicities. So that was the story in DLBCL. I wanted simply to share with you some recent data about the approval in mantle cell lymphoma. You can see the design of such a trial. So these are patients with relapse refractory mantle cell lymphoma. See, they have failed up to 5 prior therapies, so really very advanced. As I mentioned, you need 4, 5, 6 weeks to prepare these CAR T cells, so it's a logistical aspect. So you need, at some point, some bridging therapy in order, to wait until your CAR T cells are available. And in mantle cell lymphoma, there are some options. BTK inhibitors like ibrutinib, acalabrutinib. Lymphodepletion in general, there is a consensus about using fludarabine and cyclophosphamide across the whole CAR T cells. And you can see here the CR rate are really very good, more than 60%, and similar to high-grade lymphoma, DLBCL. The follow-up is shorter, of course, but still you have around 40% plateau, 30 to 40%. So huge advance. Follicular lymphoma, you can see also some results from the ZUMA 5 trial. And again, we do have a similar story, a very high CR rate, very high overall response rate. Another follicular lymphoma, and actually it's really a booming field. If you will attend the next ASH meeting, you will see dozens and dozens of abstracts testing CAR T cells. And for us in the field of hematology, I think the next step is going to come, I think, from these 3 trials. The phase 3 randomized trial, which I have highlighted in yellow, they can be practice changing. For the time being, we don't have the full data set. We have only press releases about the results, especially the ZUMA 7 and Transform trial. And because this is likely showing, according to the press releases, that CAR T cells as second line, so at first relapse, compared to auto transplant, are doing better. So you would imagine that it's going to be really highly practice changing. The third approved indication with a commercially available product is actually the multiple myeloma field. And of course, I'm sure most of you are well aware that the multiple myeloma field, when it comes to developing drugs, is hugely expanding. We have now more than 15 drugs being developed and approved in the last 10 or 15 years. But recently, we have seen a sort of a huge interest in immune therapy in multiple myeloma, especially cellular therapy, and CAR T cells are, of course, the superstars. So in lymphomas and ALL, the target is CD19 because it's highly expressed, and it's a safe antigen to target. In multiple myeloma, of course, CD19 is not an optimal target. Also, the first case report about CAR T cells in myeloma has used actually CAR T cells against CD19. In multiple myeloma, the majority of the products being developed and approved are targeting BCMA, the B-cell maturation antigen, which is a member of the TNF receptor superfamily. It's universally and highly expressed on the plasma cell. And as I mentioned in my introduction, it is a good target because actually you can live without BCMA. So you would avoid to a maximum the off-target, side effects. The BCMA knockout mice are healthy with normal B cells, but reduce plasma cells. And obviously in myeloma, we would like to kill plasma cells. So the first approved product is actually BB2121. This is the code of the product. Now it's called ID-Cell. It was initially developed in a phase 1 study, which was published in the New England Journal of Medicine with 33 patients. These are patients who received a median of 7 prior lines of treatment. So again, very desperate patient in palliative care. High-risk patient. They have received bortezomib, carfilzomib, lenalidomide, pomalidomide, daratumumab, and still the results were rather very good. This has led to the development of a larger trial, the so-called KARMA trial, which was actually published also in the New England Journal of Medicine in February 2021. 128 patients, again, single arm, not randomized, but you can see These are patients who received a median of 6 lines of prior therapy, up to 16. So you would believe how advanced are these patients. And the median time since the initial diagnosis was 6 years, up to 18 years. A typical myeloma population, age up to 78. Another important information that if the patient has no significant comorbidities, you can give CAR T cells into really later ages. So the good news is about the overall response rate, more than 80%, very excellent efficacy. In contrast to ALL and non-Hodgkin lymphoma, we don't see yet a plateau in the myeloma, but this has to do, I think, with the disease and the refractoriness status and the resistance. We have currently around a median PFS, maybe around 9 or 10 months, which is already great in such advanced population. Also, the other information about CAR T cells in myeloma, whether the ID cell or other product, is that in contrast to lymphoma and ALL, the incidence of side effects like CRS and neurotoxicity is much lower and less severe. And this has to do, I think, with the immunocompromised status of these patients. So ID-cell is now approved by FDA and in Europe, and now we're widely using it. Actually, there are a lot of patients, almost waiting list, to get these products. But there is also another very promising, highly effective product, which I believe is going to be available at some point in the next 12 months. This is about the cilta-cel product. Initially, it was called LCAR-B38M. It has been developed initially in a phase 1 trial, Legend 2 from China, and now we have a single-arm, very large trial, 97 patient called CARTITUDE-1, presented at the last EHA and ASCO meetings. Again, you can see here we are talking about a median PFS with this product of 66% at 18 months. And the median duration of response is more than 21 months, so much more than the ID-cell product. But of course, these are different trials, different populations. We cannot compare. But I think very positive, very attractive results. And as usual, the future perspective in multiple myeloma, like in lymphoma and ALL, is to try to bring these CAR T cells into earlier disease stages, and maybe at some point in a frontline stage to challenge actually auto-transplant in multiple myeloma. And you can see some of the most important trials being currently developed. I will dedicate the last 2 minutes of my talk just to emphasize, because this is something striking in myeloma where we don't see a plateau. The patient continue to relapse despite CAR T cells. And I think there are different mechanisms of resistance to the anti-BCMA CAR T cell therapy in multiple myeloma. This can be intrinsic to the CAR T cells themselves, and this is why maybe dual targeting, BCMA, CD38, or other antigens like CS1, SLAMF7, can be useful. As a co-armored CAR T cells like with interferon gamma or gamma secretates. Of course, there are arguments related to the multiple myeloma tumor cells themselves, to the malignant plasma cells, which can lead to loss of the BCMA antigen. And of course, we know that the microenvironment in multiple myeloma creates a sort of an immunosuppressive environment. And of course, this will not help the activation and the persistence of CAR T cells, because we're talking about a living drug. So if you want the effect to be persistent over time, you need to have the persistence of these cells after infusion. So to summarize the CAR T cells in myeloma, I think they are highly attractive. We'll see more and more patients receiving them. Some patients are becoming MRD negative, and these are likely patients who will enjoy longer survival. We need to improve the efficacy. I alluded to this, how to overcome the resistance to allow to have long-lasting CAR T cells. When it comes to side effects compared to lymphoma and ALL, this is, of course, much easier to handle, I would say. And they are likely to move to earlier in the course of the disease. Of course, I didn't allude in my talk to the pharmacoeconomic issues, but obviously CAR T cells are relatively very expensive, especially for those patients who don't have whatever insurance coverage, because the cost, at least the publicly available figures, can be more than $300,000 depending on the product. So this balance between cost, efficacy, safety is something that you need to keep in mind. But at the end of the day, I think we are at the beginning of a true adventure, true revolution in the field of hematology. But this will extend beyond hematology, because now we've seen the first early stage trials in solid tumors, although the problems are different, especially when it comes to the choice of the tumor antigen. They have lots of advantage. They can be infused at a single point in time. Usually in hematology, we give like long-term treatment, maintenance treatment, especially in multiple myeloma. Here we're talking about a single time infusion. It is an HLA-independent antigen recognition, so universal application. You may target a wide variety of antigen. You can use both CD4, CD8 T cells, and one way to try to improve actually the activity of CAR T cells is to work on the T cell composition, the initial product you use to manufacture. Of course, logistics can be problematic, but probably more and more we'll be able to have a rapid generation. And of course, there's no risk of GVHD. So similar to what's happening in the solid tumor arena with the immune checkpoint inhibitors, I think now either whether you have pharmacologic immune therapy or T cell or cellular immune therapy, definitely showing that in cancer in general, whether hematology or solid tumor, you have to rely on these immune therapies, because these CAR T cells are powerful, they are specific, they do have the capacity for memory, durability of protection, and of course the technology can be applied. And you may have seen last week the case report in the New England Journal of Medicine about using CAR T cells in refractory lupus. So you would say you would see the applications of these CAR T cells, of this technology, is really amazing. So with this, I'd like to thank you all for your attention, and I'm more than happy to take your questions. Thank you very much.
Thank you, Professor Modi, for the excellent overview. So we have maybe a few minutes just for a few questions, because I think we're running a little bit behind for the Juma prayer time as well. Anybody from the audience have any questions? Please, you can pass on the mic. Yes, please, go ahead.
Hi, Dr. Muhammad. Thanks for the extensive talk, and you always teach us, especially CAR T is a new field for most of us. I have one comment on on the myeloma trials. Don't you think the fact you showed how many lines of therapy these patients had in most of these trials and the mechanism of failure, do you think earlier adoption of CAR T in myeloma would improve on those mechanisms of resistance?
Yeah, I think this is really a very important and very timely question, and I 100% agree with you. I mean, we are in drug development in cancer, so I think all of us know that you usually do these early trials in the most advanced population. But actually, at the end of the day, this is not where you can get the best of a given treatment. And this is true, you know, to whatever treatment you use. So I think these trials today are leading to the quick approval, but definitely the future will be probably dedicated to earlier use. I mean, in myeloma, you have the example of daratumumab, the anti-CD38 monoclonal antibody. The initial approval and the initial introduction was a single agent in relapse refractory patient. But you know today that we use daratumumab first line. So who remember, you know, the single agent daratumumab use? I think everybody has forgotten about it, you know, 6 or 7 years ago.
And in the large cell lymphoma, I know pending the results we will see from ASH, are there specific properties of patients that you may favor CAR-T ahead of stem cell transplant, like, you know, double hit lymphomas, primary resistance?
Again, I think this is a very good question. And of course, for instance, given the cost and complexity of using these cells, you would like maybe to have a more focused or more stringent choice of the patient, especially when it comes to the first relapse and patient eligible to autologous stem cell transplantation. Unfortunately, I don't think we have the full data to see whether subgroup of patients are likely to benefit more or less from CAR T-cell or from auto. All what we know based on the available information, and this is only press releases, probably at the ASH meeting we'll have more data, is that when you look into the randomized trials, the Transform, the ZUMA-7, it looks like CAR T cells are doing better. This is all I can say. But then it means it's going to be practice changing. Also, maybe this is not going to be 100% of the patient, but then probably you will have patients where CAR T cells will be used in first relapse. So this is huge. We've been using auto transplant in non-Hodgkin lymphoma since 1995, you know, the validation of that by the Thierry Philippe, you know, trial. So 25 years later, it's a total switch in the philosophy of treatment.
Does HIV, have you done HIV patients with CAR-T? I have a current patient that's on this.
So very good question. We, in my center, we didn't do HIV patients who have lymphomas with CAR T cells. But our general approach to HIV in general is that if the HIV is controlled and they are receiving the appropriate therapy, these patients, we treat them like everybody. That's the philosophy of the treatment experience.
And lastly, any comment on neurotoxicity and any predictors on how to handle that?
Yeah, so this is a very good question. Unfortunately, well, in ALL and lymphoma, probably tumor burden can be a good indication about the severe side effects. So it can predict. But obviously, what does it mean? You know, it's a very vague concept. The treatment, I mean, the prevention is more about early recognition. This is why monitoring these patients very carefully on a daily basis and several times per day. You know, you have to make them write something and then you control it several times per day. And you can see their handwriting is going to be altered. The same treatment, for instance, with for the CRS tocilizumab can work in neurotoxicity. So I must confess that it seems to me that it's a learning curve. You know, it's like surgery. When I look to the first patient and I look now, we have less and less side effects, probably because we are becoming more trained, more familiar, but also we are using early intervention. So I think it's like everything you start doing, the initial patients are a little bit fragile, I would say, but progressively, you know, you master the technology and the treatment, and I'm quite confident and optimistic for the future.
last two quick questions, so one there and then.
It is very quick, I will do. Thank you for the good talk. I want in mantle cell lymphoma, especially in very aggressive like blastoid variant. So we usually, after induction therapy, we doing consolidation by autologous stem cell. So do you think it is if addition CAR T cell with the consolidation for mantle cell lymphoma, especially for aggressive variants? What?
No, I think it's a very good question. From a theoretical point of view, I fully agree with you. And probably this is going to be the future. For the time being, the data we have are about the relapse refractory. But of course, if something works very well in the relapse refractory, obviously it will work, I think, in earlier stage. And maybe the consolidation situation is probably an optimal situation, because this is where you get rid of the minimal residual disease and probably allow for long-term cure of these patients.
Thank you.
I think the last question, maybe Dr. Kayan has one last question and then we can end the session afterwards.
Bonjour Monsieur Monti, je suis Kayan Medli, j'étais ancienne chef de clinique en France. Donc, I had two questions. The first one was answered by you. It was on the indication of first-line treatment for curable disease like DLBCL, especially for patients who are ineligible for autologous stem cell transplantation in second line. And the second question, as you know, we are starting in UAE our program of bone marrow transplant, especially for autologous stem cell transplantation. And I would like to have your advice on CAR T cells program. What are the advices to start a CAR T cell program in the countries like UAE who has the money to do it, but who does not have maybe the infrastructure or the expertise?
Yeah, no, very good question, and I can reply bonjour. Je suis ravi d'être là. No, I think your questions are very important. Again, using CAR T cells frontline, for the time being, we don't have the approval. But of course, you know, there are many things that we can use outside the label. Given the cost of CAR T cells, I don't think people are really have lots of flexibility in using them for the time being off-label or, you know, outside the strict criteria. So again, I'm sure and convinced that we will have subsets of patients, especially the high-risk patient, where we would like to use CAR T cells in earlier stage. And I think we will see this in the next 2, 3, or 4 years happening, and I'm confident about it. Now, your second question is about how to develop a CAR T cell program. Well, this is about your infrastructure for cellular therapy and for stem cell transplantation, whether autologous or allogeneic stem cell transplantation. Today, in France, in Spain, and I think in most European countries, and in the US, by the way, right? The centers who are performing CAR T cells are actually the same centers who are doing the stem cell transplant procedures, because you need roughly the same infrastructures when it comes to ICU and when it comes to all the supportive platforms like cellular therapy, like the labs, the apheresis, etc. So it's, you know, it's part of the JC process, for instance, you know, or the FACT process to have all the SOPs. I think it's the goal within reach. Well, obviously, the commercially available products and are the ones, in my opinion, to be started first, because they are well established. And there is a clear accreditation process of the centers, not only by the scientific societies, but also by the companies. So in another word, if you would like to start using whatever the Novartis, the Gilead, the BMS CAR T cell product, actually these companies will perform a very stringent accreditation process of your center to check that you fulfill all the requirements to deliver these cells. So it takes time, it takes several months, if not more than a year, even if you have a stem cell transplant program, to get all this on track. And of course, the other requirement, and this is what I did myself, a few years ago, you need to go and train for some time in places where it is being done. I think all of us in the field of stem cell transplantation, I don't think someone has started doing stem cell transplantation without spending some time training in another center doing stem cell transplantation. And this is similar to everything we do. And, if tomorrow I have to do, I'm totally ignorant, I don't know, to treat breast cancer, then I think I need to go and spend a few months seeing how we treat breast cancer. It can't be only a theoretical perspective.
Okay, so
but definitely, I encourage you to go for this, because I think our patient in the UAE and in the Middle East in general deserves the best treatment, and I think the medical community and all of you guys have all the expertise, the skill, and there's no need, I think, to put these patients in planes and send them elsewhere with huge costs, while things can be done locally in the cultural environment with the local facilities. So 100% agree with you, Doctor.
Thank you very much. Thank you.
Thank you, Professor Moti. Thank you. And here in the hematology community, we're looking forward to a day that you are back with us again. So thank you very much for...
Absolutely.
All right. So with that, Dr. Khan, for your chairing the next session, please.
Oh, it's okay. Where was the presentation? Dear attendees, good morning. I'm Dr. Kayan Maidli. I'm consultant hematology, and I'm working in Bourjil Medical City. I'm the responsible of the hematology department in Bourjil Medical City. So I'm glad and very happy to be chosen today to moderate this session on hematological malignancies and cellular therapy, new indications in hematology, from the allogenic stem cell transplantation and to the CAR T cells. I'm very proud today to present one of my teachers, Professor Ali Bazarbashi, who is also the teacher of many of fellows and young hematologists from Lebanon, France, and USA. Professor Ali Bazarbashi is a professor of medicine, hematology and oncology, professor of anatomy, cell biology, and physiological sciences, associate dean for basic research, and director of the bone marrow transplantation program at the American University of Beirut Medical Center, AUBMC. He received his MD, PhD degrees, residency, and fellowship in France at the University of Paris 7 in France. Dr. Ali Bazarbashi has many researches and many publications, more than 300 articles in very important journals like New England Journal of Medicine, GCO, Blood, Nature Communication, and Cancer Research. He is the chairman of the EBMT Leukemia Working Group, chairman of the NCCN Lymphoma Group for Middle East and North Africa, past president of the Lebanese Society of Hematology, and associate editor of bone marrow transplantation. He has multiple prestigious national and international awards, including the 2008 award of the French National Academy of Medicine. Dr. Ali Bazarbashi, welcome.
Thank you very much, Dr. Kayan, for this very nice introduction. Assalamu alaikum, sabah al khair, good morning, everybody. I would like first to thank the organizers for the very kind invitation. I'm delighted to be here with you, although I would have preferred to be physically present, but inshallah very soon this will be the case. So we have seen with Dr. Mohammed Moti the revolutionary innovative treatment with CAR T-cell therapy. But 50 years ago, allogeneic hematopoietic stem cell transplant was the revolutionary innovative treatment in leukemia and hematological malignancies. By the way, I'm the chairman of the EMBMT Leukemia Working Party, but Dr. Mohammed Moti is the chair of the EBMT Leukemia Working Party. So despite the fact that allotransplant is here since more than 50 years, you can see that these are EBMT data on transplant activity, that both autologous and allogeneic transplant activity is exponentially increasing over the years. And this is, by the way, a job security for transplanters, despite all the innovations and the introduction of new techniques. And if we look to the main indications for allogeneic transplant, you can see that acute leukemia, both AML and ALL together, represent more than 50% of allotransplant activity, but we have also allogeneic transplant for myelodysplasia, myeloproliferative disorders, lymphoma, bone marrow failure, and immune deficiencies, and some other hereditary disorders. So why the transplant activity is increasing? You can see on your left-hand side the median age at transplant over the years. So initially, median age was 30. Between 2001, 2010, it's becoming 50. And in more recent years, we're even close to 60. And despite this increase in the median age of transplanted patients, you can see on your right-hand side the reduced non-relapse mortality, which represented a major barrier for performing allogeneic transplant, particularly in older patients. Another reason for the increased transplant activity is to be able to secure a donor. You can see the blue curve for HLA identical sibling, which is plateauing because you can find a donor from a HLA identical family donor, sibling donor for around 1/3 of the patient. But then what is tremendously increasing are alternative sources for donor, match our related donor in red, and this is thanks to transplant registry development worldwide, and in orange, which is more recent, the introduction of haploidentical transplant, which is making a donor available for theoretically every single patient in need of transplant. Very early, actually, it was recognized that much of the success of allotransplant in cancer is due to the adoptive immunotherapy, the immune graft versus tumor effect. And you can see here the result, the disease-free survival and of patients being highest for patients who had a graft versus host disease, and lowest for patients who did not have any form, neither acute nor chronic graft versus host disease, confirming that the graft versus leukemia effect versus lymphoma effect versus tumor effect is a major reason behind the success of allotransplant. So as you know, development of allogeneic transplant has faced challenges and limitations. One of them was the toxicity of what we call conditioning regimen, which is the high dose chemotherapy with or without total body irradiation that we give before transplant. And the toxicity of this conditioning initially limited the transplant to young and fit patients. Another challenge is finding a donor, post-transplant relapse, and cost of the procedure. Again, similar to what Dr. Marty mentioned for CAR T cells. So on this slide, you can have a summary of the challenge related to toxicity of conditioning regimen. The age at diagnosis, for example, for acute myeloid leukemia, the median age at diagnosis was 68 years. And in the first 2 or 3 decades of transplant, you can see that the median age of transplanted patients was 28 and 33. So, which means that the overwhelming majority of patients with AML were not transplanted and were not benefiting from this procedure. So we talked about the conditioning regimen and what are the way of improving the results with the conditioning regimen for a better and wider application of allotransplant even to older patients. So the concept of moving to what we call reduced intensity conditioning allotransplant and more recently reduced toxicity conditioning. So the aim of these reduced toxicity regimen are to improve clinical safety by decreasing non-relapse mortality, but at the same time keeping the achievement of a graft versus tumor effect, and which means that we are shifting the burden of tumor eradication from the chemoimmunotherapy to the donor immune cells and to the adoptive immunotherapy. And in these reduced intensity and reduced toxicity regimen, you can see different type of regimen developed. Fludarabine in most of them was the backbone as immunosuppressive. And then you add an alkylating agent, busulfan in France, melphalan in the UK, cyclophosphamide, melphalan or busulfan at MD Anderson. And then you add in vivo T cell depletion with ATG or Campath, and then GVHD prophylaxis. So this in vivo T cell depletion is a very important concept. And actually on your left-hand side with very low dose of in vivo T cell depletion, for example, thymoglobulin, you have a high non-relapse mortality due to GVHD and a low risk of relapse. On the other extreme, with a high dose of thymoglobulin, a high non-relapse mortality from infections, and a high rate of relapse because you are reducing the graft versus leukemia effect. And the balance, and that was actually Dr. Mohammed Motsi who made this major advance in the transplant field, is that a thymoglobulin dose of 5 milligram per kilo is the optimal window, which at the same time will reduce graft versus host disease, will reduce infection, with associated with a low rate of non-relapse mortality and a low rate of relapse. We don't have a lot of randomized trials in allogeneic transplant, but we're having some of them from time to time. And one very important one was to compare the old standard conditioning, which was busulfan and cyclophosphamide, to the reduced toxicity conditioning, busulfan and fludarabine. And you can see on your left-hand side that with the reduced toxicity conditioning in blue, you have a significant decrease of non-relapse mortality without affecting on your right-hand side the incidence of relapse. And this resulted in improvement of leukemia-free survival with the reduced toxicity regimen. So we talked about haploidentical transplant. Haploidentical means that you have 50% similarity between the patient and the donor, which means that you can take the father, the mother, the daughter, the son, and most of the siblings. So theoretically, every single patient in need of transplant can have a haploidentical donor. The initial development of haploidentical transplant was extremely difficult because of the following challenges. If you use T-cell replete, so bone marrow, so you do the transplant haploidentical, including the T-cells of the donor, then you have a very high risk of graft versus host disease that is frequently lethal because the T cells of the donor will recognize the non-shared haplotype of the patient and cause a life-threatening graft versus host disease. Then if you do T cell depletion from the graft, you have a high risk of rejection and high failure rate due to opportunistic infection and delayed immune recovery. But one major advance by the Hopkins group was the introduction of post-transplant cyclophosphamide. And actually, you give the conditioning, you do the transplant, and then 3 days after transplant, you start high-dose cyclophosphamide. And this is based on some properties of post-transplant cyclophosphamide. This drug is selectively toxic to proliferating alloreactive T cells and much less toxic to non-proliferating, non-alloreactive T cells, which means that in the first few days after transplant, the T cells of the donor and the patient will start to proliferate. You kill them with high-dose cyclophosphamide while sparing the T cells, anti-CMV, anti-toxo, and you preserve the immunity. In addition, high-dose cyclophosphamide is non-toxic to hematopoietic stem cells, and it has been shown in animal model to decrease acute graft versus host disease. And actually, this is the seminal publication from the Hopkins group showing that post-transplant cyclophosphamide, particularly when given over 2 days, day 3, day 4, or day 3, day 5, will result in a very low rate of acute grade 3-4 acute GVHD, as well as a very low grade of extensive chronic GVHD. And this is actually a publication on transplant activity in Lebanon. And you can see that over the years, the haploidentical transplant has tremendously increased and is almost similar to match-related donor, whereas our genes in the Middle East are extremely poorly represented in international transplant registry because our people are rarely candidate for to be a donor, and you can see that match-unrelated donor was really minimal in our region. And these are some results from AUB MCs. So this is adult AML in first or second complete remission. And from matched sibling donor, you can see 5-year PFS or leukemia-free survival of 55%, 5-year overall survival of 65%. And now if you do the same for haploidentical transplant, leukemia-free survival and overall survival at around 52 and 55%. So almost identical to those of matched sibling donor, confirming the efficacy and relative low toxicity of this procedure. Now, a major challenge of allogeneic transplant is post-transplant relapse. which is currently representing the first cause of death after a matched sibling allotransplant, as well as after a matched unrelated transplant. So once you have relapse after transplant, the survival is quite dismal. This is 2-year survival after relapse for young patients. So this is an EBMT acute leukemia working party study that we recently published, showing that in young patients, we had some improvement in 2-year overall survival after relapse, moving up from 16% to 26%, but still the results are quite poor. And in a patient older than 50, there was no improvement, and survival was and remains quite dismal once the patient relapse after allotransplant. So this is another way of showing this data. And this has led to a great effort to implement maintenance and preventive therapy post-transplant to prevent relapse. So why to prevent relapse after transplant? We have seen because it's the first cause of transplant failure. For obvious reason, neither the patient nor the physician would like to see the patient relapsing. In addition, treatment of relapse post-transplant is suboptimal for most diseases. We have seen the case for AML, and treatment of relapse post-transplant is likely more expensive than prevention for most diseases. So even from a pharmacoeconomical point of view, it is cost-effective to prevent the relapse. One of the first efforts was the use of post-transplant epigenetic therapy with azacitidine and or decitabine, and with the idea that this epigenetic therapy will dissociate the graft versus host disease from the graft versus leukemia effect, shifting the immune response in favor of the graft versus leukemia effect. And the first dose-finding phase 1 study by Marcos de Lima in 2010 showed that low-dose azacitidine, 32 milligram per meter square daily for 5 days, was quite promising, and that was the most effective dose in AML and MDS. And the UK phase 1/2 RICASA trial, using similar dose regimen followed by DLI if mixed chimerism, showed that patients who mounted a CD8 positive T-cell response to tumor antigen had a significantly better relapse-free survival compared to patients who did not have a CD8 response post-azacitidine. And this is an AUB study published by Dr. Sheikh in 2017, using low-dose Vidaza as preventive therapy for relapse of AML and MDS following allotransplant. So 18 high-risk patients were included. 5% of 28% of them had residual active disease, and 11% had refractory acute leukemia. In terms of disease risk index, it was high or very high in 50% of the patient. So they received this prophylactic low dose azacitidine for a median of 6 cycles. And you can see the 1-year disease-free survival and overall survival were quite promising at 63% and 70% in these very high-risk patients. Another very promising approach for prophylactic use of targeted therapy after transplant to prevent relapse was the use of sorafenib in FLT3 ITD AML. So this is the pioneer study, was published by Dr. Ahmed Antar from AUB in 2015 using sorafenib in 6 patients. Then we performed a multicentric study between AUBMC Saint Antoine and the King Faisal in Riyadh. And you can see that prophylactic sorafenib post-allo resulted in a 2-year leukemia-free survival of 75%, 2-year overall survival of 83%. And similar results were seen in the EBMT registry, and you can see in a pair match analysis that post-transplant sorafenib maintenance significantly improved overall survival as compared to no sorafenib maintenance and FLT3 ITD AML. And actually the German performed a randomized trial and found similar results, 2-year PFS, 85 versus 53% in favor of sorafenib. And you can see a very large number now of studies, including, for example, Xuan et al., a Chinese randomized trial on more than 200 patients showing a major improvement in leukemia-free survival and overall survival with the use of post-transplant sorafenib. And we have a nice science behind that was published in Nature Medicine, showing that actually sorafenib promotes graft versus leukemia activity in mice and human through IL-15 production in FLT3 ITD mutant leukemic cells. And this has resulted in a clinical practice recommendation within the EBMT Acute Leukemia Working Party that we published last year in Hematologica, recommending post-transplant maintenance therapy with a FLT3 inhibitor for patients who underwent allotransplant for FLT3 ITD AML. And in the absence of an appropriate clinical trial, sorafenib could be considered as the preferred option. So this is my last slide, in my last data slide. So in summary and perspective, allotransplant is here to stay. It is the only curative therapy for many malignant and non-malignant diseases. And with the development of haploidentical transplant and post-transplant cyclophosphamide, which by the way is currently also applied in outside the haplo setting, even in match unrelated donor. This has resulted in almost every patient has a donor. Stem cell transplant is no longer the last step of a treatment plan, but now we have this emerging concept of a comprehensive treatment package incorporating new drugs and novel cellular and immune therapy, potentially combining CAR T cells before or after allotransplant. And once tumor burden is reduced, adoptive cellular immunotherapy will achieve MRD while restoring host anti-tumor activity. And so with this concept of prophylactic post-transplant maintenance therapy, particularly in AML. So 2 years ago at AUB, we celebrated 1,000 transplant, and many of you were actually invited to this activity, and we hope to have a bigger event when we reach the 2,000 transplant, and thank you for your attention.
We'll take now some questions from Dr. Ghazal.
Thank you, Dr. Ali, for this nice resume of BMT. Nice to see you, I guess, even though not face-to-face.
Thank you, Hassan.
I have one question on FLT3 patients. So we know not all FLT3 are the same. So when do you decide to watch a FLT3 if they are in remission, especially if they have the NPM1 associated with the FLT3?
Yes. So this is actually an important question. So patients, overall patient with FLT3 ITD-AML have a much poorer prognosis compared to patient with FLT3 wild type. However, within the FLT3 ITD, those who have an NPM1 mutation have a better outcome than the others, and those who have a low allelic ratio of FLT3 ITD have also a better outcome compared to those who have a high allelic ratio. And this has led the European Leukemia Net. So if you have FLT3 ITD low allelic ratio, together with NPM1 mutation, and together with achievement of minimal residual disease negativity after induction consolidation, if you have these three together, these patients can be considered low risk and are not transplant candidate anymore. This is the attitude of the European Leukemia Net. Not everybody shares this attitude for this category of patient, because many consider that allotransplant will make them even better. But this is a minority, by the way, of FLT3 ITD patient. So for the overwhelming majority of FLT3 ITD patients, even if they have NPM1 mutation, but without this low allelic ratio, and those with NPM1 wild type, allotransplant is the standard of care and recommended actually for everybody who has a donor and who is fit for transplant. And post-transplant sorafenib has transformed the prognosis of these patients, like tyrosine kinase inhibitor has transformed the prognosis of Philadelphia positive ALL. So in the past, we used to say that Philadelphia positive ALL is a poor risk ALL. Now, if you have a 60-year-old patient, you hope that the patient has Philadelphia positive ALL because they will have the best outcome. And now it is the same with FLT3 ITD AML. Doing allotransplant followed by post-transplant sorafenib has transformed this disease from a poor risk to a favorable risk disease with outcomes better than most other AMLs.
And do you think the second generation, or so-called second generation anti-FLT3, like gilteritinib, more potent and maybe perhaps bringing them earlier in the first line would be helpful? Do you have any? I know in Lebanon probably we don't have it yet.
This is a very important question, and unfortunately the ongoing randomized trial will not answer this question because gilteritinib and other second generation FLT3 ITD are more selective, more potent, and also more selective than sorafenib. So definitely their effect on inhibiting FLT3 within the leukemic cells is more powerful. And by the way, they are more effective if you have a relapse of AML. Gilteritinib is now FDA approved for management of relapsed AML with FLT3 ITD. However, in the post-transplant setting, we have seen that sorafenib, being a multi-kinase inhibitor, is acting both on the leukemic clone and also on the immune system, triggering a graft versus leukemia effect. So we're not sure because currently we have the BMT-CTN randomized trial randomizing post-transplant maintenance, gilteritinib versus placebo. We are awaiting the result of this trial, but even if this trial is positive, then it is very difficult to compare across trial if post-transplant gilteritinib is better, similar, or less good than post-transplant sorafenib. The head-to-head comparison is unfortunately unlikely to be done.
And one question on age group. You mentioned, the inclusion of patient for allo transplant has always been hampered by age as well. What's your view on reduced intensity transplant especially for the elderly population?
So I will give you our oldest surviving patient at AUB, a 78-year-old patient, ex-AUB professor, a retiree, who had a relapsed AML with that was refractory with persistence of skin lesions. So outcome was dismal if we don't do anything, and we performed a haploidentical transplant from his son using a non-myeloablative, even lower than the reduced intensity conditioning, fludarabine, low-dose TBI, and low-dose cyclophosphamide with post-transplant cyclophosphamide. So the patient achieved complete remission. Now the patient is 82, and 4 years later, and having a normal life. And he has many properties in the Hamra district at AUB, and he's going at the beginning of every month to collect the rent.
So that's what we call the art of oncology, right? All right.
So I wouldn't say this is our standard to transplant patients above 75, but I would say up to the age of 70, there is no barrier, except if the patient has another comorbidity. So up to the age of 70, allogeneic transplant in the absence of another major comorbidity can be considered as standard of care.
And last comment, do you guys feeling threatened by the CAR-T, or do you see it more complementary to the allo transplant?
Not at all. Actually, CAR-T, as Dr. Moti mentioned, is performed by transplanters. We're working hard to implement CAR-T cell therapy at AUB. Our aim was to start in March 2020, and this did not happen. Mostly because of the COVID, and more recently because also of some financial issues. We're almost ready to start, but the COVID did not help. These are complementary techniques. I mean, CAR-T cell is doing things that we cannot do with allotransplant. So for example, multiple myeloma patients are not candidates for transplant. Allogenic transplant for diffuse large B-cell lymphoma is rarely performed, and results of allogenic transplant in relapsed refractory ALL are quite poor. So, and these are the major areas for CAR-T cells. So definitely these are complementary. And actually, I wouldn't be surprised to see very soon data on the use of CAR-T cell therapy before allotransplant as bridge to allotransplant or for relapse after allotransplant.
Okay. السلام عليكم. دكتور علي مرحبا. دكتور علي باشا from Saudi Arabia. Regarding a patient with CML accelerated or plastic crisis transplanted, underwent allogenic bone marrow transplant, which TKI you prefer to give after the transplant? Second generation, third generation, and how long you using?
So if you achieve MRD negativity, actually the most effective TKI in blast crisis CML is without hesitation ponatinib. Many of the blast crisis patients have T315I, and even outside T315I, many would be resistant to first and second line. The use of ponatinib has been has faced major challenges and problems due to cardiovascular toxicity of ponatinib. But now we have learned a lot that this cardiovascular toxicity, thrombotic events, etc., are dose dependent, and that the initially recommended dose of 45 milligram of ponatinib daily is quite toxic, and that the dose of 15 milligram daily is quite efficacious, particularly in MRD negative patients. And with this dose, you have very low rate of cardiovascular events. So to answer your question, if you have a blast crisis patient who underwent allotransplant and post-transplant, the patient is in complete remission, MRD negative, I would give ponatinib 15 milligram daily. With optimization of the cardiovascular risk factor, make sure the hypertension, cholesterol, triglyceride, diabetes are well controlled.
Okay, thank you.
Thank you very much, Monsieur Bazarbashi, sir, for this presentation, very impressive and very clear. I would like to ask you two questions. One old-fashioned question. The first one is there any place for cord blood transplants? Because many families are continuing to preserve cord blood for their children. So for adult patients, is there any place for cord blood? And my second question is, why in the Middle East we don't have an international, we are not joining the international registry for donor? Is this a lack of awareness about bone marrow transplantation and indications?
Thank you, KM. Actually, these are not old questions. These are very relevant and important questions. So cord blood is a very effective modality. You can see here the transplant activity. The cord blood activity is remains quite limited, mostly because of two reasons. The first reason is that to do the cord blood, the amount of stem cells is enough only for 40 kilo of patient weight at maximum. So, and the majority of adult, so this is more applicable to pediatric patients. The majority of our adult patients are more than 50, and already 1 unit of cord blood is quite expensive, very expensive. So when you use 2 units for the adults, which has been used actually, then the cost becomes prohibitive for most of the centers in our region, but not only in our region, even in Europe. And since the results are not better, even if they are similar to haplotransplant, if you don't have a matched sibling or a matched unrelated donor, the haplodonor is readily available and much cheaper. So this is why transplant activity in cord blood is decreasing. So for your second question regarding our representation in transplant registry, I think that this is not only lack of awareness, but maybe something cultural. We go to donate blood, and it's the same for platelet donations. In Lebanon, and I'm sure it is the same in many other countries, people go to donate platelets if they have a family member, a friend, a neighbor, somebody they know who's in need of platelets. But we don't have the same people like they do in France and in Germany and Europe that go and donate their platelets anonymously without knowing, without having somebody in need of platelet, and without knowing to whom these platelets would go. So I think it's the same for transplant. Many people in our region will donate their stem cells to a friend, to a family member, but very few will go and say, I'm a candidate. If you have somebody in need anywhere in the world, I would donate. Like they do in Germany, they have more than 1 million potential donor for stem cells. So if you are a German in need of a bone marrow transplant, your likelihood of finding a donor in the registry is more than 90%. German genes are very well represented. If you are from the Middle East, 10-15% at best.
They are giving for all Europe also.
Yeah, exactly.
Okay, thank you very much. Thank you, and hope to see you soon in UAE. Thank you.
It would be my pleasure.
Thank you.
Thank you.
So we'll close this session on hematological malignancies, and I think we have a break now. Sorry.
Again, Shamsi and the organizing committee for this successful meeting, and I would like also to thank Bayer for the invitation to this symposium entitled Latest Updates in the Treatment of Non-Metastatic Castration-Resistant Prostate Cancer. Our speaker is Dr. Hassan Jafar. Dr. Hassan Jafar is known to all of us. He is known also in the region, very active in the field of research. He graduated from the American University of Beirut in 2000, joined Tawam Hospital for 18 years until year 2018. Then he moved to Sheikh Khalifa Specialty Hospital in Ras Al Khaimah, where he's a consultant medical oncologist, and again, very, very active. He's a member of many oncology societies, and he's going to talk again, as I already mentioned, about the latest updates in the management of non-metastatic castration-resistant prostate cancer. Dr. Jafar, the floor is yours.
Thank you, Mr. Chairman, Dr. Dia, for this kind introduction. Good afternoon, dear all. Thank you, Bayer, for giving me that opportunity. So my presentation for today is to share with you. Can I have the presentation? So what are the current standard in non-metastatic castrated-resistant prostate cancer? As you all know that the definition of castrated-resistant prostate cancer are similar in all the guidelines, including the NCCN guidelines. And they define that those prostate cancer who progress clinically, radiologically, or biochemically, despite that the castrated testosterone level less than 50 nanogram per deciliter. So if we follow that definition, and when we have a patient with high PSA, we do the conventional study to evaluate whether they have metastasis or not. We end with two different groups. The first group, if we see radiological metastasis, this is defined as metastatic castrated-resistant prostate cancer, and we know that we have a bunch of drugs and options that we can use, and all these drugs has been approved based on improvement of overall survival. But the main challenge was, for a long time, that if we don't see any metastasis in these conventional study, the bone scan and the CT scan, then we were following the watch and see strategy. And this is very stressful to the patient, following and monitoring his PSA going up, and also for the physician to convince that patient that we have to continue without any intervention. And sometimes the patient come and do these tests even on every 2 weeks or every month, and we don't have anything to offer to those patients. Now, what happened with this different group? We know that they are not doing that well, and we know the time for metastasis for those patients is in the range of 2 to 2.5 years, and they survive between 3 to 5 years for those groups. And even if we want within this group to select those patients who have higher risk, they found that PSA doubling time, if you take it less than 10 to 8 months, those patients, the time to have metastasis and to survive, they are very short within this group of patients. And this has been also confirmed in a clinical study, retrospective study, more than 440 patients with the prostate cancer. They were followed and they have non-metastatic castrated resistant prostate cancer. And they found that the amber color and the green color, if the doubling time of PSA less than 3 months or less than 9 months, their time to metastasis or their survival for the prostate cancer or survival from any reason, it's dropped significantly compared with the other cohort of patients. And this is why it is very important to focus on those groups to give a better management to improve their outcome. So there was two strategies to overcome this dilemma, either by developing a more sophisticated test in order to pick up those metastases, in order to change the definition into metastatic castrated resistant prostate cancer. And we know that there are a lot of tests which has been used, whether it's a choline or a total body MRI, and recently the PSMA, it is more approved in even different indication in order to pick up those subclinical metastases in order to change the definition to allow physician to start the active treatment. The other option is just to have a treatment for those patients even without the presence of a clinical metastasis. And to find a primary endpoint which is important and relevant to this disease, they found that metastasis-free survival was probably the best primary endpoint, because first, you can get this result early enough, and also it's not contaminated with the subsequent treatment beyond progression, and it is a very strong surrogate to the overall survival. So this has been adopted by most of the clinical trials conducted in this group of patients. And we know that metastases impact significantly on the mortality of those patients, morbidity of those patients, the medical resources, and the symptomatic of progression. So it was a very important endpoint. And we know that for a long time, this has been a study with different agents. None of those agents showed an improvement in the outcome of those patients till recently, when we had 3 clinical trials very close to each other. They include almost same inclusion criteria. So patients with non-metastatic castrated-resistant prostate cancer defined with the conventional study, that CT scan and bone scan, and patients who have 2 centimeters pelvic lymph node or less, they included in this study. So they even included those patients who have metastasis. We know that the PSA elevation is always associated with a recurrence or relapse of disease. So whether you see it or not, this is the main issue. And those patients have doubling time of 10 or less months, and they have a good ECOG performance status. 3 trials, the Aramis, the Spartan, and the Prosper, they include 3 different new anti-androgen agents, darolutamide, apalutamide, and enzalutamide. The population in each study ranging from 1,200 to 1,500. The same primary endpoint as we mentioned, metastatic-free survival, and almost similar secondary endpoint for all these 3 clinical trials. If we see the first 2 trials, the Prosper and the Spartan, you see that introducing these agents, whether enzalutamide or apalutamide, improve significantly the metastatic-free survival for those patients, or almost triple the time to have metastasis if you use this agent compared with the placebo. And this was highly statistically significant. If we take the overall survival, again, there was a very significant improvement in the survival if we use enzalutamide or apalutamide for those patients. So there was a significant improvement in the primary endpoint as well as the secondary endpoint, which is the overall survival. But we know that also structurally, that darolutamide is a little bit different than the structure of enzalutamide and apalutamide. This may implement on a different efficacy or different toxicity, which we will see in the clinical trials, but at least this structure make the drug do not penetrate the blood-brain barrier. And if we see that in a study, just trying to measure the CNS penetration of that drug, after 8 hours of delivering the dose, they found that the concentration of darolutamide is almost 50% less than enzalutamide and around 30% less than the concentration of apalutamide. So the penetration to the CNS is by far much less than the previous 2 drugs, which can implement on the toxicity and the side effect of that drug when it's used. This is the schema of the trial. So those patients, they have, as I mentioned, the same inclusion criteria. They randomized 2-to-1 into darolutamide versus a placebo with the same primary endpoint as we mentioned and the secondary endpoint. The only differences between these 2 studies, the previous 2 studies, that those with seizures were not excluded, and this is mainly based on the preclinical data that the penetration to the CNS is negligible in this group of patients. Again, the primary endpoint, which is metastatic-free survival, were met, and it was significant. And if we see the subgroup analysis for those patients, almost all subgroup analyses were favoring using darolutamide versus placebo in those patients with non-metastatic castrated-resistant prostate cancer. Also, there are many physicians mentioned that probably the high category of patient, they may be less than 6 months rather than those who are less than 10 months. And here in this graph, if you split those patients, those with less than 6 months, they have the same magnitude of benefit for those who have the doubling time between 6 to 10 months. Although those with 10 to 6 months, they have a more favorable outcome, but the magnitude of benefit of introducing darolutamide versus the placebo were maintained for those cohorts. If we see the overall survival, although it's not mature yet there, but it is matching with what we see in the two previous studies, a very significant hazard ratio and p-value with favoring using the darolutamide in those patients. And this is very reassuring because if you see that post-progression use of crossover to darolutamide around 30%. So although 30% of those patients in the placebo arm cross over to darolutamide upon progression, the overall survival was maintained and it was a significant improvement. All other points like time to progression, also time to subsequent cytotoxic agents, or first symptomatic selected or skeletal events, or were all favoring using darolutamide and delaying all these symptoms. Now, a very important point, we know that those patients, they don't have a clinical metastatic disease and they don't have any symptoms from their disease. So adding any drug that can impact their quality of life, it may make a major issue for those. And if you see the use of darolutamide in the grade 3 and 4 toxicity, you don't see beyond the 1 digit. And if you match it with the placebo, you see almost there are no really differences between the two arms, which is very reassuring for those patients. Now, usually we don't do cross comparison between studies, and I'm not going to do this, but because of the inclusion and the primary endpoint and the secondary endpoint, just to be reassured that probably this agent making a big difference for those patients. So the progression-free the metastatic free survival or the time for metastasis is almost similar with the three drugs. You see it is like identical that you are using the same agent. So that from efficacy point of view, there are no really difference. From the overall survival, again, you see the separation of the graph. It's almost similar between these three arms. So there was an improvement in delaying metastasis and also impact on the overall survival of those patients. Now, if you see the quality of life for the Aramis trial, again, there is no differences between those who are taking placebo versus those who have taken darolutamide. So there was no impact or detrimental effect of using that drug. In fact, there are certain symptoms from progression of disease, and we know darolutamide delayed these symptoms. There was an favoring those patients who are using darolutamide in reducing the bowel symptoms and the urinary symptoms because of delaying the progression of that disease. If we take the toxicity, and I'm not trying to compare the toxicity in different arms, but just to compare it with the placebo within each arm. So we see that the darolutamide compared with the placebo is almost similar, and we have some numerical differences with the other agent compared with the placebo, which also favoring that the toxicity from this agent is very minimal, and if you take it for darolutamide is even much less. And even for those with the CNS related penetration, we see the fatigue, falls, fractures, or almost no differences between the placebo and the darolutamide arm. Even the dose delivery or discontinuation of the treatment, there was no difference. So most of those patients, they delivered the full dose of the treatment for those patients. That means that the tolerability was very significant. Another important point when we use these drugs, we know that most of our patients, they have many comorbidities, diabetes, hypertension, cardiac issues, and we know that the drug-to-drug interaction, many times we see these issues and we don't take it in consideration, but this can increase the toxicity and side effect if we don't take it in consideration. And we know that with darolutamide, we have much less interaction with other drugs. And probably when we prescribe this medication, we have to take it in consideration what the patients are ongoing treatment and to see if there is any interaction with the drug we are prescribing or not. In summary, this is the NCCN guidelines, and this is the last version of the NCCN. We see that those patients with conventional evaluation, that mean CT scan and bone scan. So if we don't see any metastasis and we check that the testosterone level in castrated level, we look in the PSA doubling time, and if those patients are high risk, that means it is less than 10 months, we know that apalutamide, darolutamide, and enzalutamide are category 1 to prescribe for those patients. This will impact in delaying the metastasis and improving overall survival. Watch and see probably strategy is not acceptable for those patients, and probably we have to treat them. We take in consideration the quality of life, the toxicity of the treatment, and the interaction of that drug. And by this, I finish my presentation, and thank you very much for listening.
Thank you. Thank you, Dr. Jaffer, for this comprehensive review. Great presentation, and I hope this will be interactive. We are waiting for some questions from the audience, if there are any.
Thank you, Hassan.
Thank you, Hassan. You want difficult question or easy?
Whatever you like.
So, one criticism of treating this group of patients is that, are we really treating micrometastatic disease? And then with the approval, or recently more use of PSMA scanning, it's expected that this group of patients are going to shrink even more. What's your view on that?
This is very good question, and I think this is very valid in our practice. And we are moving, I think, forward for these in order to tailor the treatment. But we know with this setting of patients, whether you do conventional study or you do the PSMA, we have options for both patients. So if I don't have the PSMA in my hospital, or if it is more costly, it is not I'm doing a suboptimal management for those patients. Conventional study with level 1 evidence of treatment. Now, in future, probably if I see that if there is a single metastasis and this can be correlated with a better outcome, if it shows a survival advantage, then probably the practice or the guidelines will change. But currently, for those setting of patient, if I don't see, if I have available PSMA and it is the same cost, probably I will do it for every patient. But if I don't have the PSMA, or if it is more expensive and this patient self-pay, still the standard of care is the conventional study, and it did not show that the PSMA at this setting, it's correlate with overall survival. If we will have this study, probably everybody will move to PSMA. And we know that within this study, some of those patients, they did subsequently a PSMA scan, and they found that there is some metastasis there, and they do benefit from that treatment similarly to the others. Because as you mentioned, most of those patients, they have PSMA. We know that there is a relapse somewhere. So whether you know it or you don't know it, I think it's the same. And probably the darolutamide will be approved later on in the castrated resistant, so it will not be a big difference between these definitions.
Exactly. The other point in all these trials, did they comment on the placebo arm and how soon was treatment initiated after detection of METs? Because that's an important distinction when you are comparing these two arms. Did all of them receive treatment in a timely fashion? Do you know?
It is sometimes very hard to define this, but again, with the presence of overall survival and the presence of similar data in the 3 clinical trials, this is a very reassuring point. Then probably you don't have to, if I want to have one study that showed this, probably I have to criticize it because of the timing. But to have 3 clinical studies showing similar, and this is why I show it, because this is a real improvement in the time for metastasis and overall survival. Otherwise, you will not have this duplication in 3 clinical trials.
And then finally, we are victims of old habits. So how do you convince a physician who have been using the other 2 agents for a while, especially enzalutamide? how do you convince them to change their practice? To
I'm not convincing. I think the 3 drugs is effective, but again, I have to select these drugs according to the cost, to the drug-to-drug interaction, and to the symptoms they have. So again, the clinical studies, it showed that a very minimal toxicity or side effect, it is there. But again, the quality of life of all these 3 drugs are good. But I have more favorable data. There is no head-to-head comparison, but still with darolutamide, I have a very minimal side effect, and those patients, they don't have any symptoms. So if I don't have any differences between the cost of this, I prefer to take the least toxic agents. Okay.
Thank you very much, Dr. Hassan Jaffer. I think Dr. Hassan has asked all the questions already. I just have a few comments. You think these definitions of categorizing prostate cancer into different categories are artificial? And because, as we know, now in the future you will have ctDNA coming and many other cancer sites as well. So as long as a drug which is delaying the disease progression and improving outcome, and we know all the drugs are very similar, and these drugs work in different settings as well.
I cannot hear it well. Can you repeat the question?
So I was just saying that these classifications of prostate cancer into non-metastatic castrate-refractory and metastatic castrate-refractory, they are sort of artificial aged classifications, because now we know that you actually have metastatic disease that you can't see on the imaging that is available on that time when these trials were designed. And we know all these drugs works very similarly. So all we are doing is we are treating these patients early for me, and you're delaying the progression. So the choice is really, if you're not making them any worse by giving a drug and making them live longer, I think that is a win-win situation for everybody. That's how I look at it, basically.
Okay, thank you, Dr. Jaffer. Any other questions from the audience? I cannot see anything from my side.
Sorry, Dr. Dia, just to answer that question, that's it. I totally agree with you that probably doubling time of PSMA, this is a very good marker whether they have overt metastasis or not. But again, clinically, the physician as well as the patient, they need to know what are the site of metastasis, and this is why we do this radiologically, and sometimes for a certain period of time, we depend only on PSMA. Now we are depending on more on sophisticated scans. But I think if this drug approved in both settings, this will not make any big difference. Thank you.
Okay, thank you, Dr. Jaffer. Just one question from my side. In fact, 2 questions, quick questions. Number 1, we have now 3 medications, enzalutamide, apalutamide, and darolutamide, all approved in the same indication. I think Dr. Hassan Ghazal alluded to this question before. So how do you make your choice between all 3? This is number 1. And number 2, all these studies related to the mentioned drugs included patients with PSA doubling time less than 10. So what do you do in patients who are having PSA doubling time more than 10, for example?
The second question is a difficult question to answer, but again, it depends what are the cutoff of that. It depends on the time for relapse. Definitively, that those patients, they need certain kind of treatment, but without a study, probably we cannot give them that treatment unless the patient know the consequences of this. We don't know whether there is an improvement in survival or not for those slowly growing tumors. So we need to have data in order to extend that cutoff. But definitively, it's a question, there is no difference from 10 or 11 or 12. But if it is much higher, then I will be very reluctant to give those patients that. But how to select, I think in the castrated, non-metastatic castrated resistant, I think the cost, as you all know, cost is an issue. The toxicity of the drug and the safety of the drug are very important endpoint. And I think all these 3 endpoints is in darolutamide. This does not mean that we cannot use other drug, but I think all these 3 are favoring currently the use of darolutamide in this setting.
Okay, thank you, Dr. Jaffer. I think time is over. We are late in the meeting, so I would like to conclude this session and give the mic over to Dr. Ahmed Al-Shamsi. I think there is a session about the abstract awards. Thank you, Dr. Jafar, and thanks for everybody. Thanks, Dr. Hamid.
Assalamu alaikum, and thank you so much for being here today. Today, or actually now, we're going to move to the top 3 abstracts winner presentations. We received more than 30 abstracts from different parts of the world, and we shortlisted them to 3 top abstracts. At the same time, we'd like to encourage everybody to go to virtual hall to review the abstract which has been submitted. This year, the quality of the abstract has much improved, to be honest with you, and we had a little bit of difficulties to select the top 3 abstracts. So I would like to thank all the participants and all the authors for their trust and submission of their abstract to the selection committee. Dr. Saeed and Dr. Saeed and also Dr. Khalid all were part of the committee to select the abstract. So I would like to thank them for their time and expertise and spending time to review all these abstracts. And Dr. Khalid, he's actually joining us virtually from UK. So I will start now with the first presentation. The presentation, actually what's going to happen is we're going to present the 3 abstracts, and after that we will decide between the committee who are the winners of the first, second, and third place. So next slide, please. So we do have 3 abstracts from Lebanon, from Ireland, and also from Egypt. We'll start alphabetically with Dr. Shahada, Lodi Shahada. She is a research fellow at the Division of Hematology and Oncology at the AUB, and her abstract titled COVID-19 Vaccination Immune Response in Patients with Solid Organ and Hematological Malignancies in Lebanon. Dr. Shahada, the mic is yours.
Good day, everyone. My name is Lodi Shahade, and I will be presenting this study conducted at the American University of Beirut Medical Center on COVID-19 vaccination immune response in patients with solid organ and hematologic malignancies in Lebanon. Patients with solid organ and hematologic malignancies are at a higher risk of COVID complication and mortality compared to the general population. Although patients on active anti-cancer therapy were excluded from the initial COVID-19 vaccine trials, they were prioritized to receive the vaccines as these are likely to be protective in immunocompromised individuals. Emerging data suggest that patients with cancer may have a reduced immune response to vaccination, which puts them at a higher risk of acquiring COVID-19 infection. This table summarizes seroconversion rates from different studies in the literature after 2 vaccine doses. As you can notice, patients with a hematologic malignancy tend to have lower seroconversion rates compared to patients with solid organ tumors, and patients with solid cancers tend to have lower seroconversion rates compared to healthy controls. Also note that all of these studies were conducted in high-income countries. Our study aims to determine the immune response to COVID-19 vaccination in patients with cancer at a tertiary care center in Lebanon. We included patients diagnosed with a solid organ or hematologic malignancy who were receiving active systemic treatment at the time of their planned vaccination at AUBMC. Patients underwent testing for COVID IgG using the Abbott Diagnostic SARS-CoV IgG2 Quant assay. 84 patients were recruited, 91.7% had a solid organ tumor, and 8.3% had a hematologic malignancy. The majority of our patients were receiving chemotherapy, whether alone or in combination with other treatments, or immunotherapy. 8 out of 15 patients who were tested following 1 vaccine dose had negative IgG titers, making the seroconversion rate 47%. 1 out of the 8 patients who tested negative had a previous COVID-19 infection. And 6 out of these 8 patients were tested again after 2 doses, and 1 of them remained negative. 7 out of 69 patients who were tested following 2 vaccine doses had negative IgG titers, thus making the seroconversion rate 90% after 2 doses. None of the patients who tested negative had a previous COVID-19 infection. The patients with negative tests were on the following treatments at the time of their vaccination. 2 were receiving chemotherapy, 1 patient was on chemotherapy and anti-VEGF, 1 patient on anti-VEGF, 2 were on anti-CD20 therapy, and 1 on bispecific T-cell engager. One of the patients who tested negative and who was on anti-CD20 therapy developed COVID-19 infection 24 days after completing vaccination and required hospitalization. So to conclude, seroconversion rates in our studies were similar to those reported in the literature, but a bigger sample size is needed to infer correlations with the type of treatment, malignancy, and vaccine. These results highlight the importance of maintaining strict precautionary measures against COVID-19 in patients on immunosuppressive treatment, particularly in low-income settings where vaccine rollout is slow and access to healthcare is difficult. Longitudinal studies are needed to establish the durability of the immune response and optimal timing for vaccination in patients with cancer. A 3rd vaccine dose was recently approved by the FDA for immunocompromised individuals, but further data is needed on long-term response monitoring in patients with cancer. Thank you, and these are my references.
Thank you, Doctor, and I would like to open the floor for any brief questions. Yeah, Dr. Ghaza, yeah, Dr. Ahmed. Mic is coming.
Sorry, patient with an anti-CD20 rituximab, we know that the response for the vaccination not so high. So for this patient, do you a recommendation to give the vaccination or not? This is the question. If yes, which is the best time to give the vaccination for these people who are in active anti-CD20 treatment?
Thank you for your question. So patients on anti-CD20 therapy have blunted immune response to vaccination because of the B-cell depleting effect of the anti-CD20 therapy. There is not enough data to suggest the optimal timing of vaccination for patients on CD20 therapy. However, as per expert opinion, the patients should be vaccinated, but following the end of their treatment by at least 6 months, because the effect of anti-CD20 can last up to 6 months and even sometimes up to 12 months.
So similar, I think part of the question was answered, but I was going to say in the literature, we already have some data on hematologic versus solid tumor, and that the patient with hematologic malignancy are really the more vulnerable ones not to have a response. In year 7, I guess the number is small, but did you look how many were hematologic, how many were solid?
So in the patients who tested negative after 2 doses, 3 of them were hematologic patients, and 4 of them were solid cancer patients. The solid cancer patients had CSF, GI, and GU tumors.
Thank you.
Excellent. Thank you so much, Doctor. Please stay with us, and we'll move now to the second presentation by Dr. Maha Ibrahim Sindi. Dr. Maha actually was one of the winners of last year's abstract competition. So thank you, Dr. Maha, for submitting again your abstract. I believe you submitted 3 abstracts this year, and the one selected was adjuvant therapy and long-term survival in older women with early breast cancer. Thank you, Dr. Maha, and the mic is yours.
Good afternoon and good morning from Dublin. Thank you, Professor Hamid. Thanks to the organizing committee. It's an absolute pleasure to be with you this year again to present my abstract. I'm a medical oncologist and a clinical fellow in breast oncology. And my abstract is entitled Adjuvant Therapy and Long-Term Survival in Older Women with Early Breast Cancer, a Single Institution Experience. I have no disclosures. We know that breast cancer incidence increases with age. Around 40% of breast cancer occur in women aged 65 and older, and 20% in women above the age of 75. Improvement in screening and advances in curative intent therapies have led to improvement in breast cancer mortality rates over time. However, we're not seeing this being translated in older patients. Older patients have similar benefits from curative intent therapies as our younger patients. Yet, under-treatment of older adults is a likely factor, contributing to the age-related disparity in breast cancer prognosis. There is limited guidance in treatment of older patients as few clinical trials have included patients above the age of 65. The management of older patients with early breast cancer can be challenging, and these patients are both at risk of overtreatment given the high risk of toxicity due to treatment and competing causes of mortality, and undertreatment due to age-based restrictions. Our objective was to assess the survival outcome, overall survival, and recurrence-free survival of elderly patients with early-stage breast cancer in our institution. So we collected data of 512 patients with early-stage breast cancer, stage 1 to 3, who underwent curative surgery from 2010 to 2018. Data was extracted from electronic patient recording system. Tumor subtype, adjuvant therapy, and survival outcome were analyzed. The Kaplan-Meier method was used for comparison of survival rates by log rank test and Cox regression model to examine the effect of the different variables. We use descriptive statistics to present the data. You can see on the graph on your left-hand side the baseline characteristics of the patient. Among 512 elderly patients with invasive breast cancer, the median age of diagnosis was 77. You can see that the majority, approximately 60% of patients underwent breast surgery and 40% did not. Of them, 45% underwent modified radical mastectomy and 55% underwent wide local excision. Half of the patients underwent some kind of nodal procedure, with the majority having a sentinel lymph node biopsy. The most common subtype was ER-positive, HER2-negative breast cancer, and 91% of patients received adjuvant therapy, mainly in the form of hormonal therapy, and a very few patients, 20% approximately, received chemotherapy, and 4.1% received monoclonal antibody. Half of the patients received adjuvant radiotherapy, and half of them did not. In a multivariate model, age was identified as an independent risk factor for overall survival, but not recurrence-free survival, with a p-value of 0.005 and 0.24 respectively. Tumor subtype and adjuvant therapy did not impact the overall survival. The median overall survival for patients who did not relapse was 2 years. But as you can see on the graph on your right-hand side, the Kaplan-Meier curve show clear separation in patients who are above the age of 80 in comparison to patients aged 79 and less. However, when we look at the median follow-up, after a median follow-up of 6 years, the recurrence-free survival was 7.5 years for all patients. And we don't see a difference in terms of recurrence-free survival when we look at the age category. We looked at the effect of adjuvant therapy according to tumor subtype. Although adjuvant therapy did not affect the overall survival and recurrence-free survival, when we looked at the tumor subtype, we noticed that the adjuvant therapy was statistically significant impact or factor in recurrence-free survival, with a p-value of 0.046, where it did not affect the overall survival, probably due to the presence of competing risk factors. In conclusion, this was a single institution retrospective study of elderly women with breast cancer. Overall survival was significantly worse in patients above the age of 80. Age was not found to affect recurrence-free survival, but impacted overall survival. And as you can see, this is probably due to the effect of competing risk factors. Adjuvant therapy was not found to affect overall survival or recurrence-free survival for the whole cohort. However, when stratified by tumor subtype, again, the majority being ER-positive, HER2-negative breast cancer, adjuvant therapy impacted recurrence-free survival. Our study was limited by its retrospective nature and lack of prospective follow-up. Further studies are needed to establish the optimal treatment for elderly patients with breast cancer. We need, as oncologists, to emphasize the routine use of geriatric assessment to identify patients who would truly benefit from adjuvant therapy and patients who are going to be at risk of toxicity. And as the president of the SIOG committee said in the last meeting, we're all geriatric oncologists, but we just don't know it. Thank you.
Thank you so much, Doctor. And I'll open the floor for any questions. Dr. Saeed Hamad?
Yes,
Dr. Saeed.
Oh, you have, go ahead. Thank you very much. Just wanted to understand a bit more the methodology. So you had 500 patients. So what percentage of them were eligible for the adjuvant treatment, and how many actually got it? And did you then compare both groups? So I'm just trying to understand how did you come up with the results? So you had 500 patients. How many of them were eligible for adjuvant treatment, and how many then did receive it?
So 91% of patients received adjuvant therapy. And again, the majority of these patients were, obviously, this is a retrospective nature. So you can see those are highly, there is a high subjective bias in them. The majority received hormonal therapy. Only 4% received monoclonal antibody, like in the form of anti-HER2. We don't have follow-up in terms of who stopped treatment or not. So we know that those patients have started therapy, where we don't have any prospective data in terms of those patients actually end up stopping treatment.
Dr. Maya, thank you very much indeed for your very interesting research and nice presentation. Obviously, you know, these are 500 patients or so. They are different stages of disease, stage 1 to stage 3, and they have received different adjuvant treatments, perhaps including adjuvant chemotherapy, anti-HER2 therapy, and perhaps, you know, endocrine therapy as well. And you also need to bring into that, you know, statistics, the radiotherapy as well when you are thinking about event-free survival in these patients. What do you think that the co-founders of this type of research is?
What do I think is the, sorry?
The confounding factors, you know, what are the issues with this type of research that we are doing in terms of the retrospective trials?
Yeah, I mean, obviously the stage, the nodal effect of the patients, the performance status, those are all factors that, you know, those are confounding factors that will impact recurrence-free survival and overall survival. So obviously, I absolutely agree with you. Those are patients with different stage of breast cancer. We don't know their nodal status, you know, whether the patient was compliant to therapy or not, whether, you know, the presence of other risk factors and other competing effects is definitely have to be put into prospect.
Thank you.
So maybe I missed it. What are you comparing these, when you say overall survival and then RFS, what is the other side? Whom are you comparing it to historical numbers? And when you say there is no OS and no RF?
So I'm just, these are just based on our studies. We're not comparing them to any, cohort.
Yeah, but you are concluding there was no OS difference. Difference then what?
So in patients who received the adjuvant therapy, so the trial, I mean, our study looked at the effect of the adjuvant therapy in overall survival or their impact of recurrence-free survival. So whether the patients received, and again, you have to understand those are mostly patients who had hormone receptor positive. There are a high variable group of patients. So understand there is a lot of subjective variability in between patients.
Okay.
Thank you so much, Doctor. And now we're going to move to the last presentation or abstract. By Dr. Roda Hamid, who's a clinical oncology consultant at the International Medical Center. And the title of her presentation is Predictive and Prognostic Impact of Tumor Infiltrating Lymphocytes CD88 and CD4 in breast cancer patient treated with a new adjuvant chemotherapy. Dr. Roda, the mic is yours.
Thank you so much. I'm Dr. Radwa Hamid, clinical oncology consultant at the International Medical Center. I will present you our data about the predictive and prognostic impact of tumor-infiltrating lymphocyte CD4 and CD8 type in locally advanced breast cancer receiving neoadjuvant chemotherapy. Sorry. As we know, breast cancer is a heterogeneous disease with a different molecular subtype. Historically, breast cancer wasn't thought to be immunologically active when compared with other tumors like melanoma and lung cancer. But recent evidence emerged that the presence of tumor-infiltrating lymphocytes in breast cancer can predict the response to neoadjuvant chemotherapy and also improve prognosis. Tumor-infiltrating lymphocytes are composed of a variety of immune cell subsets which affect tumor prognosis. About 70% of TIL found are T cell type, especially CD4 and CD8 have a direct effect on prognosis and response to treatment. Why we did this study? What was the question of our study? Actually, we had 3 questions to be answered from our study. The first, is breast cancer immunogenic disease? This is true or false? The second is the correlation between the immunogenicity of breast cancer and the response to the neoadjuvant chemotherapy. The third question was about the amplitude of immunogenicity and the survival. Does it have any direct effect on survival? So, we prospectively evaluated the presence of TIL in a core biopsy taken from 50 female patients with locally advanced breast cancer before receiving their neoadjuvant chemotherapy. We assessed this TIL by immunohistochemistry, and it was defined as the percentage of tumor area that occupied by the CD4 and CD8 as a continuous variable with positivity at 1%. Then we classified our patients into 2 groups. The first group was high TIL infiltration, and the other group was low TIL infiltration with a cutoff point 30%. What was the answer of our questions? Regarding the immunogenicity, this chart shows that we had 44 patients were positive to CD4 versus only 6 patients were completely negative to CD4 expression. Also, we have 49 patients positive for the CD8 versus 1 patient with no expression. So we can say that breast cancer can be considered an immunogenic disease. The correlation between this immunogenicity and the response to the neoadjuvant chemotherapy. This table shows our classification of our patients in CD4 high and low and CD8 high and low also. We had about 16 patients with a complete pathological response. About 2/3 of these patients were found in CD4 high expression group. What about patients that have no response at all to the neoadjuvant chemotherapy in the form of this stationary disease, or patients who progressed while they were receiving the neoadjuvant chemotherapy? These patients were found in CD4 low expression group and CD8 low expression group. And this data were statistically significant, especially regarding the CD4 group. The effect of TIL on survival. At a median follow-up of 24 months, patients with high CD4 had a higher 2 years disease-free survival compared with patients with low TIL expression. And this is the Kaplan-Meier curve that shows the difference between high and low CD4 expression patients. Regarding the CD8, we had the same result as a patient with CD8 high expression group had a higher DFS compared with low expression group. What was our summary and recommendation? TIL have been associated with higher rate of PCR after neoadjuvant chemotherapy. The cutoff point of TIL level is still controversial. Tumor-infiltrating lymphocytes may help in identification of a group of patients with excellent prognosis. Thank you so much.
Yes, we'll take just one question for the sake of time from Dr. Saeed.
Thank you so much for this excellent research and presentation. Just a question, obviously, you know, this is looking at the tumor infiltrating lymphocyte and association in response to neoadjuvant chemotherapy. But I was wondering if your sample size allowed to look at the different histological subtypes, for instance, triple negative, HER2 positive, and so on and so forth.
Sorry, but I have a problem. Sound?
Sorry, I don't know if you heard me. I was wondering whether you have done any of these, subgroup analysis for different histological subtypes.
Yes, we have a different subgroup analysis for this patient, but actually our patients were only 15. So our data was mainly significant regarding the triple negative patients. But because they were a small number of patients, so we didn't like to express high presentation or high result regarding just only there was just 10 patients.
Okay. We will actually, hello? Yes, what we're gonna do is we're gonna move now to the next session, and then we're gonna deliberate and we'll come up with a decision in the next half an hour. So please bear with us. So I'm gonna introduce now Dr. Saeed Hamad to chair the next session. During this time and presentation, Dr. Tony will come back, and after that we'll announce the winner of the first, second, and third place. So Dr. Saeed Hamad, he's our colleague and friend. He's the head of the Medical Oncology Department at Dubai Hospital. And welcome, Dr. Saeed, and thank you for your support.
Thank you very much, Dr. Humaid. It's my pleasure now to introduce you to Dr. Tony Shuri. He's the director of the Lank Center of the GU at Dana Fabre, and he's also a professor of medicine at the Harvard Medical School. He's the co-leader of the Kidney Center program at both institutes. He also serves on the NCCN panel for kidney cancer. He has over 500 publications listed on the PubMed, and has led many phase 1 to phase 3 clinical trials in the GU. So he will be talking today about updates, recent updates in the GU cancers. Dr. Tony?
Hi, can you hear me?
Yes, we can hear you.
Perfect. And can you see the slides?
Yes, we can.
Perfect, perfect. Well, I want to thank you first for this kind invitation, especially thanking Dr. Al-Shamsi, who's doing a great job, really, with the Emirati Oncology Association here. And thank you all. And hopefully next year will be in person. So I wanted to give you some updates the past year from several meetings and publication about GU oncology and what is going on. This is just, my view, and I'm sure I'm going to miss some important topics. These are my disclosures, and I'm going to start by renal cell carcinoma. So finally, we do have an adjuvant study in renal cell after waiting for years and years. This is the first adjuvant immunotherapy study that is positive, that was presented at ASCO 2021 and was just published in the New England Journal of Medicine. And that study is by the name Keynote 564, where a patient with confirmed clear cell renal cell carcinoma without prior systemic therapy were randomized to pembrolizumab for a year or placebo, with the primary endpoint being investigator-assessed disease-free survival. And this is how we define patient at higher risk for recurrence. So the first category is patient with intermediate high risk. These patients have T3 disease, so stage 3, irrespective of grade, or they could have stage 2 disease, PT2 after surgery, but they have to have high grade, grade 4 or sarcomatoid. Then you have the high risk patient, T4 or N positive. Then one category of patient, which really is another totally unmet need. These are the patients with metastases that are surgically resected and rendered M1 NED within 1 year of nephrectomy. So the primary endpoint of the study, disease-free survival, was met with a hazard ratio of 0.68, corresponding to a 32% decrease in the risk of recurrence or deaths. For example, at 2 years, the DFS rate was 77.3% for pembrolizumab versus 68.1% for placebo. Now, the median follow-up remained extremely short. This is top-line analysis and first analysis from this study. And the median follow-up is only 2 years. If we look at different subgroups that were presented, all the subgroups favor pembrolizumab with hazard ratio less than 1 in all these subgroups that you can look at here, including performance status, PDL1 status, and others. Now, overall survival, very important to look at, was a secondary endpoint. Unfortunately, this is a very, very preliminary data with only 51 events, so 51 deaths on a study of over almost 1,000 patients. And why is that? Because we need more follow-up. And the first year, as you can see here, not much happened in terms of deaths, but at 24-month rate, there's a 3% absolute difference in survival. Now, you need a very, very stringent p-value here, which we did not achieve, but at least there is some emerging, encouraging results here with a hazard ratio of 0.54. No surprises in terms of side effects, more AEs with pembrolizumab, obviously, compared to placebo. This is the immune-related AEs, mostly consisted in hypothyroidism and hyperthyroidism. If you look at the high-dose steroid, which were being used more and more as a reflection of these immune-related AEs, anything that is 40 milligram a day or greater in terms of use of systemic corticosteroid, pembrolizumab 7% versus 0.6% with placebo. And I put that in the presentation during the ASCO meeting, wanted to show you how we came a long, long way. ASCO 1992, 29 years ago, I wasn't done with medical school at that time. And it was the first randomized control trial of adjuvant immunotherapy with cytokine. And since that, all these adjuvant immunotherapy were negative. You can see a snapshot here. The Keynote 564 came in. It took 29 years. I think there are still many, many questions here. This is top-line result. And I outlined them here. Is disease-free survival enough? Do we need overall survival? Do we need a biomarker? I had a lot of talk about ctDNA. I warn you here that ctDNA in renal cell cancer, it's not colorectal nor bladder. It's very, very, very hard. This tumor doesn't shed much tumoral DNA. Do we need 1 year? How did we come up with 1 year of pembrolizumab? Maybe we need 6 months, or maybe we need 2 years. How's quality of life on 1 year pembro? And you're gonna have some of the results within 2 weeks at ESMO. What's the financial cost? And most important, if a patient tumor progress on adjuvant pembro, what is next? Would you use still immunotherapy or not? These are open questions. And hopefully there are other studies of adjuvant immunotherapy with immune checkpoint inhibitors that are ongoing. Some of these already finished accrual, and hopefully they shed light on this question and give a consistent message that adjuvant TKI failed to do so. Now I wanted also to show you another renal cell study and the primary result and quality of life data, this time in metastatic disease, and that's the Len-Pembro study, again published in 2021 in the journal. And this is the study design. This was a frontline metastatic RCC study where the control arm at that time, and not anymore, luckily, of sunitinib was compared to 2 experimental arms, one containing a checkpoint inhibitor, that's the combination of pembrolizumab and lenvatinib, a TKI, or a non-IO containing combination of lenvatinib and everolimus. The primary endpoint was progression-free survival. Interesting enough, in the IO arm here, the highest progression-free survival seen to date, almost 24 months compared to sunitinib. And overall survival was met with an impressive response rate over 70% and a CR of 16%. Now with the lenvatinib everolimus arm, despite this arm response rate and PFS were superior to sunitinib, the overall survival was actually not significant. And I would venture to say that the hazard ratio more than 1 makes this combination not a starter in the frontline treatment of RCC. Now, this study also, and that was during ESCO, collected a lot of quality of life data. Again, with the non-IO, non-PD-1 inhibitor control arm, the len plus everolimus was either as good as sunitinib in terms of patient-reported outcome or inferior, or sunitinib was better. And the opposite happened with the IO, the len-pembro arm, where the differences were not significant, the same as sunitinib in terms of quality of life, or in blue, as you can see, with many quality of life metric here, was even better. So quality of life is important to differentiate between different regimens, especially that many of these IO-VEGF combination were not compared head-to-head. And I wanted to give a minute update about Keynote 426, since this is the VEGF IO study that showed an overall survival benefit, but also has enough follow-up here. And this was presented at ASCO 2021. Continued to show improved outcome with pembrolizumab and axitinib. This is the 42 months follow-up, showing a 5 months difference here with sunitinib. The only thing I wanted to say, despite the progression-free survival and the response rate that remains strong in terms of and consistent in terms of hazard ratio, the overall survival from the initial presentation where the median follow-up was a year to the last one where the median follow-up was between 3 and 4 years went up. The OS hazard ratio from 0.53 to 0.73. Several explanations, 2 of which could be that the responses with one IO with pembro axi maybe are not durable, and the patient perhaps do progress at the end, or perhaps second-line treatment, make the study of VEGF IO versus VEGF followed by IO. But we haven't seen that trend in the nivolumab ipilimumab study. I put here all the immunotherapy combination trials to date. This is updated as of yesterday night. All the study that showed an OS benefit here. And the nivo-ipi study of IO was the one that showed, the most consistency and lived up to its expectation and with time. Here with 48 months follow-up, the hazard ratio has not changed much from the initial reporting. While with VEGF IO, it went up, although stayed, statistically significant. So these are the take-home messages. I think first-line combination, VEGF IO, continue to rule here. There is really very little role for single-agent TKI. Remember, the nivo-ipi has the longest minimum follow-up, and the patient-reported outcome may become differentiator. I showed you early data, still not FDA approved, this agent, pembrolizumab, in high-risk renal cell cancer. I had to put something about biomarker. This is most of my laboratory research here. Still no biomarkers you can use in practice in renal cell cancer. I want to draw your attention of a study in papillary metastatic unselected papillary RCC, just published in Lancet by Dr. Pal here, showing cabozantinib to be superior to sunitinib in terms of progression-free survival. And remind everyone here about the revolution in renal cell cancer happening with HIF-2 inhibitor here, such as belzutifan, with a response rate of 25% in refractory renal cell cancer. This is important because this was also the base of a Nobel Prize in 2019 that dealt with HIF-2, but also with the larger theme of oxygen sensing. Now we move to prostate cancer. Wanted to put the most salient here finding. You heard about lutetium PSMA. This was another plenary. So ASCO 2021 plenary, 5 abstract, 2 of them GU, the adjuvant renal study and the lutetium PSMA study here by Dr. Sartor and others. So what's PSMA? PSMA is a transmembrane peptidase, carboxypeptidase. It stands for prostatic specific membrane antigen. It is really expressed in prostate cancer, including metastatic lesion, and it's restricted. It has a restricted normal expression, maybe a bit in the salivary and the lacrimal gland. And in addition to being a treatment, here this is an excellent target for PET imaging. Now, the treatment part is this 177 lutetium PSMA targeted ligand therapy, which bind to PSMA with high affinity, is able to emit beta particle that damage the DNA after endocytosis and lead simply to prostate cancer cell deaths. And this was the VISION study of patient whose tumor with metastatic castration-resistant prostate cancer, whose tumor really progressed on androgen receptor pathway inhibitor and taxane here, and were randomized to receive the lutetium or the protocol standard of care, whatever that was. And there was an overall survival benefit of 4 months with this new class of agent. And this survival, if you look here, despite the confidence interval are quite wide, was irrespective really of any specific features. All the hazard ratio are less than 1. Progression-free survival also was improved here with lutetium PSMA. Now the question is, as well as PSA response and overall response rate, by the way. Now, as you could expect from all these radionucleotide, you know, the side effects, though they're mostly grade 1 and 2, is bone marrow suppression. Very few, you know, high-grade toxicity. The bone marrow suppression, nausea, vomiting, not surprisingly dry mouth, because as we said, PSMA could be expressed on the salivary gland. And I wanted also to discuss a very important and potentially controversial study here, piece 1 presented by Dr. Karim Fizazi also at ASCO. This study that you know, went over 5 years. So this study was before, it started before docetaxel became standard in castration-sensitive prostate cancer. So this is a study, piece 1, dealing with metastatic castration-sensitive prostate cancer, where patients were randomized to standard of care, androgen deprivation, versus adding ABI radiation or ABI plus radiation. And what happened, the protocol was amended after it started, and started including, you know, patient to include standard at that time docetaxel. So it was possible to stratify for docetaxel use. And what Dr. Fizazi first presented is the radiologic progression-free survival in the overall population, showing superiority, not surprising, for abiraterone over ADT only. So ABI-ADT versus ADT only. But the important thing here, if you look at this large subgroup of 700 plus patients that received docetaxel, the radiologic progression-free survival was superior in the ABI group, suggesting a triplet may be of benefit here. This is my take-home message. I showed you the VISION study, a potential new option, totally new target and drug, you know, opening the field of radio nuclear therapy in castration-resistant prostate cancer with lutetium PSMA here. And the second, the triplet, should we start giving triplet without an overall survival benefit? A similar study, if you want, with enzalutamide, not with abiraterone, that's the Enzamet study published 2 years ago, showed a progression-free survival of 0.48 in the docetaxel group. Also, the OS hazard ratio was 0.9. So it will be very interesting to see what piece 1 OS will be. And finally, bladder cancer here. I want to remind you about, you know, 2020, actually, New England paper that was also a plenary here at GU with avelumab maintenance, which is a standard after chemotherapy here as a maintenance, showing a 7 months difference in overall survival from Javelin Bladder 100 Want to remind you also now that we have an adjuvant IO in bladder cancer. And I had, all these slides I did months ago, and I had to update them yesterday night, significant update. For example, on August 19, the FDA approved nivolumab for the adjuvant treatment of urothelial cancer who are at high risk for recurrence. So I leave it up to you to define that. The benefit was for disease-free survival. We did not see data for overall survival. The study was published by Dean Bajoran earlier this year. And also another study published earlier this year in metastatic urothelial cancer after chemotherapy, after immune checkpoint inhibitor, the antibody drug conjugate against Nectin-4, enfortumab vedotin, that we're gonna call EV, showed an overall survival benefit over dealer choice chemotherapy here, docetaxel, paclitaxel, vinflunine, with a hazard ratio of 0.7. And one thing I wanna mention at the end that, there is a renewed interest in bladder sparing procedures and research in muscle invasive bladder cancer. Here you're seeing a lot of chemo IO combination. I wanted to contrast these two presentations at ASCO here, and just the conclusion that they're safe, awaiting randomized trial. But there is a bit of frustration here because the endpoint across trial are very different. Pathologic CR, bladder intact, disease-free survival. The follow-up is very short. Really, it's hard to say whether this can become a mainstream approach, but there are several randomized trials that are ongoing, and we have to wait for these studies. So in terms of take-home message, and again, a lot of changes, and I made sure yesterday night to update the slides here. So remind everyone, platinum-based combo of chemo followed by avelumab as switch maintenance is standard in those patients that achieve responses or stable disease after platinum-based therapy for 4 to 6 cycles. Now, I had this listed as first-line pembro or atezo in cisplatin ineligible PD-L1 positive is a very reasonable choice based on non-randomized phase 2 trial. That was the accelerated approval. But just a couple of days ago, a final approval for pembro came, and the label changed to urothelial cancer patient not eligible for any platinum-containing chemo, including carboplatin. So remember that. Antibody drug conjugate are here to stay in metastatic urothelial cancer. We have 2 that are approved, EV and SG, better to just say their initial. And remember that the momentum is building for bladder preserving therapy for muscle invasive bladder cancer, with a backbone of an immune checkpoint inhibitor. And nivolumab is now FDA approved just, not long time ago, this month, or just past months, as adjuvant therapy in high risk muscle invasive bladder cancer. And remind everyone also that erdafitinib, which is an FGFR inhibitor, remain the first targeted agent for advanced UC in those patients, around 15% that have mutation or fusion in alteration in FGFR3 and 2. And finally, I want to thank again Dr. Al-Shamsi and EOS for the second year in a row invitation and the beautiful here scenery in your beautiful country. And until we are back again, hopefully next year. Thank you for your attention.
Thank you very much, Dr. Tony Shori. We'll have time for some questions from the audience, please. You can hear us, yeah?
Hi, Dr. Shwari. Thank you for this very nice summary. I'm in Dubai.
Oh, hi,
Hi.
Dr. Mukherjee. Great to see you.
So I have a
And
question.
congratulations on the award.
Thank you very much.
And,
Thank you very much.
congratulations for EOS for recognizing our superstar women in oncology that always push the envelope further and make the world of oncology.
Thank you to EOS. And did you notice that our three abstract presenters were actually women? So we have now reached the goal that everything is based on merit and not gender, which is fantastic. So my question was about...
Beautifully done research. I know not in the best situation and the environment, but you guys are able to pull it.
Thank you. So I have a question about the value of next generation sequencing in advanced kidney cancer, because in parts of the world which are not based in academic centers, we can obviously follow the guidelines of systematic treatment, but there's a lot of push to do next generation sequencing for all tumors. So do you think this is valuable in metastatic kidney cancer? Are there pathways that are commonly rearranged that can be targeted outside the current treatments that we have approved?
I mean, the short answer is no, simply, despite this is the research that I do on a daily basis. But let me just give you the longer answer here. I would not do it in the adjuvant setting, in first-line setting, but, you know, against that sometimes the specimen is lost. Sometimes you are in a situation where you need to see if there is anything underlying. You don't want to wait till the last moment. But with all the really deep sequencing study in all renal cell cancer, with the tumor suppressor genes and other, you know, alteration, these were not and are not still druggable. I can think of some examples in non-clear cell RCC where we found something, but these are handful examples. I would say perhaps the one that is important to keep in mind is germline testing, especially in younger folks, because 5% of kidney cancer tend to be hereditary, so that's very important, as well as non-clear cell RCC. The mutation here that carries probably the most weight where we have done studies is MET alterations that could be captured, but you can have the counterpoint here is that you have cabozantinib, which is approved first line, second line, in combo. So, you know, you're going to have that drug anyhow, irrespective part of the patient treatment. So the short answer is certainly very low on the list compared to diseases like lung cancer, for example.
Okay, thank you very much.
I think there's one more question from Dr. Hassan, and we have...
Thank you, Tony, for this nice, quick update. I'm sure we'll have so many questions, but I'm going to limit because we don't have enough time. It's interesting what you mentioned about the hazard ratio changes when you're using VEGF and IO. And so my proposition, if you have a rapidly growing disease and you need a quicker response, do you think a strategy of starting with this kind of combo and then maybe shift to a IO would be helpful? And it's strangely because when you think about epi-nivo, it's really only the 8 weeks of epi, and then the patient is on single agent nivo. And it's strange, even with pembro and the axi, that we're having this decline. So is there something to that 8 weeks of epi, you think, that's causing this maintenance sort of remission?
Yeah, I think epi is an active, very active, I mean, I wouldn't say very, it's an active agent that induces durable remission in a subset of clear cell RCC. We don't know who are those patients, but, you know, there is very few studies of epi high dose, even at the time of TKI, that showed responses, but this drug was not developed, I would say, well in renal cell cancer. It must be the IPI that lead to these durability of responses. And with 1 mg per kg, 4 doses, like you said, you do it 3 months and you're done, and then they're on maintenance nivolumab. That could be given every 8 weeks. So I agree with you. You know, the strategy here that we took, because I agree with you also, if you have a rapidly growing disease, you need a VEGF TKI on board. But the strategy here that we took is to we embarked on a study that finished accrual actually of nivolumab, ipilimumab, and cabozantinib at 40 milligram once a day versus nivolumab, ipilimumab only. It's a large phase 3 study that finished accrual, and hopefully you know, we don't have to think about that more. But I mean, I am giving a talk at ESMO, an educational talk about an optimal first line, and I have a paradigm at the end that's my own. I have my own disclaimer that could be controversial, but you could do many things when a combination has shown an OS benefit.
Right, absolutely. And then on the Fizazi study, I mean, the analogy to that, I would think, let's take breast cancer anti-CDK. It took us 3 to 4 years to show survival advantage, but all these drugs were approved based on a big PFS advantage, which was in the range of 12 months. So don't you think 2.5 years is in prostate? I know we think different about breast and prostate, but if you think of the PFS degree of benefit, to me, 2.5 years is huge. What do you think?
I agree with you. I think it's a huge, I personally think we don't want to wait for OS, but that's my thing. I think overall, it's the culture difference between doctors that treat prostate cancer and the one that did breast cancer. That's the only difference. It has nothing to do with science. Same thing in the culture of accepting an adjuvant treatment that yet doesn't have an overall survival in bladder and soon in renal cell compared to breast cancer. So we have to work these differences and see. If you have today a patient in front of you in clinic, and what would you do if the study has a short, medium follow-up to show an OS? You tell them to come back in 2-3 years.
Right. And just one last point on the enfortumab vedotin pembro combo. Do you think that's going to make it to the front line?
Very possible. The responses, I think, from the earlier study of 70+% without cisplatin is extremely encouraging. Now, EV has its own side effects too, not to ignore, but I think this combination is extremely attractive. Will I be surprised if it's superior? I would not be surprised based on the prelim data.
Thank you.
Thank you for having me.
Okay. I think we'll have time for one question. Is it okay?
Okay.
Yeah.
So thank you so much for this comprehensive presentation. My question is that how would you approach a patient with metastatic medullary renal carcinoma? And is there any novel agents that has shown some promise in this disease? Thank you.
Yeah, no. Again, this is an excellent question. It's a rare disease, so you have to put it into context first and review the pathology. Rare disease, at least in the US, you have a sickle cell trait, young patient usually come with metastatic disease, although there's another entity without the sickle cell trait that is medullary-like. These pathology classification, the newer one. Still, chemotherapy is the way to go, despite poor prognosis and the poor response rate with carboplatin and paclitaxel. That is my standard. Some folks have added bevacizumab on top of that, but this is a disease that really is quite somber. My good friend Nizar Tanir at MD Anderson, has done some very elegant work on this very rare histology.
I'm sorry, there's one burning question from audience, if you don't mind. Last one.
So it is a short question. If you have patient metastatic RCC on the treatment with pembroaxitinib and the slowly radiological progression without not symptomatic, so which time prefer to shift the treatment and which the treatment you preferred after pembroaxitinib?
Yeah, no, thanks for the question here. I can tell you that, it depends a bit. If the patient has no side effects or very little from axi, I go up on the dose. I have patient on 10 BID. If there is a progression, but in one side, two sides on a disease that, have many sites, involved, I will go with localized therapies, whether SBRT, surgery. I have currently a patient, same thing, 20 nodules in the lung plus liver metastases, bone, well controlled on pembroaxi, and there is one site in the adrenal that keep growing by 5-10% each time over the next 10 years. So we're gonna get, this patient has another adrenal functioning, so we're gonna address that adrenal. Now, if you really, you say, I did my best and this is pembroaxi progression, usually I go with cabozantinib or everolimus, usually second line cabozantinib. That has the strongest data here. We do have though 2 studies that ask an important question, whether we should continue to use immune checkpoint inhibitor, PD-1 inhibitor, after progression on prior PD-1 inhibitors. So we have CONTACT-3. This is a study of cabozantinib versus cabozantinib atezolizumab, specifically in patients that progress on prior IO. So your patient on pembroaxi would be eligible. We have another study with the novel TKI just recently approved called tivozanib, with tivozanib plus minus nivolumab. I think the burning question here, Doc, is should we continue the immune checkpoint inhibitor, whether it's pembro or another drug? We don't know. We're going to test that soon.
Thank you so much, Dr. Tony. This is Hamid Shamsi. Thank you so much for your support and for your support for EMERGE Oncology Society and also the Community Society in the Middle East as well. And also very well done for being named the most influential oncologist on Twitter. So thank you for your support and congratulations again.
I don't know if that's good, but I want to thank you for raising the bar here in the Arab world and this part of the world and doing things that many cannot do. So this will not go unnoticed, Dr. Al-Shamsi.
Thank you, doctor. Thank you so much.
Have a good day, everyone. Bye.
Thank you. So we'll go now back to the top abstracts winners. And actually, the agreement was between the 4 of us about the winners, and Dr. Saeed Hamad will take care of this. Dr. Saeed, can we have the screen of the videos live for all the participants? Yeah. Yes, please. Yeah.
Okay. Thank you very much for submitting your articles, and it's very encouraging to see, especially now, women, as Dr. Mukherjee was pointing out earlier, are the 3 chosen abstracts in the top. So all of you are winners actually. So we have done the moderation, so we come to the conclusion. So we'll announce the third winner. So third prize will go to Dr. Maha Ibrahim.
Thank you very much to the Emirati Oncology Society and for everybody, and thanks for participating today.
And there's actually a cash prize as well, so it will be a 3,000 dirham cash prize. So congratulations. Okay.
Thank you.
First one. Okay, yeah, second. Okay, so our second prize goes to Dr. Lodi Jihad.
Thank you, everyone. I would like to thank the committee at EOS and Dr. Mukherjee for her guidance in executing this trial.
And the cash prize for you is 5,000 dirham. Congratulations. So finally, the final prize, the first prize goes to Dr. Radwa Himad from Egypt. Congratulations.
Thank you. Thank you so much. I want to thank you, and I want to thank all my professors for helping me in this study. Thank you so much for giving me this chance to participate with you. Thank you.
مبروك رضوى and يعني نبارك لك هذا الانجاز ونتمنى ان شاء الله باذن الله ان يكون هذه الجائزه ايضا حافز لمزيد من الابحاث من مصر ومن العالم العربي. Thank you so much and we wish you all the best. We look forward to have more research from Egypt and the Arab region ان شاء الله. مبروك.
Thank you so much. Sure. Thank you.
Thank you. Okay. So we'll resume now. So mabruk and congratulations to all the winners, and we look forward, inshallah, for more abstracts coming in the next year. And we'll move now to the next session by Dr. Hassan Ja'far, inshallah. And Dr. Hassan doesn't need an introduction. We have 2 Hassan, Hassan Ja'far and Hassan Ghazawi. Both of them are well known.
Thank you, Dr. Ahmed. Good afternoon again, dear colleagues. So we'll start the symposium of Astellas. And I'm delighted to present Dr. Imad. He's a colleague and friend. He is currently a consultant medical oncology in Tawam Hospital. He finished his MD and PhD in 2010. Also, he joined the Royal College of Physicians of UK Medical Oncology in 2012. He participated in many clinical trials and abstract published more than 50. He's also a member of different societies. So he will discuss mainly the evolving landscape of metastatic hormonal sensitive prostate cancer, individualizing patient care in prostate cancer. Please welcome Dr. Imad.
Thank you, Dr. Hassan, for your nice introduction. Another thanks for the Astellas for inviting me, and thanks for the organizing committee for giving me this opportunity. And today I'm going to talk about the evolving landscape in management of metastatic hormone-sensitive prostate cancer and how we can individualize the patient care in this setting. So this is a disclaimer from the company, and this is my disclosures. Well, historically, androgen deprivation therapy was the standard treatment for men with metastatic castrate-sensitive prostate cancer. And in recent years, combining docetaxel with ADT or novel hormonal therapy or even radiotherapy, it did really improve the overall survival for those group of patients. And these approaches become a standard of care for patients with metastatic hormone-sensitive prostate cancer. But however, it is unknown how to sequence these agents and whether combining this agent in this group of patients, it will improve the outcome or not. But metastatic hormone receptor hormone-sensitive prostate cancer, we have a lot of facts and challenges. The fact that it's a heterogeneous disease, patients with de novo metastatic, they do differently from those with the recurrent metastatic disease. The compelling evidence of X drug plus ADT, it's a standard of care in polymetastatic disease. And currently in 2021, I think it will be very rare to find the patients only in ADT. But the fact that the study from US showing that almost 43% of patients is still on ADT in hormone-sensitive metastatic prostate cancer. Another challenge that what is the role of local therapy in this group of patients? And we have a major challenge that we are lacking a comparative study to guide the optimal treatment in this setting. That requires to consider multiple disease factors as well as non-disease factors to select the treatment options. And most recently, we have approval of PARP inhibitors in patients with germline mutation positive and castrate resistant. So what if we know that this patient has BRCA mutation in sensitive setting, and what the role of PARP inhibitors is still these questions not answered in this group of patients. So docetaxel, it was the first drug has been approved in this setting, and this is the Charter trial for patients with metastatic hormone receptor sensitive disease. They randomized into ADT plus docetaxel up to 6 cycles versus ADT, and they stratified the patient according to the prior adjuvant therapy and volume of the disease. Primary endpoint was overall survival, and secondary endpoint was clinical progression-free survival. This trial was positive. It did improve overall survival in intent to treat population, but if you digging in depth according to the stratification factors regarding the disease volume, you find that patients with high volume disease, they have the magnitude of benefit with improvement in overall survival and hazard ratio of 0.63. However, those with low volume disease did not derive the same benefit and lacking overall survival with a hazard ratio of 1. Stampede trial it's an open label, multi-arm, multi-stage trial also. They have been addressed the rule of docetaxel plus standard of care versus standard of care. And this trial showed also there is superiority in overall survival by adding docetaxel to the standard of care versus standard of care alone. Unfortunately, the GTOG trial, it did not show that overall survival benefit with a hazard ratio of 0.88. And this is a pooled analysis from both chartered and GTOG trial, looking for the disease volume as a biomarker for response to docetaxel, and it was clearly that patient with high disease volume, they drive the same, the magnitude benefit for overall survival with the hazard ratio of 0.68. But those with the low volume disease, there is no overall survival benefit. And as you see, the hazard ratio is 1. And this is meta-analysis for or randomized trial for docetaxel that showed there is an absolute benefit of 9% in 4 years overall survival by adding docetaxel to standard of care in hormone-sensitive metastatic prostate cancer. But it's not every patient can tolerate docetaxel, especially prostate cancer patients. They are mainly fragile. They have a lot of comorbidities. And here we have the novel hormonal therapy, and this table showed that the different approved treatment options, starting by abiraterone acetate, and we have 2 phase 3 trials, the Latitude trial and the Stampede trial, enzalutamide from Enzamet and the Ashes trial, and finally the apalutamide from the Titan trial. So most of this trial, the primary endpoint was overall survival, and it has been met, and the trials all are positive. And the challenge is that how we can select the proper treatment for our patients. And probably we are selecting the treatment options according to the patient characteristic, the patient comorbidities, as well as the toxicity of each drug. If you know that the abiraterone acetate, it has liver toxicity with the high transaminases, hypokalemia, hypertension, while enzalutamide, mainly fatigue, and apalutamide, skin rash, and also fatigue. So the Latitude trial, which is the first trial to address the efficacy of abiraterone plus prednisolone in hormone-sensitive prostate cancer, this trial was positive. It met its co-primary endpoint by improvement in radiographic progression-free survival with a hazard ratio of 0.47, as well as overall survival with a hazard ratio of 0.6. The same from the Stampede trial from the arm G, where the abiraterone plus prednisolone has been also compared to the docetaxel and abiraterone. And this is the only data that we have chemotherapy versus novel hormonal therapy in hormone-sensitive setting, where as you see, there is not any overall survival benefit, but probably we do have a failure-free survival, progression-free survival, metastatic progression-free survival, and symptomatic skeletal events. They are in favor of abiraterone rather than docetaxel. And I think also the toxicity profile of abiraterone would be better than the docetaxel in this group of patients. Enzalutamide also has been approved based on 2 phase 3 trials. The Enzamet trial, which is an open label multi-center phase 3 trial for patients with hormone-sensitive metastatic prostate cancer. Patient randomized into enzalutamide plus testosterone suppression or standard non-steroidal anti-androgen and testosterone suppression. They stratified the patient according to the disease volume and prior exposure to docetaxel. As in this trial, they allowed up to 2 cycles of docetaxel. The primary endpoint was overall survival, and we have a secondary endpoint of PSA, progression-free survival. As we see here, the trial is positive. It met its primary endpoint by improving the overall survival. We have a 36% reduction in risk of death with a hazard ratio of 0.67. And if you looking for these patients with those exposed to docetaxel before, so the progression-free survival was positive in this trial. We have a hazard ratio of 0.48. but there is no overall survival benefit for this group of patients, has a ratio of 0.9. But in case of the patient did not receive docetaxel, progression-free survival as well as overall survival, both are highly statistically significant in favor of enzalutamide. The safety profile of enzalutamide, it's well known for all of us, and we have been using the drug since quite some time, starting from the castrate-resistant prostate cancer, non-metastatic castrate-resistant prostate cancer, and the recent approval for hormone-sensitive prostate cancer, where mainly I think fatigue is the most important side effects, but to be honest, it's mainly grade 1 and grade 2. As you see here, 25% of the patients, they have grade 1 and grade 2. Severe grade 3 and 4 toxicity, it's only 6%. Other side effects like hypertension, risk of fall, or seizures, in my practice, I didn't see these side effects just reported in the clinical trials. And I think it's very, very rare and should be negligible. The second trial is ARCHES trial, and here it's double-blind randomized phase 3 trial. And here they allowed for a full course of docetaxel up to 6 cycles. And they randomized the patient into enzalutamide plus ADT versus placebo and ADT. And they also have stratification according to the disease volume, low volume versus high volume disease, and previous docetaxel exposure for those patients completed 6 cycles or less than 6 cycles. So the primary endpoint in this trial was radiographic progression-free survival, and secondary endpoint was overall survival. This trial also was positive. It met its primary endpoint by improvement in radiographic progression-free survival. And as you see here, the two curves are separated as early as the first assessment at 3 months. The median progression-free survival for enzalutamide ADT even not reached. And we have a hazard ratio of 0.39. So 61% of the patients, they are radiographic progression-free at 2 years of follow-up. And this is a subgroup analysis for radiographic progression-free survival. And as you see, all patient population, they derive the same magnitude of benefit by adding ADT, by adding enzalutamide to ADT, even for those with pre-specified stratification according to the disease volume, low volume or high volume disease, or those with the prior exposure to docetaxel or no exposure to docetaxel. And also they reported the quality of life for those patients. And as you see, there is no any deterioration in quality of life by adding enzalutamide to ADT. The two curves are almost overlap. What about apalutamide, which is the third drug approved in this indication? And this is the TITAN trial, where the patient with the metastatic castrate-sensitive prostate cancer, they are randomized into apalutamide plus ADT or placebo plus ADT. And again, they stratified the patient according to prior exposure to docetaxel. So they allowed patient with previous exposure to docetaxel in this trial. Primary endpoint was overall survival as well as radiographic progression-free survival. Also, this trial was positive by improvement in the radiographic progression-free survival. And here at 2 years of follow-up, we have 68% of the patients are radiographic progression-free, and versus 48% in the ADT plus placebo. The median radiographic progression-free survival not reached for apalutamide, and it's 22 months for the placebo and ADT with the hazard ratio of 0.48. Overall survival also has been achieved in this trial. So at 2 years of follow-up, 82% of patients still survive versus 74% in ADT placebo. And the median not reached for both a group of patients, but we have an hazard ratio of 0.67. So we have a 33% risk reduction of death with the apalutamide in this group of patients. This is a subgroup analysis for the hazard ratio of radiographic progression-free survival. And as you see, all patient population, they benefit from adding apalutamide to ADT. Toxicity profile, as expected from this class of patients, class of medications, fatigue and rash are the most common side effects, but rash, I think it's unique for the apalutamide, which is not in other novel hormonal therapy. Darolutamide also, it has a phase 3 trial in hormone-sensitive prostate cancer metastatic patients, and this is Arsene's trial. So they randomized patient into ADT plus docetaxel and darolutamide. And this is the second trial showing the combination of novel hormonal therapy and docetaxel versus ADT and docetaxel and placebo. Primary endpoint of this trial, overall survival. And this trial has been completed recruitment, and we are anticipating the data to be presented in this ESMO. I don't have the results yet. And in my conclusion, selection of treatment option for patients with metastatic hormone-sensitive prostate cancer, it's depend on many factors. We don't have a head-to-head comparison for this class of agents. So probably we rely on the practical considerations, such as patient comorbidities and the volume of the disease, low volume or high volume disease, adverse events of each drug, duration of therapy, and route of administration or IV, and most important, the financial toxicity of each drug. So with that, I will end my presentation, and thanks for your listening. I'll be happy to take any questions. Thank you.
Thank you, Dr. Ahmad, for this nice overview on the treatment of metastatic hormonal sensitive prostate cancer. So the floor is open for questions. Please, Dr. Hassan.
Nice review, Dr. Dawood. So can you comment on the study we're talking about, Dr. Fizazi's trial, because I think it's very relevant in this type of patients. And do you project that this may become a standard? That's, combination of ABI plus docetaxel. That was, I think, from the get-go. They started combination from the initial docetaxel, and then they continued with abiraterone, and there was a 2.5 years PFS difference.
You mean the PEACE-1 trial, right?
Yes, Doctor.
Yeah, actually, this is one of the interesting trials. I didn't present in my presentation for sake of time. This is the first trial that showing the combination of androgen deprivation therapy plus abiraterone plus docetaxel plus even radiotherapy. So we are giving everything in this setting. The trial is positive, and the only thing that the toxicity profile. So how much our patients can tolerate everything in one time. So if you don't mind, I can show you.
I think Dr. Ahmad is not only the toxicity profile, but also the overall survival, also data is not there, which probably we approve all this medication based mainly on the overall survival.
Again, if you will wait for overall survival, it will take some time, but it depends on the primary endpoint of this trial.
Right, and I gave the analogy of breast cancer, the anti-CDK4/6, they were all approved based on PFS of 12 months, much shorter than what we saw with prostate.
I think the only limitation for this trial is I think the toxicity profile of combining everything for the patients. Especially our patients here, they are difficult to give docetaxel as a monotherapy. So imagine to combine docetaxel with the radiotherapy and with the abiraterone and ADT. This will be one of the most limitation to adapt this combination. But the trial for the primary endpoint, at least what is presented in the last ASCO, it was positive.
Yes.
And in terms of radiating, since we mentioned radiating the primary and low volume disease, do you think, is that a standard now you're doing at your place?
Well, in our center, we are discussing such cases in the tumor board. So those patients with low volume disease or oligometastasis, we irradiate the primary tumor. We have a phase 3 trial that showing overall survival benefit.
Thank you.
Dr. Deborah.
Thank you very much for a really nice summary of the data. So I'd like to ask you about your experience in this part of the world with your patients with prostate cancer. Do you find that they're often diabetic, obese? Do you have problems giving patients? You mentioned chemotherapy is problematic. Do you have problems with the steroids that might need to be given with drugs like abiraterone, or is that not so much a problem in your patient population?
Thank you, Dr. Deborah, for your questions. Actually, the prevalence of diabetes in our community is very high. So most of the patients, they are diabetic, where giving the steroids, it's one of the limitations for those patients. But just put in mind that the abiraterone acetate with the prednisolone here in hormone sensitive only 5 milligram daily, and in castrate resistance 10 milligrams. So we see more difficulty in castrate resistant rather than the castrate sensitive because of the dose of prednisolone. But it's still one of the limitations to adapt this combination for some patients with especially those with uncontrolled diabetes.
Okay. Thank you very much. Lots of options. Sometimes it's difficult to choose between them, and these small details can be helpful.
Well, we have the enzalutamide, which is have been used in the market since a long time. We have a very good experience for this drug, and probably only fatigue is only limiting toxicity, and this can be also managed by those medications.
Okay, thank you very much.
Dr. Ahmad, do you see any subset of patients in the metastatic hormonal sensitive, they may need only androgen deprivation therapy?
Well, it's very rare, but I think those patients with low volume disease, they have a benefit from novel hormonal therapy, and most of novel hormonal therapies are well tolerated for those patients. But probably patients with maybe oligometastasis, I may consider ADT alone, or if patients are not fit for any novel hormonal therapy, but it will be very, very rare.
One more point. There was, we heard a lot about cardiovascular morbidity from, anti-androgen therapy, etc. And then just 2 days ago, there was a recent publication which said there was actually no difference in mortality. So we have data for and against. What's your view on that in terms of cardiovascular side effects?
Well, even if it's reported in the trial, it was quite rare. It's not that common. And in our practice, we are not seeing that. And you mentioned that it's not, there is no difference at the end. So I don't think this is something that we have to pay attention for that. It's quite rare.
Thanks.
So for those patients with the bulky disease, how much you go for chemotherapy combination versus the second generation anti-androgen treatments? And which one you will use? Do you use which one of the three?
Well, first of all, I will discuss with my patients. So I may consider chemotherapy if the patient is young, fit enough for chemotherapy, with visceral disease, and or high volume disease, if they don't want to go for long-term therapy. And this is very few patients, but most of the patients are elderly patients, and they don't like to have the chemotherapy, so we'll end up with one of the novel hormonal therapies. And it's the same discussion and debate in the castrate resistance will be the same applied in the castrate sensitive, and probably also in the non-metastatic castrate resistant, because all these agents has been approved in these indications. So I will go with the toxicity profile of each drug and the patient criteria and comorbidities, and most important, the cost of each drug. So this is the only 3 factors that I will choose which treatment according to the patient factors and side effects of the drug.
Thank you very much, Dr. Imad, and we will move to the other session. Dr. Faraz Khan. Dr. Faraz Khan is a consultant medical oncologist in American Hospital who will take the lead in the second session.
Good afternoon, everyone. And it's a pleasure to introduce again Dr. Imad Dawood. I guess everybody knows the introduction. Dr. Imad is a wonderful colleague, consultant medical oncologist at Tamam Hospital. And I believe he has already been introduced. So he will be discussing evolving treatment approaches in the frontline advanced ovarian cancer. Dr. Imad.
Thank you, Dr. Faraz. And thank you again for having me for this talk, and I would like to thank AstraZeneca for inviting me. I know we are moving for a different disease area, but luckily they are in the same pelvis. So now I'm going to talk about the evolving treatment approaches in frontline advanced ovarian cancer. And this is the disclaimer by the company. And as we all know that BRCA mutations are considered the most common gene mutation in ovarian cancer, and currently we are assessing this mutation in patients with ovarian cancer in the front line, whether the germline mutations by blood test or the somatic mutation in the tumor itself. And for quite some time, we considering that BRCA mutation is a biomarker for use of the PARP inhibitors, but currently, it's beyond the BRCA mutations, and we have almost up to 10 gene mutations in the spectrum of what we call homologous recombination deficiency, which is approximately in 50% of patients with the epithelial ovarian cancer. They have HRD, and they are showing response to the PARP inhibitors. BRCA mutation is the most common gene mutation in the HRD, and it's considered also as a standard of care, and you have to assess the BRCA mutation in the front line for all patients with epithelial ovarian cancer, especially those with high-grade serous carcinoma or endometrioid adenocarcinoma. The rationale for assessing the BRCA mutation and HRD, it's because of the uses of PARP inhibitors. Now it's standard of care in the first line. And also there is some risk of other cancers, such as breast cancer for these patients, and also for the hereditary or familiar cancers if they have BRCA mutations. HRD testing also, it's important in the first line treatment decision, and we are going to discuss this in the next couple of slides regarding the approval of the PARP inhibitors in patients with HRD positive epithelial ovarian cancer. And currently, olaparib and niraparib, and even olaparib plus bevacizumab approved in BRCA mutated ovarian cancer, and niraparib and olaparib plus bevacizumab approved in HRD positive, and only niraparib in HRD negative patients. But for those in subsequent treatment lines, I don't think there is a need for that. But just to know that BRCA mutation, it drives the greatest efficacy, followed by HRD positive and then HRD negative patients. So luckily, we do have currently a commercial test for the homologous recombination deficiency, and this is the Myriad My Choice CDX assay, which is assessing the HRD in the tumor itself. And thanks for our partners in AstraZeneca for sponsoring this test for our patients. So this test looking for the genotype of tumor BRCA mutation, as well as the phenotype genomic instability. So if patients having HRD positive should have one of these two factors or two tests that should have BRCA mutation in the tumor and or genomic instability score of 42 or above. So if negative, that means that there is a BRCA wild type, and the genomic instability score if less than 42. And in last year, the FDA approved olaparib plus bevacizumab as a maintenance therapy in ovarian cancer. And also they have been approved the Myriad My Choice CDX as a companion diagnostic test for the use of olaparib in this group of patients. Here, just to show that the evolving landscape in the treatment in the first line, and since the approval of bevacizumab in 2011 based on the GOG 218 and ICON 7, we spent almost like 7 years without any improvement in this frontline setting until the approval of olaparib based on the SOLO-1 trial in BRCA mutation patients. And last year we have the niraparib and olaparib plus bevacizumab in frontline patients for all comers. So I'm going to discuss the three main phase 3 trials: the SOLO-1, olaparib versus placebo; the PRIMA trial, which is niraparib versus placebo; and the PAOLA-1, which is the olaparib plus bevacizumab versus placebo and bevacizumab. Well, first of all, I would like to highlight that if you miss to give your patients PARP inhibitors in the first line, so probably the chances to give PARP inhibitors in subsequent lines, it will be only 30%. Looking for the Kaplan-Meier curves of the progression-free survival from the placebo arm in the SOLO-1 trial, in the first 6 months, almost 20% of the patients will relapse. So they consider as platinum resistance, and by definition, they are ineligible for PARP inhibitors. The vast majority, up to 55%, they will relapse after 6 months. So they are platinum sensitive, but unfortunately, 40% of those patients will not respond to subsequent platinum therapy. So they consider also ineligible for PARP inhibitors. And the rest of 25%, they have long-term remission, or you can consider them acute patients. Probably they will not receive any subsequent therapy. So 1 out of 3 patients, if not receive PARP inhibitors in the first line, will only 1 out of 3 will receive in the subsequent line. And here I would like to highlight the data from the SOLO-1 trial. And here the trial was designed to assess the efficacy of olaparib in patients with stage 3 and 4 high-grade serous or endometrioid ovarian cancer, those with BRCA mutations. And they randomize patients into olaparib or placebo treatment up to 2 years, or if there is any evidence of progression of the disease. They have stratification factors according to the response to the platinum-based chemotherapy, whether they have complete response or partial response. And the primary endpoint of this trial is investigator assessed PFS. But we have a secondary endpoint, which is overall survival, time to first subsequent therapy, time to second subsequent therapy. And here the baseline patient characteristic, which will balance it between the 2 treatment groups. Just to highlight, the vast majority of patients are stage 3 in more than 80%. Majority of patients are BRCA1 mutations, and 6% they have upfront surgery, and up to 1/4 of the patients they have residual disease, and the interval cytoreductive surgery has been carried in 1/3 of these patients. The trial was positive. It met its primary endpoint by improvement in progression-free survival. And here, at 3 years of follow-up, we have 60% of the patients still progression-free versus almost 27% for the placebo group. We have hazard ratio of 0.3. Median progression-free survival not reached for the olaparib, and it's only 13.8 months for a placebo group. And if you're looking for the subgroup analysis according to the progression-free survival, so all patients population, they derive the same magnitude of benefit by adding olaparib to our patients, regardless the stage, regardless the type of BRCA mutations, or even the response to the chemotherapy. But they highlight that the outcome from patients according to the time of surgery. We know that upfront surgery, it's preferred, and patients those having upfront cytoreductive surgery, they have a better outcome when compared to those patients with the interval cytoreductive surgery. But no matter the timing of surgery, olaparib, it did improve the progression-free survival when compared to the placebo. And it was obviously clear that patients with upfront surgery, they're doing better than patients with the interval debulking surgery in both treatment group, olaparib and placebo. The same for the surgical outcome, those having no residual disease or there is the residual disease, it's no matter. It's still olaparib, it did improve the progression-free survival in both treatment groups. But in general, those patients with no residual disease, they have a better outcome when compared to those patients with a residual disease after cytoreductive surgery. Response to the chemotherapy, those patients with the complete response or partial response, again, no matter, there is a significant improvement in progression-free survival in favor of olaparib. And probably, again, those having a complete response, they have a better outcome compared to those patients with partial response. But it's still a very significant hazard ratio in both group arms in favor of olaparib. So they also highlighted the outcome from patients with the low risk criteria, those patients with the stage 3, those patients has no residual disease and they're having a complete response to the chemotherapy. So in those group of patients, even the olaparib, it did improve the outcome with the hazard ratio of 0.32, which is matching the hazard ratio in the overall population. So even with the low risk factors patients, olaparib, it did improve overall progression-free survival. Coming to the toxicity profile, and I think we all are familiar with the safety profile of olaparib, and probably GI such as nausea, vomiting, and diarrhea, and most of these side effects are grade 1 and grade 2. The most important one is anemia, which is on only 17% in grade 3 and 4 of our patients. And in this trial, they have been looking for the dose reductions over the 2 years of olaparib, and 64% of the patients, they maintained the full dose of olaparib, and only 1/3 of the patients, they required dose modifications. Last year, we have an updated 5-year survival from the SOL-1 trial, and this is at 5 years progression-free survival. So almost we have 50% of the patients is still progression-free, and I may consider this as the cured patients. The hazard ratio of 0.33, and median progression-free survival of 56 months for the olaparib, and only 13.8 months for the placebo. Other post-hoc analysis, such as time to first subsequent therapy, or PFS2, or time to second subsequent therapy, also has been statistically significant, higher in favor of olaparib compared to the placebo in this trial. And with the longer follow-up, after 2 years of olaparib, and this is the safety profile at 5 years, there is no any new safety signals were observed during the long-term post-hoc analysis. Here the PAOLA-1 trial, and this just to try to use the PARP inhibitors for all comers and patients with the stage 3B and 4 high-grade serous or endometrioid ovarian cancer. Those completed the first line of chemotherapy and the surgery. Those have a kind of response to the platinum-based chemotherapy plus bevacizumab, randomized into olaparib or placebo plus bevacizumab. And bevacizumab has been given here up to 1 year, and olaparib up to 2 years, or placebo up to 2 years. So they have a stratification according to the BRCA status, and also the outcome after the first line chemotherapy. Primary endpoint is investigator-assessed progression-free survival. Secondary endpoint, overall survival. This trial also, it's positive. It met its primary endpoint for all comers. There is a significant improvement in progression-free survival, with the median progression-free survival for olaparib and bevacizumab 22 months, and only 16.6 months for the placebo and bevacizumab. The hazard ratio here is 0.59, which is statistically significant. And if you stratify the patient according to the HRD status, you'll find that the magnitude of benefit was for those with the BRCA mutation with a hazard ratio of 0.33 and 37-month median progression-free survival for olaparib and bevacizumab, and only 17 months for the placebo and bevacizumab. Also, patients with HRD positive tumors, rather than the BRCA mutation, they have improvement in progression-free survival in favor of olaparib and bevacizumab, 28 months versus 16 months. And only patients with HR proficient, they lack the benefit by adding olaparib to bevacizumab. We do have a hazard ratio of 1. There is some exploratory analysis according to the risk criteria in this trial. So they consider patients with low risk criteria, those patients with stage 3, those having upfront primary cytoreductive surgery with no residual disease. So they have all low risk criteria. And they have another group of patients with high risk factors, such as patients with stage 3 disease and residual disease after surgery, or those having stage 4 disease or received neoadjuvant chemotherapy. So they are considered as high-risk patients. So they have been looking for the outcome by adding olaparib to bevacizumab versus placebo in bevacizumab for patients with high risk in all comers regarding the HRD status. So again, the hazard ratio was statistically significant with 0.6 in favor of olaparib bevacizumab. We have 20-month median progression-free survival and only 14.7 months for the placebo and bevacizumab. The same for patients with low risk criteria, regardless of the HRD status. We have a very significant hazard ratio of 0.46 and almost 39-month median progression-free survival versus 22.9 months for the bevacizumab and placebo. And if you look for the patients with HRD positive patients, the adding olaparib to bevacizumab, it did great regardless of the risk factors. So high risk patients and HRD positive, the hazard ratio of 0.39 and 36 median progression-free survival versus 16 months for bevacizumab placebo. But in my opinion here, in low risk patients, to see 90% of the patients progression-free at 2 years of follow-up with the hazard ratio that is difficult to see in any clinical trial in ovarian cancer with 0.15 hazard ratio of progression-free survival, and the median not reached for olaparib bevacizumab, and only 22 months for the placebo and bevacizumab. Again, the safety profile from the Paula one, it was matching with the safety profile in the Solo one trial. Just one exception, that the hypertension, which is probably related to the bevacizumab in this trial, but again, the GI toxicity, which is very minimal grade 1 and grade 2, and anemia only the one with the 17% grade 3 and 4 toxicity. Other than that, I think that the drug is well tolerated and there is no any major side effects. The last trial here, the PRIMA trial, which has been designed to assess the efficacy of the niraparib as a maintenance therapy in patients with newly diagnosed advanced ovarian cancer after platinum-based chemotherapy, regardless of the biomarker status. So they randomized patient into a niraparib or placebo, and the endpoint was progression-free survival, second endpoint overall survival. They have stratification factors according to the neoadjuvant chemotherapy, yes or no, and the best response to the chemotherapy in the first line. The trial is positive for the all comers, and as you see here, we have a hazard ratio of 0.62 in favor of niraparib, and the median progression-free survival 13.8 months for niraparib and 8.2 months for the placebo. And even if we dig in depth looking for the HRD positive or HRD negative. The trial is positive even in HRD negative patients. And the magnitude benefit was initially for those patients with the BRCA mutations, followed by HRD positive, and the least benefit it comes from patients with HRD negative disease. So that's why all international guidelines, they included the PARP inhibitors in frontline of ovarian cancer patients. And here just to highlight that ASCO guidelines, they approved olaparib and bevacizumab based on the PAOLA-1 trial in patients with HRD positive tumors, the same for the ESMO guidelines. And finally, I will this is my conclusion. We have in phase 3 trial PAOLA-1 that median progression-free survival was significantly prolonged with the addition of olaparib to the bevacizumab in the front line after platinum-based chemotherapy in patients with ovarian cancer, regardless of BRCA mutation status. But the pre-specified subgroup analysis suggested that patients with HRD or tumor BRCA mutation, they have the most significant improvement in progression-free survival. And data shows activity of olaparib plus bevacizumab in patients who are BRCA mutation negative but HRD positive. And safety profile of combining olaparib and bevacizumab was tolerated and consistent with the previous step. So again, thank you for your listening, and I would be happy to take any questions. Thank you.
Thank you, Imad. Thank you, Imad. So this is a question right there.
Yes, Dr. Dawood, thank you again for a nice review of the subject. My question, so we have the SOLO-1 trial, which used single agent olaparib. And then we have the PAOLA-1. Unfortunately, they did not have a single arm with olaparib alone, because bevacizumab was given, I guess, since it was more standard to give. But looking at the curves, I mean, I know we're comparing across trial, but do you really think the addition of bevacizumab, especially in the maintenance phase, is doing anything on top of olaparib? The reason I say that, you know, these patients usually want a break. They don't want to come and keep getting IVs. So it certainly would be much more convenient to stay on single agent oral therapy. What do you think on that concept?
Thank you, Dr. Hassan, for these very interesting questions, actually. And this is what we have been discussing with my colleagues in daily practice in our clinics. What if we have a patient with BRCA mutations? The curves are widely separated in SOLO-1 and PAOLA-1. Even the hazard ratio almost pretty similar, 3.1, 3.3 in both trials. So in our practice, what we are doing, we're assessing the BRCA germline and as well as HRD. So if patient having BRCA mutation, probably will prefer to go for SOLO-1, olaparib monotherapy, and saving the toxicity of adding bevacizumab. But if BRCA mutation or BRCA wild type HRD positive, so they have only one data from the PAOLA-1 trial, and usually we go for bevacizumab and olaparib.
And then, so in the HRD negative, you know, I know you mentioned briefly the primer trial, the niraparib, showing benefit in the HRD negative, but if you look at that subgroup, the benefit was almost similar to bevacizumab maintenance. Would you agree with that? And would you offer in between niraparib and bevacizumab, what would be your choice?
I agree with you, but at the end of the day, the drug has been approved in patients regardless of the HRD. And luckily, we don't have the niraparib in our area, so I'm not bothering myself to think about niraparib, so I have only olaparib. And we are using only in patients with the BRCA mutation or HRD positive population.
And I think PAOLA-1 also, right? The PAOLA-1 also, I mean, of course, it's not in the indication, but PAOLA-1 also showed HRD negative benefited as well, but the benefit was not the same.
It wasn't in the label.
Exactly.
One last comment. We have seen recent data. I know we always say if it's platinum resistant, don't bother with PARP, but actually there's emerging data that may not be true. They're challenging that concept, the one you were talking about, if we don't give PARP in the beginning. So because it's all about relative resistance, and the definition of resistance is a gray area anyway. So there was recent publication on that as well. I don't know if you saw it, that there is probably not an absolute resistance to PARP if you had been exposed and labeled as platinum resistant. What do you think?
Well, you know, we have a platinum refractory, we have a platinum resistance, and the definition of refractory and resistant based on the timing since progression, and this is nothing scientific, just we agreed that we consider 3 months it's refractory, 6 months it's the resistance, more than 6 months it's sensitive, more than 1 year it's very sensitive. It's arbitrary classifications, and but in my practice we used to see that kind of resistance to PARP inhibitors if the patients are resistant to platinum-based chemotherapy. Sometimes, if the patient's like progressing in the border of 6 months and they are challenged with the platinum-based chemotherapy, if they responded, I still using PARP inhibitors if not used before in maintenance subsequent treatment lines. But I cannot use PARP inhibitors in patients with clearly this platinum resistance, and for 2 reasons. Number one, it's a costly drug, so I would like to save it for the patient that is really in need. Second, I don't want to waste the patient time by using drug that, doubt that they will respond. And we have standard of care of other platinum-based chemotherapy like liposomal doxorubicin or topotecan plus or minus bevacizumab will work for this group of patients. But I think in the future, maybe probably combining PARP inhibitors in the chemotherapy, it may be the solution for this to combine both together. And I think we have data from the vilaparib plus chemotherapy, but that was in front line. Maybe if we have such data in the subsequent line, it may solve this problem.
I think as a strategy is tried adding immunotherapy as well, but I think it hasn't been so impressive. That's why I don't think there is more development of IO plus PARP inhibition. It's been tried in other cancers, but I think in ovarian it has not been as expected. I don't know if you've seen any data on that.
Yeah, I agree with you that ovarian cancer is not that immunogenic disease, and immunotherapy, unfortunately, it failed to show any efficacy in this group of patients. Apart from those with the MSI high or high tumor mutational burden, we are not using the immunotherapy in this group of patients. So sometimes we are doing the mismatch repair or MS high, or doing NGS and found that patient has high tumor mutational burden, and we tried the pembrolizumab in those patients. But to be honest, our experience, the drug does not show that impressive outcome, especially in ovarian cancer. Probably in other diseases such endometrial cancer, we have very successful other story. In ovarian cancer, it's not that immunogenic disease.
No, I agree. I think the most impressive data we've seen so far is the folate receptor antagonist. Actually, I was a PI when I was in the US on one of those small trials, but it's yet to be approved. But I think stay tuned. I hear it maybe get approval soon, the folate receptor antagonist, mirvetuximab.
Yeah.
So I think, do you have more questions, or? I think with that, we can end. And Dr. Hassan Jaffer.
Thank you.
Thank you, Ahmed. We'll move to the next session, and I'm delighted to present Dr. Michael Frumovitz. He's a professor of Department of Gynecology in MD Anderson, Houston, Texas. After he graduated from MD Anderson Gynecology, Dr. Michael, he had advanced laparoscopic training for the treatment of gynecological malignancy, which is conducting in different gynecological malignancies, cervical, endometrial, and early ovarian cancer. Also, he pursued lymphatic mapping for this gynecological malignancy. He was also invited in many writing books, chapters, and review articles in a variety of gynecological malignancy. He's very active in publishing, and he's probably the best to present the fertility sparing approach in gynecological malignancy. Not further ado, so please welcome Dr. Michael.
Good afternoon. Thank you again for the invitation to speak. I had the honor of speaking last year. I was hoping this year I would be able to actually come to Dubai in person, but unfortunately, maybe we'll have to wait till next year. So I'm going to speak about fertility-sparing therapies in gynecologic oncology. And just to make sure that we're clear on the terms, you know, oncofertility refers to essentially the reproductive endocrinologist approach to fertility in cancer patients. So harvesting eggs, freezing embryos, IVF, and things like that. When we talk about fertility-sparing therapies from a gynecologic oncologist point of view, we're talking about what are the things we can do in the initial treatment of the cancer that would potentially spare fertility. So either retaining ovaries, retaining uterus, or hopefully retaining both. Why is this becoming important? Well, it's becoming important because women are delaying childbearing, and we know the direct relationship between cancer and age. So as women are waiting later in their life to have children, they're becoming more and more at risk for cancer. If you look at in North America and Europe, you can see here between 1970 and 2006 across all of the countries, there's been an increase in age at first pregnancy. So in the U.S. in 1970, it was 21 years of age when women were having their first pregnancy, but by 2006, it was 25. You can see, particularly across Europe and even Japan, women are even close to 30 before they're having their first children. If you look at the change, so that's the age at first pregnancy, but you can look at the change also when women are having children in general. So from 1990 to 2000, there was a 31% increase in women having kids between the ages of 35 and 39. And between the ages of 40 and 45, a 51% increase in women having kids. And if you look between 2000 and 2014, in that 35 to 39 group, there was an additional 23% increase. So again, women are delaying childbearing. And again, that means we are running into that risk as women are kind of finishing childbearing. We're seeing more and more cancers because they're entering that age range where we start to see gynecologic cancers. So when we think about fertility-sparing therapies, obviously it's kind of the big three GYN cancers that we look at: ovarian cancer, uterine cancer, and cervical cancer. For borderline tumors, sex cord stromal tumors, and germ cell tumors, it's already well established that if the other ovary looks normal, you can certainly leave the contralateral ovary as well as the uterus, and patients will do very well. And in fact, for germ cell tumors, even if there's tumor on the other ovary, you can leave that ovary because these tumors are so sensitive to chemotherapy that you can often achieve a cure, even if you leave gross disease on the contralateral ovary. And remember, for germ cell tumors, these are often girls in their teenage years or early 20s. So it's really important to not just reflexively take out both ovaries because there's tumor on it. For early stage invasive cancer or epithelial ovarian cancers, traditionally that's been, you got to take out both ovaries and the uterus. But now more and more data are showing that for disease that looks like it's that it's limited grossly or intraoperatively to one ovary, we can probably spare the other ovary and uterus. So let's talk about ovarian cancer. And when you see EOC, what we're talking about there is epithelial ovarian cancer. So serous cancers, mucinous ovarian cancers, endometrioid cancers, clear cell cancers. So in the US, there'll be 21,000 new cases this year, 13 or almost 14,000 deaths. But about 10 to 15% of these cancers are occurring in women who are under the age of 40. So in that group where we might think about sparing fertility. Remember that when cancers are found as stage 1, they have an excellent prognosis. So remember, stage 1 is limited to one ovary. However, unfortunately, less than 10% of patients will be stage 1 at diagnosis. But again, about 10% of those who are stage 1 will be under the age of 35. This was one of the first studies to look at fertility preservation in young women with epithelial ovarian cancer. So this was a study that looked at the SEER database. For those who aren't familiar with the SEER database is a nationwide database in the United States that basically accounts for about 25 to 30% of all patients in the country. And there's about 12 or 15 kind of SEER centers around. So this study looked at women under the age of 50 who had stage 1 epithelial ovarian cancer. And they compared women who had both ovaries moved, bilateral saphengoophorectomy, to those who had only one ovary removed. And then they also looked at women who had a hysterectomy as part of the surgery compared to those who didn't have a hysterectomy. You can see here that the survival curves for stage 1A and 1C cancers were essentially the same, whether they had one ovary, just the affected ovary taken out, or both ovaries taken out. Same for hysterectomy. So actually the dotted line is preservation of the uterus. So you can see here for stage 1A and 1C, leaving the uterus behind when there was no gross disease found on it, did not seem to change oncologic outcome. Sometimes I like to say that the uterus is sometimes guilty by association because it's near the ovaries. Sometimes we reflexively take it out, but it's really a different organ and there's no reason that it needs to come out. Just like you wouldn't take out the sigmoid colon, which sits right by the ovaries, if there was no disease on the ovary, on the sigmoid colon. So if you look at this study, the 5-year overall survival rate for those who had ovarian preservation was equivalent to those who had bilateral oophorectomy, and the same for those who had uterine preservation versus hysterectomy. A more recent study looked at both the SEER database and the National Cancer Database. The National Cancer Database is another nationwide study that's run through the American College of Surgeons. And they looked at patients who had what they called fertility-sparing surgery. And fertility-sparing surgery was defined as either unilateral saphengoophorectomy or uterine preservation. And they limited the group to under the age of 45. What this study did is it broke it up by high-risk subtypes. So you can see here no difference in the SEER database when you have basically fertility-sparing surgery compared to bilateral saphengoophorectomy and hysterectomy for all of the high-risk subtypes. And the National Cancer Database also similarly no difference in survival. So it seems like if we have disease limited to one ovary, the other ovary looks normal and there's no evidence of metastatic disease, sparing the contralateral ovary and the uterus are safe. What I tell patients is, my young patients who have an ovarian mass, I said, we're going to take out that one ovary and we're then going to wait for the pathologist to tell us what it is and make a decision. And I said, and I say, even if I think the other ovary should come out, I'm probably going to leave it because we can always go back at a second surgery and take out that other ovary uterus as we need to, but we can never put it back in. So I always err on the side of caution with these young patients and really just typically remove one ovary and leave the other ovary and uterus until I know for sure. Again, I can get a frozen section during the surgery, but those are not always with certainty. So I know for sure what we're dealing with. Now, is it important to spare fertility in these patients? In other words, if you're sparing fertility, are these women actually A, wanting to go on and get pregnant, and B, are they able to get pregnant? And you can see here, this is a study from Europe that looked at 52 patients from 8 sites who had stage 1A or 1C epithelial ovarian cancer. They were all under the age of 40. For these who had their fertility preserved, there was a very high overall survival. You can see here, 24 of them attempted pregnancy, and 71% were able to achieve pregnancy. So they A, want to get pregnant, and B, are able to get pregnant. And most importantly, most of these patients will have had chemotherapy. There's no reason to believe that chemotherapy will have any long-term effects with congenital anomalies, but this was just a study that showed that there were no congenital anomalies. Well, how about uterine cancer? How can we treat uterine cancer, a cancer of the uterus, and still maintain fertility? Well, again, just to give you the demographics, 67,000 new cases, 13,000 deaths. Remember, at least in the United States, we have an obesity epidemic where over almost 2/3 of our population is either overweight or obese. And because of the direct relationship between obesity and uterine cancer, we're seeing more and more uterine cancer, and we're seeing it in younger and younger women. So 15% of our uterine cancers are in premenopausal women, and 4% will occur in women less than 40. So originally, we looked at high dose of oral progestational agents as a way to manage, essentially as a non-surgical approach to uterine cancer. You can use either medroxyprogesterone acetate or Megase. This was a study that we did at MD Anderson looking at the literature and looking at oral progesterones for grade 1 cancers. You can see that there's a 55% who will achieve a long-term cure, 25% progress on therapy, and then 20% initially respond, but then are destined to recur. The important thing is, I think, that last bullet, which is that no patients had extrauterine disease in the progressions or recurrence. In other words, if your initial workup is negative for metastatic disease, you can try conservative management with a progestational agent. And if the patient progresses, it's unlikely that they're going to be upstaged. In other words, it's not like a patient has stage 1, you try them on a progestational agent, and all of a sudden they develop a stage 4 cancer, and they've gone from something that was potentially curable with the surgery to something that's now incurable. We very, very rarely, if ever, see that. So again, in this study that reviewed oral progesterones for grade 1 cancers, 20 patients were able to achieve pregnancy. 12 of them required some sort of reproductive assistance. So from our reproductive endocrinologists, either IUI or IVF. You can see those 20 patients had 29 infant deliveries. So again, if you can spare fertility in these patients, A, they're able to get pregnant, and B, they want to get pregnant. Well, oral therapies can be pretty tough for patients. You know, first of all, these patients tend to be overweight and obese to begin with. That was their risk factor for getting cancer. And now we're giving them a medication which is a very, very active stimulant of the appetite. So just when we want patients to lose weight to reduce that risk of cancer, we're giving them something that almost invariably increases their weight. The other are issues with compliance. You know, taking a pill 4 times a day or twice a day can be difficult. And then again, there's a risk of VTE and pulmonary embolism. Again, they already have a baseline risk because of their BMI. So we've really moved to treating patients with more localized therapy, and that's with essentially a progesterone-releasing IUD. So this was a retrospective study from our group at MD Anderson that looked at 32 patients who had a Mirena IUD placed into the uterus. And you can see here, you know, again, they talk about overall response rate and partial response rate, but really the partial responses are really not important, right? A partial response doesn't say you can stop treating them. It doesn't say that they're not going to need to go on to a hysterectomy. You know, they can't get pregnant. So really we're looking at the complete response rates. You can see, at least in this retrospective study, patients with complex atypical hyperplasia had a 73% response rate with the Mirena IUD. And if you look at the grade 1 cancers, you know, 25 to 40%, at least in this retrospective study. Well, that retrospective study led us to then do a prospective study with the Mirena IUD. Here are the results. They were just published recently. And you can see here again, I'm highlighting the complete response rate. You can see in this prospective study, 90% complete response rate for the Mirena IUD in complex atypical hyperplasia, and over 50% for grade 1 endometrial cancers. So really, you know, you need to have progesterone and estrogen receptors present for this to work. And the grade 2 and the grade 3 endometrial cancers tend to have very low receptor status. So they're really not good candidates. So the patients who are good candidates for this are obviously wanting to retain fertility, grade 1 cancers, and those who are going to be compliant, because you do an endometrial biopsy every 3 months for patients who are on this. We give patients 6 to 9 months. If they've not resolved their endometrial cancer in 6 to 9 months, we then say that essentially it's time to go on to hysterectomy. But they need to be very compliant so that they come back in for their every 3-month biopsy. So that's what the NCCN guidelines now include. Again, well-differentiated grade 1 cancers, consultation with a reproductive endocrinologist first to make sure that there aren't any fertility issues. And then you can give either oral or Mirena IUD or other progesterone-eluting IUDs. And then we do a endometrial evaluation every 3 months. The NCCN says every 6 months, but really 3 months is probably the safest thing to do. So we do that in the office. We don't take them to the operating room. It's very easy to do a Pipel endometrial biopsy around the IUD. So you can see over the last, over the last few years, more and more women are attempting this. So if you look at the blue lines, really is what we're looking at is those women who are reproductive age and who are trying some sort of progesterone agent. Again, this is a database study, and you can see that over the years, those blue lines have gone up to now almost 20% of women who are reproductive age are having an attempt at fertility-sparing surgery. Fertility-sparing therapy with a IUD. And then again, women are able to get pregnant afterwards. You can see here the patients who just got the progesterone alone. There was 92 patients out of 421 who got pregnant. Of those, 49 of the 92 experienced a live birth. So the overall is 49 out of 421, which is about a 12% live birth. Again, the majority of women did not attempt to get pregnant. What about ovarian preservation? So let's say you have a grade 2 or a grade 3 endometrial cancer, so you can't really spare the uterus. Can you spare the ovaries and then go back, retrieve oocytes, and then maybe use a gestational carrier? The answer is yes, you can do that. Again, these are the patients who had uterine cancer, who had a hysterectomy, but their ovaries left in place. And I'll tell you, for even my patients now who are under the age of 45, who have uterine cancer and no obvious disease spread, and we're talking about adenocarcinomas, so we're not talking about serous carcinomas or carcinosarcomas, but for those patients who have adenocarcinomas who are under the age of 45, who have to have a hysterectomy, I'm leaving their ovaries in, not so much for fertility, but just for quality of life and to keep them from going into menopause. A related issue that I just like to touch on, because I think it's something that a lot of people are worried about in women with endometrial cancers. Can you give these patients hormone replacement therapy? So a lot of these women are young. You're putting them into surgical menopause, which can be very, very difficult. Can you give them estrogen therapy back? The theory is, potentially, are you stimulating a uterine cancer by giving them estrogen back? Well, the GOG did a phase 3 study with about 1,200 patients. You can see here, there was no difference in recurrence in those who got placebo versus those who got estrogen replacement therapy. So 95% or so were alive without evidence of disease. There was about 1.3 to 1.5 recurrence. And then, the total deaths were about 4% from uterine cancer. So again, very equal in both groups. I am very, very comfortable giving estrogen replacement, for a limited time to my premenopausal patients who have surgical menopause and who are really not tolerating the menopausal symptoms very well. I'll try first with some non-hormonal agents such as SSRIs, but really I have a very low threshold to give them some estrogen replacement back because it's very, very good for the quality of life, and it is oncologically safe. Okay, so finally, let's look at cervical cancer. Really, the standard of care is radical trachelectomy. Again, in the United States, 15,000 cases, 4,300 deaths. Worldwide, it's a much larger problem due to lack of screening. We're hoping now with HPV vaccines that we really see this number come down worldwide. Remember that cervical cancer typically is a disease of younger women because of the HPV relationship. So women get exposed to HPV in their late teens, early 20s. It takes 10 to 15 years from that HPV infection to develop into a cancer. And so we see a lot of women in their 35 to 40 range getting this cancer. So for those of you who aren't familiar with the radical trachelectomy, a radical trachelectomy is essentially very similar to a radical hysterectomy, but instead of removing the fundus of the uterus along with the cervix, you can see on the photo, the drawing on the right, we essentially cut across the cervix because the tumor is way out here. So we're able to cut across the cervix. We then put in a cerclage, and then re-anastomose, because the cervix is short, so it's going to be a little weak. So when they do get pregnant, they're at risk for preterm delivery. And then we re-anastomose or reconnect the cervical stump to the top of the vagina. They're very kind of strict criteria for who are candidates for this. Marie Plant and Michelle Waugh really defined it in the late 90s. Essentially, it's patients who desire to preserve fertility, have 1A2 or 1B1 disease, which are tumors less than 2 centimeters in size. There needs to be limited endocervical involvement because we really need to find a good margin between, where the tumor ends in the endocervix and where we can come across the endocervix. There needs to be no evidence of metastatic disease, and this is really only for patients with squamous or adenocarcinomas. Patients with rare subtypes like neuroendocrine cancers are not candidates for this. It can be done vaginally or abdominally, although we favor the abdominal approach, and the overall recurrence rate is quite low, 4%. It's about the same as what we would expect in these patients after a radical hysterectomy for similar sized tumors. You can see here that there's good pregnancy outcomes. For those patients who get pregnant, about 70% will make it to more than 32 weeks. So there is a slight increase in preterm delivery. But again, most patients are getting to 32 weeks where you're going to have a healthy, viable baby. In the GYN oncology community, what we've really started to think about is a radical trachelectomy really something that needs to be done. Can we do something less? Do we need to do such a radical surgery? If you look at the radical trachelectomy, the radical part of the radical trachelectomy is this part that I just showed you on the right, and that's removing the parametrium. So removing the parametrium is what makes this a radical procedure. But removing the parametrium is what is the biggest risk of during the surgery. So you can see here, about 16% of patients will have some sort of postoperative complication, mostly based on that radical part of the surgery. So can we do less? Well, we think so because it's very easy to identify a group of patients who are at very, very low risk for parametrial involvement. So you can see here, this is a study our group did at MD Anderson that basically looked at patients who had a radical hysterectomy. 8% of them did have parametrial involvement, so we were very glad that we did the radical part for that 8%. But in 125 patients out of those 350 patients, we were able to identify a group of patients who had no parametrial involvement. And so if the tumor was less than 2 centimeters, if there was no lymphovascular space invasion, and if it was a squamous or adenocarcinoma, in those patients, and there were 125 of them out of the 350, so about a third of them meet this criteria, there was no parametrial involvement. And if you look at the literature, there are lots of other studies that have found patients who are at low risk for parametrial involvement. And essentially, it's small tumors less than 2 centimeters, invading less than 10 millimeters, no LVSI. Those groups, they're very, very likely to have parametrial involvement. And so those are patients who we can safely probably omit the parametrectomy. So there are lots of retrospective studies that have looked at conservative management. So essentially cone biopsy, simple trachelectomy. A simple trachelectomy is just a big cone biopsy, or a simple hysterectomy to replace radical surgery. You can see here, I put the table at the top, but really summarizing the table is that in the literature, there were 250 patients who had this conservative therapy. About 5% had positive nodes, so you can't abandon the lymphadenectomy, so you need to do some sort of lymph node assessment. But the recurrence rate in those patients who are lymph node negative was very, very low, less than 1%, and the death rate was less than 0.5%. And you can see here again, of those 250 patients, there are lots of patients who want to get pregnant and who do go on to get pregnant. So the rationale and these data have led to 3 prospective studies that are looking at conservative surgery, so less radical surgery for patients with early stage cervix cancer. So there's the SHAPE study, which is being run through the NCIC and the GCIC, which is being run by Marie Plant. Al Covens has GOG278, and Kathleen Schmaler at MD Anderson has run the CONSERVE study. And basically all 3 studies essentially look at conservative therapy for stage 1A2 and 1B1 tumors that are adeno or squamous carcinomas. All of them are allowing either a cone biopsy and lymph nodes or a simple hysterectomy and lymph nodes. The CONSERVE study is the first to finish. And the CONSERVE study was a straight phase 2 study. So all 100 patients essentially had either a simple hysterectomy and nodes or cone biopsy and nodes. Again, the nodal part of the nodal assessment is important. Even though these are low risk patients, about 5% will have lymph node metastases. So you still need to do lymph nodes. You can see here, the recurrence rate to date is about 4%, exactly the number that I showed you for a radical trachelectomy, exactly what we would expect for radical hysterectomy. You know, my overwhelming sense is that in the next 5 years, this will become standard of care as the SHAPE study and GOG 278 finish and report. So just to summarize, for ovarian cancer, you can conserve the unaffected ovary and uterus in well-staged stage 1 epithelial ovarian cancer patients. For sex cord stromal tumors, we can preserve if the other ovary is grossly normal. And I mentioned for germ cell tumors, even if there's disease on the other ovary, you can preserve that ovary, treat them with chemotherapy, and those girls are going to do very, very well. For endometrial cancer, patients can have a trial of hormonal therapy with high-dose progesterone, although we favor a progestational IUD. Really, it's for grade 1 cancers, not grade 2 or grade 3. Remember, you got to follow with biopsies every 3 months, and then perform a hysterectomy for progressive or unresponsive disease. We define unresponsive disease as 9 months, 6 to 9 months, depending on your level of risk. And finally, for cervix cancer, the radical trachelectomy is the standard of care. We can also try, we also think that there'll be, in the next few years, a push for less radical surgery, either simple hysterectomy for those who don't desire fertility sparing, or cone biopsy for those who do desire fertility sparing. And remember, you still need to assess. Well, thank you again for the invitation. Like I said, I was hoping to be there in person this year. Maybe in 2022, we'll be able to get together in person. And again, thank you for the opportunity to speak with you all.
Thank you very much, Professor Michael, for this very elegant presentation and good cover for the fertility preservation surgery. So the floor will open for questions. I have a question. What consideration you take for those, especially for the ovarian cancer with germline mutation? So is there any special consideration for those patients? And the second question, for a long-term plan, do you do and go back to the optimal surgery or the standard surgery after the pregnancy, or you consider this is the optimal surgery and you keep those patients because the treatment tailored for the early stage?
Those are great questions. And actually, so the first one I think is a fairly straightforward answer. The second one's a little trickier. So for patients who have a germline BRCA, it's probably not a great idea to have any sort of fertility sparing surgery. Now you can leave the uterus, even though there are a slightly increased risk of uterine cancer, but I would not leave the contralateral ovary. You know, we're recommending, prophylactic oophorectomy in women age 40 for most BRCA, 40 to 45 for BRCA anyway. And so, really, for BRCA patients, that's someone who I would probably consider not leaving the contralateral ovary. The second question of, do you go back and do completion surgery after childbearing is done is a little tougher. And I think a lot of that depends on the patient's, desire. And a lot of it also depends on when they are done with childbearing. So if someone has, say, a uterine cancer, you're able to get them into complete remission. They immediately go out and get pregnant, and then they say, okay, I'm done. And you say, okay, and you then, for that, someone who I might then, go back and do a hysterectomy. If you get someone, say, with uterine cancer in a complete remission, and 10 years later, she has a baby, and then, and she's lost a lot of weight, and, nothing has come back in that 10-year period, for that patient, I may say, well, we can kind of watch you and see what happened. Remember, a lot of these patients are morbidly obese, and so, not doing surgery is not only a fertility sparing option, but it's also probably a good option because of the surgical complications or surgical risks that these patients have. For cervix cancer, I'm less likely to go back and do completion surgery. You know, those cancers, if they're going to recur, are typically going to recur in 2 or 3 years. If women get to be, you know, 5, 7 years out, at that point, I'm less likely to go back and do any completion surgery. The other thing with cervix cancer is we have a very good way to kind of watch and observe. Almost always these cancers are going to have a pre-malignant state that we can then treat definitively.
Thank you. Is there any further questions from the floor? By this, we finish this session, and thank you very much, and we hope to see you next year.
Thank you. I hope to be there next.
Now, I'm delighted to move to the next session, and I'll present Professor Hamid Shamsi. He's double-boarded in oncology from Canada and MD Anderson. He worked for 2 years in the GI as a consultant medical oncology, and he joined Burjeel. He's the director of oncology there. He's also a professor in Sharjah teaching, and I think he has his fingerprints in the publication in UAE. I think he had a lot of movement, and also he's the president of the Oncology Society, and I think all this activity and achievement is related to his effort and energy. So please welcome Dr. Hamid.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. Hassan, for your very kind introduction. And it's all about actually the team and the EOS family, and it's not only one-man show here. So thank you everybody for being here till late, and thank you for staying with us. So this talk is sponsored by Epson, and I'll be talking about an update about the neuroendocrine tumor. I'll be focusing a little bit more on the somatostatin analog treatment, but also I'm going to present some data which has not been published before, some of the research we did about the neuroendocrine tumor in this field. So this is my disclosure. So I'll first outline the burden of the neuroendocrine tumor based on the survey that we did last year among the oncologists in UAE. Then also I will highlight some neuroendocrine tumor clinical pathological features which was done at Tawam Hospital during my time with our colleagues, Dr. Aidil Awadi and Mr. Khalid Al-Qawasma. And then I'll also highlight the update in the neuroendocrine tumor management. And lastly, if I have time, I will also discuss the recommendation for completely resected GEP tumor, since there's no agreed recommendation how to manage or to follow these patients. So neuroendocrine tumor, as we know, they arise from epithelial endocrine cells distributed throughout the digestive tract, and they used to be called carcinoid tumors, and they frequently express somatostatin receptors. We did a survey last year. I'm going to share this again. I think I shared this last year, and I'm going to share it again since we didn't get the chance to publish them. So what we did actually, we sent a survey among oncologists in the country, and 45 oncologists and surgical oncologists, they responded to the survey. So we do have that around 72% out of the 45 are medical oncologists and 3 surgeons. So the question was regarding if you are actively treating a neuroendocrine tumor, and 72% said yes at that time. And when we look at the number of cases per year they experience, most of the oncologists actually, they have around 5 to 6 cases per year, which is actually what we do see in the practice. Few had more than 12 or 15, and this is most likely because they're practicing in high volume centers. When we look at the most common type of cancer of the neuroendocrine tumor, mostly GI, followed by lung, and this is again, in keeping with what we see in practice and reported in the literature. What's interesting actually is regarding the most common gastroesophageal, gastroenteric, pancreatic neuroendocrine tumors. It was reported that mostly are pancreas, followed by stomach, and followed also by small intestine and appendix, which is really maybe not what has been reported. We know that most, neuroendocrine tumor are mostly in the appendix and also small intestine, but mostly the rectum and the stomach, most likely not seen by the oncologist, because they are mostly surgery and the GI physicians are treating these patients, and most likely are not referred once they're diagnosed. When we look at the need for more education, when we ask the oncologists, certainly there's a need for education for the GPs regarding this disease, with 95% agrees with this statement. When we look at the percentage of patients who had stage 4 at the time of diagnosis, and 50% or even more, actually more physicians, they believe that patients are being diagnosed in advanced cancer. So imaging modality mostly used in patients with the neuroendocrine tumor. 29% reported to have a PET scan and scan. Octreotide scan also around 24% in practice. Chromogranin A and 5-HIAA are mostly also used by physicians at the time of the routine workup of these patients. So number of patients with neuroendocrine tumor in your practice, that they are increasing over time, and around 37% they were not sure, but half of the physicians agree that we're seeing more and more neuroendocrine tumor cases over the last decades or so. So what about the dedicated neuroendocrine tumor availability? And 81% reported that they didn't have any access to MDT that specialize in neuroendocrine tumor. And maybe this is something that we have to consider as a society and also as a team as well, that maybe we need to have some sort of international collaboration to improve the care of our patient with neuroendocrine tumor. So what about the experience with PRRT? Most physicians actually, they didn't have experience. Again, this modality was not available in the country, so I don't expect many oncologists, they have experience with it. And 26% they have fair experience, and around 90% they have no experience. So this is another room also for improvement of educational activities for oncologists providing care for neuroendocrine tumor patients. Moving now to epidemiology of neuroendocrine tumor, and this is a study by myself, Dr. Aida, and Mr. Khalid Khawasma. Thank you for the support, and hopefully, inshallah, we'll work to publish this soon. What we did, this is the first study in the region regarding neuroendocrine tumor, and it was approved by Tawam Hospital during my time there. It was a retrospective single center study over 5 years period, and the primary objective was to understand the clinical pathological features of patients with a neuroendocrine tumor in our country. So we identified 149 patients based on the ICD score 9, ICD code 9 and 10, and we analyzed this data, and we found that 65% of these patients, of let's say 150 to make it simple, 150 patients were males, and 20% were locals, and also 20% were from Middle Eastern and other Asian countries, and Europeans were also there. Other countries, actually, there were a significant number of Filipino nationalities, which is something maybe interesting to see and also to analyze in the future as well. The frequency of, the past medical history, most of the patients, they had no past medical history at the time of the diagnosis. They had other comorbidities, including diabetes, which was around 40% of the population during the study time. Age diagnosis was distributed between early 20s all the way to 80s, but if we see that most patients were between the age of 55 to 65. And when we look at the symptoms, abdominal pain was one of the most common symptoms actually in the patients who were diagnosed with a neuroendocrine tumor. So this is something, again, we have to keep in mind during the differential diagnosis and educate our GPs and gastroenterologists to keep this in mind when they're evaluating patients with abdominal pain without any clear underlying diagnosis. What about the primary site of disease? GI, non-pancreas, was around 65%, followed by lung, followed by pancreas, peanut, followed by gynae and uterus and cervical, or let's call them gynecological neuroendocrine tumor. Non-pancreatic GI neuroendocrine tumor, mostly as we expect, small intestine, followed by gastric, followed by appendix and rectal. When we look at the localization, 68% of these patients actually, they had metastatic disease at the time of diagnosis. Again, this is compatible with the reported data from international studies as well. When we look at the metastatic disease, not surprising, most of these patients, they have metastatic into the liver, which is the most common site for metastatic disease in patients with a neuroendocrine tumor. When we look at if the patient received any surgery at time diagnosis, there were 46% of patients they did receive primary tumor resection, and 7% they received primary and metastatic resection at the time diagnosis. Only 2% of the patient had second surgery for resection, which is also something we have to consider. Maybe some patients they may benefit from further surgeries down the road if they're eligible, and based on different criteria, which I'm going to mention also during my talk here today. Carcinoid symptoms, there are different symptoms associated with the functional neuroendocrine tumor, including chest pain and diarrhea. Diarrhea was the most common with 14% in all patients. Epigastric pain, also another common symptoms. Chromogranin level was done in 60% of all patients with a neuroendocrine tumor, while urinary 5-HIA was not done much. Actually, only 15% of the patient had the 5-HIA, maybe because of the difficulties with obtaining the test, maybe difficulty also preparation, difficulties collecting the urine over 24 hours. So there are different various factors that may contribute to the lower use of the urinary 5-HIA in diagnosis. So in conclusion, this is the first clinical study in UAE and the other GCC about the neuroendocrine tumor. Most common GI net, small intestine, rectum, appendiceal, and gastric. 60% are males, 60% with the stage 4, mostly in the liver. 46% get surgery at the time of diagnosis, and chromogranin used mostly in the initial workup as well. Moving now to update in the neuroendocrine tumor management, and as we know that the neuroendocrine tumor incidence has been increasing over time. Is it because we are better in diagnosing these cancers, or should we call them cancer or no cancer? This is a different topic. Let's say, are we getting better in diagnosing neuroendocrine tumor, or are we also having better modalities which are helping us to diagnose these neuroendocrine tumor more often? This is still question remains. This is the incidence of neuroendocrine tumor in Ontario, and you can see clearly that the solid line that climbing clearly over time from the 1994 up to 2009 would increase the incidence of the different types of neuroendocrine tumor. So one of the challenges with the neuroendocrine tumor is actually they're not as common that maybe I shouldn't say that, maybe they are not very well recognized. They are usually called zebras, but maybe some other also oncologists practicing in this field, they call them maybe difficulties with the unicorns beside the zebras. They are not very commonly thought about during the workup of these patients, and hence the delay in diagnosis. We're going to look at the result of the first global neuroendocrine tumor survey, where actually a significant number of patients reported seeing more than 5 physicians before being diagnosed. It was actually 48% of this sample that reported they're seeing many physicians over time until they were diagnosed with a neuroendocrine tumor. When we look at the patient being seen by different specialties, we see that patients are seen in the last 2 years mostly by general surgeon, by gastroenterologist, and also by family physician. If you look at the bar there, that your family physician, there are a significant number of patients that are seen by family physician, but they are not diagnosed because of the difficulties and the vague symptoms that they're having. So 60% reported that their cancer was metastasized at the time of the diagnosis. Again, this is exactly what we see here in UAE. 60% also were diagnosed in advanced cancer as well, and 71% of the respondents in the survey responded that there's a need for improving the understanding of the neuroendocrine tumor, and this is something we have to take actually the ownership of, and we should educate our physicians and GPs and gastroenterologists about how common this disease and how should we keep this in mind when we see patients with different GI symptoms which are not explained. Treatment modalities, I mean, the treatment modality for neuroendocrine tumors is very complex, and because they are not as common as other cancers, maybe sometimes it's difficult to come up with a clear plan for treatment of these patients. As we can see, surgery is part of the treatment modality, somatostatin analogs, PRRT, TACE, also targeted therapies and chemotherapies. All the options are available for patients with the early cancer and and advanced cancer, and that's why MDT for neuroendocrine tumor is very important to come up with the best outcome for these patients. Surgery, again, resection of the primary tumor and cytoreductive surgeries, debulking of the tumor with radio frequency and local regional therapies, medical therapies, which we're going to discuss in details, and also dotatate, lutetium-177 are the options available for patients with different stages of the neuroendocrine tumor. So general principles for management of patients with a neuroendocrine tumor: removal of localized and limited metastatic disease in the absence of the extrahepatic metastasis, diffuse bilobar involvement or compromised lung functions are regionally advised. Advanced diseases, maybe they're also an option to control the hormone secretion, control the tumor growth, and also minimize toxicity of systemic therapy as well. This is actually one of the good reviews that, regarding to do surgery or not for a patient with the liver metastasis from neuroendocrine tumor. It's a meta-analysis which showed that, there's improvement and there's a trend to improvement of survival in patients who goes under surgery, and surgery appears to have survival advantage over observation or local therapy or hepatic arterial therapy. Again, the different modalities of local therapies, including the SIRT, TACE, and hepatic arterial embolization, also has a range of between 40–60% to control the disease in the liver as well. This does not, wow. I didn't realize that this is, okay. So this is just the progress of the GI neuroendocrine tumor over time. We can see that from the 1980s, ceftriaxone was approved by the FDA. Over time also, we see that the sandostatin also has been approved, and lanreotide was also approved, and we have the Sutent and everolimus all approved as options for a patient with a neuroendocrine tumor, including pancreatic and also small intestine and lung as well. Let's look at the PROMET and the CLARIONT trials. We'll start with the PROMET trial, which included patients with a well-differentiated mid-gut neuroendocrine tumor, and octreotide LAR was used at a dose of 30 once a month, and there was improvement in the time to progression in octreotide arm versus placebo. The improvement also was seen with non-functional tumor and also patients with functional tumors. So we can see that both were benefiting from this modality of treatment when compared with the placebo. When we look at the CLARIONT trial, the CLARIONT was a randomized placebo-controlled phase 3 study of lanreotide for tumor control versus placebo. They included patients with non-functional neuroendocrine tumor, and again, this is different than the PROMET. I'm going to compare and contrast the CLARIONT and PROMET later on in my slides, and also they included patients with the pancreas, midgut, hindgut, and also unknown primaries, including the Ki-67 of less than 10%. There was an observation period around 3 to 6 months before the patient were included in the randomization with lanreotide 120 milligram subcut versus placebo 1:1 randomization, and the primary endpoint was progression-free survival. Secondary endpoint included proportion of the patient alive without disease progression at 48 and 96 weeks as well. So the baseline characteristics were similar between the two arms without significant differences between the two groups. Most patients were treatment naive and didn't have any disease progression according to the RECIST criteria 3 to 6 months, as I mentioned in the previous slide, prior to the enrollment. And this is one of the criticism for the study. They were selecting the patient prior to the enrollment in the study, and approximately a third of these patients had G2 neuroendocrine tumor as well. The study also showed that there's significant prolongation of progression-free survival in patients who received lanreotide versus placebo, or again, you can call it watch and wait without any active intervention. And the placebo group in the study may be considered a surrogate for deferred treatment as well. The CLARIONT study showed that there's improved PFS irrespective of the tumor grade, as you can see here, the subgroup analysis, the grade 1, grade 2, and also irrespective of the hepatic tumor volume, less than 25% involvement in the liver versus more than 25% of the liver as well. Sorry. So at 48, so the lanreotide also offers improved PFS over placebo at 48 and 96 weeks of follow-up as well. And the quality of life also showed that patients with more than 50% reduction in chromogranin level from the baseline at the follow-up with the lanreotide compared with the placebo as well. I will skip this slide. So the Clarion study also showed the higher rate of GI adverse event compared with placebo. Again, we're aware of these symptoms: diarrhea, abdominal pain, and also gallstones. Some advocate for screening this patient with the ultrasound prior and surgical intervention. Personally, I didn't do this actually, and maybe it will be good to hear from the others if they consider gallstones evaluation prior to any intervention or starting lanreotide in these patients. So there was a follow-up study called the Clarion Open Label Extension OLE trial, or OLE. And what they did was actually a patient who completed the study with the Clarion trial, they were actually screened, and the patient who had stable disease or who had progressive disease in the placebo arm were enrolled, and they were given, it was a single arm, non-randomized study. They were starting this patient on lanreotide, and they were followed over time to see what's the safety and also long-term effect of lanreotide in this population. So of the 89 patients enrolled in the OLE trial, 42 continued to be on lanreotide, and 47 patients switched from placebo to lanreotide. And most of the patients were switched from placebo actually were pancreatic cancer, pancreatic neuroendocrine tumor switched to the lanreotide. So there was a higher patient experienced progressive disease, and placebo had pancreatic neuroendocrine tumor than other patient group. Patients also continued to be in lanreotide, report fewer side effects during the OLE study than during the core study, which is also an interesting observation, 26% versus 40% in the lanreotide study. And the lanreotide continuation efficacy data consistent with the continued anti-tumor efficacy even beyond the 96 weeks of the follow-up for this patient. What's interesting was actually patient with the median PFS was longer in patient with a neuroendocrine tumor of the midgut comparing with the PNET. Median overall survival was not reached at the time of the reporting of the OLE trial, and this continues to be positive. So how do you compare the PROMED versus Clarion trial? I mean, one of the questions that I'm going to anticipate is which one do you prefer? I'm going to leave this for you to answer, and Dr. Hassan Ghazal is laughing, so I'm not going to answer that question for you. You can answer that question. I'm going to just compare the two studies for you. This is actually the timeline between the PROMED trial versus the Clarion trial. PROMED was done early in the 2000s versus the Clarion was done later on. The studies, the PROMED was published in JCO, the other one published in the New England Journal of Medicine. Now 84 patients with the midgut versus 204 patients with enteropancreatic neuroendocrine tumor. The octreotide was given 30 octreotide LAR versus lanreotide 120, included patient Ki-67 of less than 3% in the PROMED trial versus less than 11% in the lanreotide Clarion trial. This is again the comparison between the two studies. I would like to draw your attention that the primary endpoint was different between the trials, so really it's difficult to compare these studies together. The time to progression was the primary endpoint in the PROMED trial versus the Clarion trial, progression-free survival. Ki-67 used in the PROMED trial was less than 2% versus the Clarion trial was more liberal, using less than 10%. Again, liver involvement was higher in patients with the Clarion study, with patient of more than 25%. Up to 39% of the patient involved, included in this trial. Again, PROMED was mostly small bowel versus Clarion enteropancreatic trial, the primary endpoint TTP was 42 weeks in the PROMED versus 33 weeks in the other study, the Clarion trial. So question to be answered, we don't have the answer for them, is regarding the role of the SSA beyond progression. Should we continue them? Should we stop them? I personally continue this treatment as long as possible as the patient, even when we use other modalities of the treatment. Dose escalation also another question. Should we increase the dose from 30 sandostatin LAR to 60? Should we switch from sandostatin to lanreotide? All these questions, I don't think there is any clear answer for them, but definitely will be worthwhile, discussing these different different modalities. The radiolabeled somatostatin dotatate is 177 is another modality which has been growing. It has been actually used mainly in Europe for a long period of time. It has been lately approved in the US in 2019, I believe, and this showed around stable disease of up to 35% in patients with the heavy involvement of their disease. As you can see an example here, patient with liver metastasis with good response to treatment in this example. The NETTER-1 trial includes patient progressive mid-gut neuroendocrine tumor, despite the patient being on octreotide LAR 30 milligram, arm 1 PRRT versus octreotide, and the study, as you can see, was clearly, in favor of the PRRT when it comes to progression-free survival. There was 72% reduction in the risk of disease progression, and estimated median PFS in the lutetium dotatate was 14 months. And again, this is the study which was published in the England Journal of Medicine. I think it was 2017, sorry, 2017, not 2019. Radiant-4 is everolimus, an advanced non-functional neuroendocrine tumor by Dr. James Ho. Actually, he was our head of department at the GI Medical. He's still actually at MD Anderson GI Medical Oncology Department. Radiant-4 assessed patient using everolimus, an advanced non-functional neuroendocrine tumor versus placebo, and the study showed that the use of everolimus 10 milligram versus placebo was significant improvement progression-free survival over placebo, with the 52% reduction the relative risk of progression or death with everolimus versus placebo. I mean, we know the side effects with the everolimus, which we use heavily in patients with breast cancer, with the stomatitis and rash and diarrhea as well. We know how to manage them. Another modality treatment for patients with pancreatic neuroendocrine tumor is a Sutent, and this again shows progression-free survival and improvement in overall survival when compared to the placebo as well. Temozolomide plus or minus capecitabine is a study which was completed but not reported fully. I believe it was only reported, to the best of my knowledge, in abstract form, the E2211 study, temozolomide versus temozolomide plus capecitabine in patients with a progressive G1, G2 metastatic pancreatic neuroendocrine tumor. And there was improvement in the temozolomide capecitabine, the time for diagnosis. The progression-free survival was improved in the combination versus the single agent temozolomide, which is actually something that we use a lot in the setting of this disease. And this again, the overall survival also shows superiority of the combination versus the single agent temozolomide. I'm going to skip this. This is just the summary of the approved FDA for PNET, including everolimus, Sutent, and lanreotide, everolimus, and also the FDA approval for Luthera in 2018 as well for the neuroendocrine tumors. So lastly, I'm just going to spend just a few minutes to talk about the follow-up for patients with the resected neuroendocrine tumor. This is again an area of questions, and this study by Dr. Simran Singh from Ontario in Canada, where he assessed the follow-up recommendation for completely resected gastropancreatic neuroendocrine tumor. And this is the study which was published in JAMA Literature Review, showed clearly there's a huge variation between the practices. Most physicians, they do follow up patients closely every 6 months. You can see the purple line here, 62%, they do 6 monthly follow-up in the first 2 years. But as you can see, in the more than 5 years, the follow-up is minimal for this patient. And their recommendation here was to do a follow-up up to 10 years for these patients. Sorry, just... Yeah, this is a summary for all the current recommendation from NCCN guidelines, the ENETs, ISMO, and also the common nets regarding how should you follow up with this patient. At least for the first 2 years, you should be doing some form of screening depending on the type of the cancer for the first 2 years, every 6 months, and then you should follow up with this patient up to every 1 or 2 years, up to 10 years. So in summary, patients with neuroendocrine tumor actually they require multidisciplinary team approach, requiring all these subspecialties, and certainly that there's a much need in the country for such service. We understand that the numbers are maybe small, maybe collaboration with other entities and international experts in this field would be very, very beneficial for our patients. And I think the way forward is to establish GCC net, collaboration regarding research, increasing awareness, and also collaborate with the neuroendocrine tumor research foundations like ENITS and others, trying to improve our understanding and also collaboration and research in this area. Thank you so much for your attention.
Thank you very much, Dr. Ahmed, for this very nice and hard cover for the neuroendocrine from epidemiology as well as the review of the management of those patients. So I think the first question you already asked yourself, so can you answer it?
Regarding, there were many questions.
Who you select, you go for sandostatin LAR versus liraglutide?
I think with the current data, I think when I have a question like this or different options, I look at the clinical trial. The clinical trial actually, I mean, if the patient has, a Ki-67 of 8 or 9, I'll be leaning more toward, the lanreotide. If the patient has a heavy liver involvement, I'll be also leaning more toward the lanreotide. Again, this is sponsored talk, so I do want to say lanreotide is superior, but I think the options always go to the inclusion criteria, look at the clinical trial, look at the option that, you have that, for the outcome. Are you looking for the time to progression? Are you looking for PFS? And then you can answer the question based on the patient profile and clinical pathological features, and based on that you can select the best modality for the patient.
Fair enough. Dr. Hassan.
So I promise I won't make it difficult, but the approval was January 26, 2018. I just got it for you. So my question, when do you add to the sandostatin analog? I mean, you mentioned chemotherapy, you mentioned target therapy. And sometimes we get discordance, you get metastatic disease biopsy where you see a high Ki-67 and then the primary is only 2-3%. So how do you approach when you have discordance?
I mean, I tend to go with the worst Ki-67 available to me. I mean, if there's clear discordance between the different pathologies, I will certainly consider the worst pathology and trying to treat it. Dr. Hassan, what do you think?
And I was going to say, does FDG PET versus dotatate gallium PET give you a clue also in that regard?
Sorry?
The PET scan, the regular FDG versus gallium PET dotatate.
I think it can help you, but certainly I will not ignore, high, Ki-67 high grade degree. If the PET scan also was not really keeping with this, but certainly I will do a full evaluation for the case, and if I believe the patient clinically also progressing fast, I will be leaning more toward the high grade and will treat. But if the patient behaving low grade, and this is only that sample, I may redo biopsy as well just to confirm.
So let me run a case by you. I have an actual case from here who was treated somewhere else, but it's a mess. He's only 40 years old. So he had bleeding and pain in the rectal area, actually, and he was found to have a rectal mass. Biopsy at that time, they read it as signet signet ring, so adenocarcinoma. So, and there was some suspicion in the liver as well, but not very clear in the beginning. So he actually had total neoadjuvant therapy for rectal cancer, like Folfox plus radiation. And then during that time, somebody came back and said, we need to biopsy the liver. And the liver was neuroendocrine tumor with a Ki-67 of 2%. Anyways, so the patient recently had surgery, low anterior resection, and surprise, it was neuroendocrine tumor, but they reported Ki-67 to be over 20% and 3 positive lymph node. So now we are left with the metastatic liver disease. And he had 2 PET scans, one with the FDG, that's why I was asking, and one with the gallium PET. And both of them in different areas were hot. And usually FDG hot in neuroendocrine tumor indicate high grade versus the dotatate where you detect more the lower grade. So how do you approach his treatment at this point? He's still not treated.
In fact, the first thing is I'm going to review everything from scratch with the pathology. I think we all know that there are some challenges with the pathology in some places in the country, and that's why, especially with neuroendocrine tumor sarcomas, I'll be very careful and I will review the pathology very carefully. In this case, patient who was treated with the adenocarcinoma protocol of the rectum and then eventually has metastatic disease, I really think we need to evaluate this again. We know that patients with rectal cancer, neuroendocrine tumor, high grade, they have worse prognosis than average patient. I will certainly consider cisplatin etoposide for this patient, but also we had a recent case with MD Anderson, myself, Dr. Hassan, where they recommended FOLFIRINOX, if you remember that case. So FOLFIRINOX also is another modality. There is no study about it, but I know they are being used more and more in this setting, which will cover the rectum and also the metastatic disease as well for the patient.
And I think it's very important also to differentiate from the small cell variant versus the neuroendocrine, where probably the treatment completely different. And sometimes discussion with the pathology is really very critical to decide what is the line of treatment.
Yeah, I mean, this was reviewed in 2 hospitals. Of course, in retrospect, the initial adenocarcinoma probably was not correct, but they assumed that he has 2 different tumors. And they went ahead and treated his rectum anyway because he was symptomatic. So he has a full local treatment. Actually, on the MRI, I didn't mention that, there was actually a good response to the FOLFOX and radiation. If that gives us any clues, even in the liver, there was partial regression from the FOLFOX.
That's why I mentioned that FOLFIRINOX is being used more and more in patients with the high-grade neuroendocrine tumor. But certainly that, I think evaluation of the entire pathology will be important, and giving the patient more systemic therapy, either cisplatin, etoposide, or FOLFIRINOX will be definitely needed. I think this is an ideal case for MDT, for specialized, team to give an opinion about this case as well.
And PRRT would be an option. That's why I asked you on time.
I will not actually use PRRT in this setting. I'll still try to use some systemic therapy before jumping to the PRRT modality. I'll leave it as an option.
I was glad to see it's available here as well, like you said, at Tawam. It's available in the UAE.
Yes.
And I think especially it is potentially resectable. So if you can aim for complete resection for both, I think it's better.
Unfortunately, he had multiple lobes involved.
Systemic therapy then.
So I think there is another question, especially for the small cell variant, because I see the numbers 150. It's probably it's a much higher number what we see it in a clinical practice. Does that number include the small cell variant? Or it is a purely...
There were many different histologies, but we couldn't actually, break them down because they were the small numbers. But certainly, I'm going to look into that in details. But we'll try to report the grouping of the histologies. So I'm going to look at it, and I will definitely, hopefully, be able to publish this soon, inshallah.
I have another case, a patient with neuroendocrine tumor that he had initially surgery for the pancreas and the liver. And now, after a certain period of time, he's in complete remission. Then he had a local recurrence. We did the PET scan, and then we had a DOTA-DAT scan, and then we saw that there are 2 lesions there. The patient is very reluctant to do the surgery. He went to Cleveland. He joined us, and he also discussed it with his primary physician over there. Such a bridging for this time. Do you go for lanreotide, sandostatin LAR before you do the surgery just to delay the appearance of others, or you go for PPRT?
How big is the tumor, other tumors?
These are 2 small lesions, but because he had previous surgery, from the surgical point of view, one is accessible, it's resectable. The other one, probably they have to do intraoperative radiofrequency ablation.
Is it close to the diaphragm?
It is not that close to the diaphragm.
Yeah, I mean, ideally, as we discussed in my presentation, if you can do surgery, you can convince him. These patients, they tend to do well, especially if the Ki-67 was low to start with. If he doesn't want, local therapy will be reasonable. If he doesn't want, then we'll go for systemic therapy. These are the options, but my preference will be the local therapy.
Yes.
Any?
Yes. Shukran. So I thought I'll stress one issue mentioned, which is DOTA scan is really for low grade, while FDG PET is for high grade. So sometimes when colleagues ask, just bear in mind, so that's one issue. The other issue is that actually I have a patient who has several liver mets bilaterally from already resected pancreatic cancer, and he is in remission, but he has both lobes, and so we've decided to send him for liver transplant. In fact, we reviewed his case with Koreans, and now hopefully he will do this at Vanderbilt University in Tennessee. So just to think out of the box occasionally. One issue is an old treatment for carcinoid specifically, like we used to use a long time ago, is interferon. We had patients who responded for 10 years or so. And in fact, if you have a patient where you have sandostatin not working well and you don't want to throw chemo, you can try to add interferon on top. Lastly, just the name of the study is not clarinet, it's clarinet. It's by the name of musical instrument.
Excuse my English, Doctor.
لا هذا music. But it's like a trumpet, you know. It's that's why they call
regarding
the
transplant actually role in GI cancer is growing. There have been some studies looking at the cholangiocarcinoma, looking at the colon cancer, also liver metastasis. So certainly the role is growing, but certainly it's not really, you know, the option now unless you have very highly selected patients. So thank you, Doctor, for your comments. Much appreciated.
I think by this we finish this symposium. Thank you, Dr. Ahmed, and thank you for Ipsen. And we move to the next presentation.
We have online Dr. Kanan Shimri.
Yeah.
So we're going to now move to the next session. We do have Dr. Kanan Shimri, who's a consultant medical oncologist joining us from Riyadh. Dr. Kanan is a consultant adult medical oncologist who's joining us, and I would like to congratulate Dr. Kanan for the recent success of their Precision Oncology Conference, which was a great success with more than 1,000 attendees. Thank you, Dr. Kanan, for joining us.
Thank you, Professor Ahmed. So I thank you personally. I thank EOS, and I thank the organizers for asking me to moderate the next session. So I'm actually delighted to present the next speaker, who is Dr. Elena Elamova, who is a staff medical oncologist at the Princess Margaret Cancer Center, who I actually had the pleasure of working with briefly during my training in Toronto. So she's also an assistant professor at the Department of Medicine, Division of Medical Oncology at the University of Toronto. Her main disease of interest is gastroesophageal cancers. She did produce some research on GE junction and gastric and esophageal malignancies, and she is heavily involved in clinical trials. So Dr. Elamova, the mic is yours.
Thank you so much. It's a pleasure to be here. And as always, it's really nice to see all of you, actually. So what I really want to talk about is this, again, has been a big year for gastroesophageal cancers. We have a lot of new treatments, and I think a lot of treatments that will evolve over the next few years. So I'm very excited. These are my disclosures. What I'd like to do is I'd like to review the recent gastroesophageal data, talk about what these results mean in the context of wider literature, and then talk about how we can apply these to our current clinical practice. The first thing I want to touch on is the perioperative and adjuvant management of esophageal and G-junction adenocarcinomas. I think there were two very important studies this year. The NEO-AEGIS study was presented at ASCO, and the Checkmate 577 study was updated this year at ASCO. So this is the NEO-AEGIS study. It tried to answer a very important question that I think we as medical oncologists have been trying to grapple with for quite some time. This was presented by Dr. Reynolds. It looked at patients with esophageal and G-junction adenocarcinomas and randomized them to receive chemotherapy, surgery, and more chemotherapy, or cross-type protocol followed by surgery. And this was a non-inferiority study with the primary endpoint of overall survival. And because FLOT became the standard of care during this study, about 27 patients on this study received FLOT. Not surprisingly, when we look at toxicity, chemotherapy was more toxic in terms of neutropenia, in terms of diarrhea and vomiting. And looking at the results, at least in terms of pathologic response, treatment regression grade, and R status, Arm B seemed to be the winner. But looking at overall survival, there was absolutely no difference with a hazard ratio of 1.02. So what can we conclude? Well, preoperative chemotherapy was not unacceptably inferior to cross-TMT. The 3-year survival was 57 versus 56% respectively. Looking at sort of local regional outcomes, cross was the clear winner. And I think a lot of people are still asking the question, would this hold true if more patients had received FLOT chemotherapy? And do these results really apply in the context of the results of the Checkmate 577 clinical trial as well? So let's then move on to Checkmate 577. This study was updated by Dr. Kelly at this year's ASCO. Again, just a reminder for everyone, what we looked at was stage 2 and 3 esophageal and G-junction patients. These patients could have either adenocarcinoma or squamous cell carcinoma. They had to receive neoadjuvant chemoradiation therapy and surgical resection. They also had to have had an R0 resection and then had to have residual pathologic disease. They were randomized in a 2-to-1 ratio to nivolumab or placebo for up to a year. The primary endpoint being disease-free survival and secondary endpoints including overall survival. The majority of the patients on the trial were actually patients with adenocarcinomas. And because at the time that this study actually started, tumor cell PD-L1 expression was thought to be more important. This was extrapolating from lung. This is what was initially looked at. And as you can see, very few patients had tumor cell PD-L1 expression greater than or equal to 1. Looking at the disease-free survival, as we now all know, this was doubled, 11 versus 22 months. And the disease-free survival seemed to favor nivolumab in really all of the subgroups looked at. These are the new data that were presented at ASCO. The distant metastasis-free survival was 17.6 versus 28.3 months. And progression-free survival 2 was also presented. So progression-free survival is the time from randomization to progression after first subsequent systemic therapy, or the initiation of second subsequent systemic therapy or death, whatever happened first. So you can see that with placebo, that was 32.1, and with nivolumab, it was not yet reached. So what can we conclude from this study? I think we now know that nivolumab is certainly an option in the adjuvant setting following chemoradiation therapy in those patients who have residual pathologic disease. What I tell my patients is that disease-free survival is doubled. What I also tell them is that we still don't know whether there will be an overall survival benefit. I certainly hope there will be because of this improvement in distant metastasis-free survival and progression-free survival, but clearly we don't know. And what is, I think, also very important, when we looked at the quality of life analysis, these patients weren't harmed by receiving nivolumab for up to a year. So I think that is equally important. Next, I want to talk about the metastatic gastroesophageal cancer setting. And I think there have been quite a few studies in the past few years that look very encouraging. So first, let's talk about what had established our standard of care in HER2-positive gastric cancers. This trial, which is now a fairly old trial, published in Lancet in 2010, the TOGA trial by Dr. Bang. They looked at patients with HER2-positive advanced gastric cancer and then randomized them to 5-FU or capecitabine plus cisplatin, with or without trastuzumab. And we've all seen the results of this trial. These are patients who are defined as HER2 positive, so FISH positive IHC2 plus or IHC3 plus. These patients benefited with about a 4-month overall survival benefit with the addition of trastuzumab. These are the new results that were presented by Dr. Jinkijian at this year's ASCO, again, the Keynote 811 study. So this was a very important study. It looked at patients with advanced gastric or G-junction adenocarcinomas who had had no prior therapies in the advanced setting. They had to be HER2 positive, and they were randomized in a 1-to-1 ratio to receive trastuzumab and FP or CAPOX with or without pembrolizumab. There was a dual primary endpoint of overall survival and progression-free survival, and secondary endpoints included overall response rate, duration of response, safety. So what Dr. Jingijian presented was a protocol-specified first interim analysis, and there are a couple of things I want to point out about her presentation. First, the majority of patients in the study had IHC3+ cancers. Also, if we look at PD-L1 CPS greater than or equal to 1, the number of patients that had a CPS greater than or equal to 1 is actually quite high. These are the results of the study, and although the overall response rate is very impressive in the pembro arm, what also strikes me is that patients respond quite well to chemotherapy alone. So this study showed an overall response rate improvement of 22.7%, which is clearly statistically significant. However, if we look at the duration of response, it was 10.6 versus 9.5 months, and this was not that different. Looking at safety, there were really no new safety signals that were identified in the study. And what can we conclude from this study? Well, pembrolizumab plus trastuzumab plus chemotherapy clearly results in an improvement in overall response rate. Adverse events were similar between the two arms, and certainly there were no concerning signals that we saw. Overall survival and progression-free survival is not yet available. However, we also know that the FDA has recently approved pembrolizumab in this setting based on improved overall response rate. I guess the question for my colleagues is, would you prescribe it? Do you believe that that was the right decision by the FDA? I guess these are philosophical questions. I certainly do discuss this study with my patients. However, currently, I don't believe that I have enough to recommend that my patients pay for pembrolizumab, which is not currently covered in Canada in the first-line setting. Then the next question, let's talk about novel HER2-targeted therapies in gastroesophageal cancers. So this is trastuzumab deruxtecan study. It was published by Dr. Shitera now in the New England Journal of Medicine. This is a third-line study in HER2 positive gastric or G-junction adenocarcinomas. The patients were randomized in a 2-to-1 ratio to TDXD, or physician's choice chemotherapy, which in this case was irinotecan or paclitaxel. The primary endpoint of the study was overall response rate. And the results of the study were actually quite impressive. When we look at the responses to trastuzumab deruxtecan, we see that many more patients respond to it than to chemotherapy. Now, remember, this is in the third line or beyond. The overall response rate is also very impressive. It was 51 versus 14%. And the overall survival was also improved. It was 8.4 versus 12.5 months. But there was a safety signal identified in the study. 12 patients were diagnosed with interstitial lung disease, and 3 of these had grade 3 or 4 toxicity. So this is moving to our earlier line phase 3 trials. We now all know that. So we will see where this drug ends up. This is the other drug that I find very interesting. It's called zanidatamab. The results of the gastroesophageal cohort from this phase 1 study were presented by Funda at GI ASCO 2021. So zanidatamab is a bispecific HER2-targeted antibody. It binds to ECD4, which is the trastuzumab-targeted domain, and ECD2, which is the pertuzumab-targeted domain. And because it has this unique transbinding, it has multiple mechanisms of action, including enhanced receptor clustering and internalization. I just want to point out that the majority of patients that were treated in this study had 3 or more lines of treatment. In terms of tolerability of the drug, the majority of the side effects we saw were grade 1 and 2 diarrhea, which were not that common, and infusion-related reactions. We saw very little grade 3-4 toxicities. This is the anti-tumor activity of zanidatamab plus chemotherapy. We see most patients experience some degree of response. So let's talk about what the response rates were. To monotherapy, in this heavily pretreated population, the response rate was 33%. And to combination chemotherapy, the response rate was 54%. What was most impressive to me was, albeit now in a small number of patients, was this progression-free survival of 10.9 months. And what I will say is that this has held true with more patients and prolonged follow-up as well. So what can we conclude? Zanidatamab is well tolerated with promising anti-tumor activity in patients with HER2-expressing gastroesophageal cancers. The majority of the AEs that were seen were grade 1 or 2. There were durable responses, and based on this, zanidatamab is also now being evaluated in patients with HER2-expressing gastroesophageal cancers in global studies. So what would I conclude in the HER2 positive setting? Both trastuzumab deruxtecan and ZW25 or zanidatamab have promising activity. Whether this will translate into benefit when combined with chemo in earlier lines is yet to be determined, but is being studied. And pembrolizumab has been approved for HER2 positive patients in the United States. Will this happen for the rest of the world? I think we'll have to see once more data is available. The last thing I want to talk about is I want to touch on the use of immunotherapy in gastroesophageal cancers. There are many trials of PD-1 and PD-L1 in gastroesophageal cancers. Many of these have now been published. Most recently, the Checkmate 649 trial was updated at this year's ASCO. And of course, the Checkmate 648 study was also published. What did we know about IO in gastroesophageal cancers before the publication of these two studies? Well, we did have some negative studies. The Keynote 061, which was the second line study, and the Keynote 062, which was the first line study, both looking at an intention to treat population of patients with PD-L1 CPS greater than or equal to 1, were both actually negative studies, as we're well aware. The MSI high patients, though, clearly benefited, and that led to this hypothesis that there would be a biomarker that could be used to help select patients for IO therapies. So the CPS score matter. We all now know that it does. This was the initial analysis presented by Dr. Shutera and published in Lancet. Looking at the post hoc analysis of the Keynote 061 clinical trial in patients with the CPS greater than or equal to 10, they clearly benefited from the use of immunotherapy over chemotherapy. Now, this is the Checkmate 649 clinical trial, which was presented this year at ASCO by Dr. Moeller. What was presented were really two arms, although I'm just going to remind everyone that this is a 3-arm study, which included Nivo-1 and AP3. And that's important because we'll talk about what Checkmate 648 clinical study showed this year. So the two arms that were updated again were the Nivo plus Zelox or Folfox arm versus the Zelox or Folfox arm. Just reminding everyone, although I know everyone knows this, that this was a dual primary endpoint, overall survival and progression-free survival in patients with a PD-L1 CPS greater than or equal to 5. So the majority of these patients had gastric cancer. Most of them had metastatic disease, and most of them had, actually very few of them had MSI high disease. So most of these patients had MSS disease. Here are the overall survival results. Overall survival was certainly improved in patients with PD-L1 CPS greater than or equal to 5. It was 14.4 versus 11.1 months. And I think that is a significant improvement. We can also see that PD-L1 CPS greater than 1 and all randomized patients benefited in terms of overall survival. But what I will point out is that the hazard ratio seems to be increasing, which would point to a decreasing benefit, which to me indicates that this might be driven by patients with a CPS greater than or equal to 5, which made up 60% of the total population in the study. So let's look at the efficacy subgroup analysis by PD-L1 CPS in all randomized patients, and then broken down by CPS. So looking at patients with a CPS greater than or equal to 5, overall survival Nivo plus chemo 14.4 versus 11 months. Hazard ratio is impressive. However, when we look at patients with a CPS less than 5, the survival is 12.4 versus 12.3 months, hazard ratio of 0.94. I also want to point out that the overall response rates, regardless of CPS, were improved. And I think that's important when we look at what happened with the Keynote 811 study and why it's important for us to wait for the progression-free and overall survival results there as well. These were the new data that were presented at ASCO. This is the time to symptom deterioration in all randomized patients. So there was a 23% reduction in the risk of symptom worsening with Nivo plus chemo versus chemo. And when patients were asked to fill out the FACT-GA forms, the majority of all randomized patients indicated they were not at all or only a little bothered with treatment side effects in both treatment arms. So that's whether they received nivolumab or not. Just a quick reminder of the other studies that give us support for use of IO in adenocarcinoma patients. So I've shown you the results of Checkmate 649. However, we also remember that Attraction 4 study was presented within the last year. Attraction 4 was different than Checkmate 649 because it was done in Asia only, and it did not use a cutoff of CPS or TPS. Keynote 590 study, which was also clearly positive, actually included predominantly esophageal squamous cell carcinoma, and it did use a cutoff of CPS greater than or equal to 10. The results of these studies, interestingly, in terms of Checkmate 649, this was a positive study. Attraction 4, though, was not positive in terms of overall survival. But what strikes me about this study is if we look at the overall survival, even in the control arm, it was 17.5 months. So just think about how much better patients do in Asia. And why might that be the case? Well, a lot of patients in Attraction 4 actually went on to receive second-line chemotherapy, while quite few went on to receive second-line chemotherapy in North America. And a lot of these patients also went on to receive subsequent IO, which may well have diluted the overall survival benefits. So what have I concluded from these studies and how do I apply them? Well, nivolumab in combination with chemotherapy clearly improves overall survival for patients with a CPS greater than or equal to 5. I'm not as convinced that it actually works in patients with a CPS of 0. In fact, I really think that these patients probably don't benefit at all. And I also don't think that there is strong evidence that it benefits patients between a CPS of 1 to 4. So CPS score clearly does correlate with response. Importantly, quality of life was preserved with nivolumab. And I think as we're all aware, recently the NCCN guidelines recommended using IO for patients with a CPS score greater than or equal to 5, which is interesting because the FDA, as we all know, has approved immunotherapy in all comers in the first line. So this is the last study, but I think a very important one. This is Checkmate 648 study, which was presented by Dr. Chow at this year's ASCO. This is a very important study which randomized patients with unresectable, advanced, recurrent, or metastatic esophageal squamous cell carcinomas in a 1:1:1 ratio to receive Nivo plus chemo, which was 5-FU cisplatin, Nivo, which was dosed at 3, and Ipi, which was dosed at 1. So I just want to remind you, in Checkmate 649, the dosing was actually reversed. So Ipi was much higher dose, Nivo was the lower dose. And then chemo 5-FU plus cisplatin. So the primary endpoint was overall survival and progression-free survival. I also want to point out that the primary biomarker used in the study was actually tumor cell PD-L1. So like what we use in lung, not CPS. So about 50% of patients in the study had a tumor cell PD-L1 expression greater than or equal to 1. And most of them had de novo metastatic disease. So here are the overall survival results with Nivo plus chemo. I think these are very impressive. In patients with tumor cell PD-L1 greater than or equal to 1, there was a 46% reduction in the risk of death and a 6.3-month improvement in median overall survival. So clearly this is clinically meaningful. The hazard ratio observed was very low and impressive at 0.54. In all randomized patients, for me, the results were not as impressive. The hazard ratio increased significantly to 0.74, and the overall survival benefit was 2.5 months. For me, this would indicate that probably this overall survival benefit is being driven by these patients. In terms of who benefited from Nivo plus chemo versus chemo, all groups seem to benefit. They presented the tumor cell PD-L1 expression. So look at the patients with less than 1. The hazard ratio observed was 0.98. Okay, overall survival does not seem that different. Interestingly, females did not seem to benefit and as much, and then patients with recurrent disease also didn't seem to benefit as much. I mean, again, what can we draw from these? Not much yet, because these are subgroup analysis. The overall survival in terms of nivo plus ipi versus chemo was also impressive. I do want to point out one thing. There's this characteristic crossing of the curves. So there are clearly some patients which were treated with nivo and ipi who did not benefit from the study, and probably in whom this was actually detrimental. However, the overall survival in the randomized patients was improved by 4.6 months with a reduction of risk of death of 36%. All randomized patients too benefited, but look at this hazard ratio at 0.78. So clearly, again, I think this is being driven by patients with the tumor cell PD-L1 expression greater than or equal to 1. In terms of overall survival subgroup analysis, again, I'm just going to point out that women who are actually rare in this patient population in general don't seem to benefit as much. And again, patients with recurrent disease don't seem to benefit as much. In terms of treatment-related adverse events, there was really nothing new identified here. This was a fairly safe treatment, and there really were no new safety signals. In terms of grade 3-4 events, these occurred in less than 6% of patients across organ categories. And I just want to point out that even treatment with nivo-ipi, albeit the dosing of ipi, as I mentioned, was different, was actually quite safe. So what they concluded is that nivo-ipi and nivo plus chemotherapy are a new potential first-line treatment options in squamous cell carcinomas, and that there were no real safety signals that were identified here. I do agree with their conclusions. Both nivo plus chemotherapy and nivo plus ipilimumab are reasonable treatment options in first-line esophageal squamous cell carcinoma patients. However, I don't believe that all patients benefit equally. Clearly, TPS is a better predictor of response. I'm really excited to see this paper published, and I know that they're also working on biomarker analysis, which I personally will be very interested in as well. In terms of selecting patients who go on nivo-ipi alone, I think these must be carefully chosen. Personally, I wouldn't put patients with high volume disease on nivo-ipi alone. I think we all know that immunotherapy takes a while to work, and clearly there were some patients on this study who did not benefit. So what can I conclude? Great time to be a gastroesophageal cancer medical oncologist, a medical oncologist who treats gastroesophageal cancers. There are now new adjuvant treatment options. We all knew chemotherapy was very toxic. Nivolumab clearly is not. New metastatic options for both squamous and adenocarcinoma patients, and new HER2 targeted options are coming as well. Thank you very much for your time.
Thank you, Dr. Alamova. So thank you. Comprehensive review, I have to say, very elegantly presented. So if I may, I'm going to start with a few questions. I'm going to start with a philosophical question, just like the one you asked early on, Elena. So US FDA have approved nivo plus chemo based on the Checkmate 649 study, irrespective of PD-L1/CPS score. Now, why is this important to us in this region? I'm going to speak about Saudi Arabia. So when PD-L1 CPS score with us is a send-out test. Now, send-out test means it takes time to come back. We are very frequently presented with patients who come late, who are quite symptomatic. So we want to give them, the best, or what we think is the best regimen up front. So would you, how does this translate into the FDA approval? What's your approach, Elena?
So I'll be very honest with you. This is a question I get asked by patients a lot. So in Canada, this is not covered by our government. It was just recently Health Canada approved. So we're waiting, as you know, on the P-coder decisions in funding. And I have a suspicion as to what will happen, but I don't know exactly what will happen. I'll also tell you that we struggle with the fact that CPS testing is actually not validated in gastric cancers in Canada at all. So it sounds like you guys are actually ahead of us in at least having a validated test. So what I typically do for my patients is, as I completely agree with you, often these patients are patients who can't wait to start treatment. I start chemotherapy. I can obtain CPS testing in my center, and I do wait for it. And if a CPS is greater than or equal to 5, I do actually make the recommendation that if either the insurance will cover it or the patients can pay for it out of pocket, that they take it. With a CPS less than 5, I really find it difficult to recommend, given the biomarker analysis that have been presented in this trial, and also now given the NCCN guideline recommendations. I think you know that there's been a lot of talk about this, and that experts don't all agree on what should be done here, but clearly the experts in the NCCN guidelines have come together. For me, I also tend to recommend this for patients with a CPS greater than or equal to 5. But I do start with chemotherapy and then add the nivo, usually, within 1 or 2 cycles, similar to what I do with Herceptin.
It makes a lot of sense. I think this is probably what we do in Saudi Arabia, just because of the time that it takes for the test to come back. Mm-hmm. So going back to the Keynote H11, I know you answered this, but FDA approving based on objective response rates. I completely agree with you. I think we should probably wait until we see what the PFS and what the overall survival is like. But it is quite interesting, to see a significant difference in objective response rates, probably driving the FDA approval. So what's your commentary on this, Elena?
So I showed you the results with the Checkmate 649. If you look at the overall response rates in Checkmate 649, those patients all also had an improvement in overall response rate. And that improvement was actually quite impressive as well. But as we saw in Checkmate 649, that didn't necessarily translate into an overall survival benefit. Fundamentally, I don't believe that we should be approving drugs based on overall response rates, because we all know that overall response rate is not a surrogate endpoint for either progression-free survival or overall survival. I mean, anyone who can show me a study that shows that, we already argue is PFS, is DFS a surrogate for overall survival, and there we actually have some data, right? So fundamentally, I think those kinds of approvals stop a lot of clinical trials that are important in answering questions. So I personally don't agree with it on a philosophical level. And also I find it difficult to discuss with my patients because frankly, should I recommend something that I don't know improves overall survival? I just don't believe in that,
Makes a lot of sense, Elena. I guess my next question is, where does triplet chemotherapy in the metastatic or advanced setting still fit? Would you consider giving it to super fit young patients, or are we still thinking that, doublet is enough and we shouldn't use triplet?
So I think this depends on what you're trying to achieve in these young super fit patients with metastatic disease. Because fundamentally, when you look at trials, let's say of HIPEC, or when you look at trials of metastatectomies in gastroesophageal cancer, all that these trials show is that if you take patients with a very good biology of disease and you give them chemotherapy for a long time, and if they do well, and then you resect their disease, some of them, not many, but few, do well. Okay, and I think that speaks more to the biology of their disease than it does to giving them more treatment. So what we don't know is that giving these people triplets is going to actually get more of them to surgery. In fact, if you look at the FLOT data from Dr. Albetran, where he looked at a very carefully selected patient population, right? Like these were patients with very minimal metastatic disease. One can argue whether they really showed any benefit in those patients. I think what I can say is it adds more toxicity. Overall response rates now with the use of nivolumab plus chemo are also quite impressive. So if I'm going to use something, I would go to chemo, FOLFOX, CAPOX, plus some type of targeted therapy. That would be my personal preference. Personally, what I think will happen in the treatment in gastroesophageal cancers, because there are also some very interesting data with, let's say, FGFR2b, right? I think what we will eventually see is the segmentation, similar to what's happening in lung. That will be the way we treat gastric cancer, by biomarkers, or I hope so.
We all hope so, certainly, Elena. Last question, I promise. Approach to elderly and very frail patients. How would you approach those patients if they have metastatic gastric cancer?
So I'll be very honest with you again, okay? So there's good data, I think, that's available, including retrospective analysis from our center of the very elderly patient population. Many older patients are treated, and they're treated without having increased toxicity. So chronological age does not necessarily equal, you know, your metabolic age. So I have some I often say I have some 80-year-olds that are better than some of my 50-year-olds. So of course, we're lucky in that we have geriatric oncologists who work with us. We will often get their input. However, if a patient is fit, regardless of age, I would treat them as per standard of care. And I think when you do that, these patients do just as well, although they were not originally included in clinical trials.
Thank you, Elena. We do similar. A significant number of our elderly patients who are in their 80s, specifically the ones that they don't come from large cities, they come from small villages, are quite fit. And they tend to do well with chemotherapy, and I don't think we should undertreat them just based on age. So I agree with you, Elena. I'm not sure if the audience have any questions. Now, I can't see them nor their questions, so I'm not sure who's actually sitting at the stage, if any of the physical attendees have any questions to Dr. Ilimova.
Yeah, yes, hi, Hassan Ghazal here. Thank you for a really comprehensive talk. So just a brief first on the cross versus flot. May I ask what you do in the outside clinical trial?
Absolutely. So I should say that we practice so I've worked in two places in my career. One was MD Anderson and one was Princess Margaret Hospital. And we actually practice fairly similarly. So in patients with G-junction tumors, if they're CWRT1, or if they're esophagus, we do prefer cross therapy. All of our patients with localized disease have to be discussed. This is actually a quality control measure at our center in a multidisciplinary setting. Even if the plan, I'm talking even about very early stage patients, because we often know that, you know, how we stage patients often underestimates their stage. So first of all, I guess what I would say is all these patients deserve a discussion by a medical oncologist, radiation oncologist, surgeons in conjunction with pathology and radiology. And then a combined decision. But generally what we do is we treat the AG type 3 tumors similarly to what we treat gastric tumors like, so preferentially with chemo. And I'll be honest with you of why we do that. In terms of looking at these AG1 and 2 tumors, esophageal tumors, a lot of them, if they have local recurrences, these are horrible recurrences. It's all about how they're gonna fail. We all know that with chemotherapy, the chances of having these bad local regional recurrences, even the NeoAGES study showed us that, or probably more. So historically, this is how we have treated patients. What do you guys do? I'm curious.
Well, similarly, I agree with you. I think the more they are in the through GE junction, I would say chemoradiotherapy is still the preferred cross trial. Plus, it's faster. I mean, you remember you have to give 4 cycles and surgery, then come give 4 cycles post-op, and you know what happened post-op many times. Patient have long recovery, delay. So of course, I think we're a little bit more preference for cross trial still. My other question.
And it's better tolerated as well, like you said.
Yes, absolutely. And just one comment, this is the first time FDA has more liberal approval than NCCN guideline. It's usually the other way around. And in fact, we were all surprised because every other cancer where they had PD-L1 subgrouping, and the FDA strictly gave the approval only for the particular PD-L1. So I think everybody was shocked. So my other question, how do you choose between Nivo and Pembro? We have so many trials. And does the location matter, esophagus versus gastric? And in that sense, does chemo matters, where cisplatin 5-FU was used in the squamous and more with the FOLFOX with the Nivo? Do you shuckle around or you strictly follow the trials?
So can I be very honest with you on this? Because we are just in Canada, our coverage often lags behind what the government approves. So Health Canada approval may come and has come, but our approval for payment will be about a year behind. So the answer to that question is a very practical one for me. If we have a compassionate access program, I'll use that because a lot of my patients can't afford to pay for these drugs. In terms of how would I apply it strictly, I mean, I think these agents have overlapping activity. That's the truth of it. I think that if you're going to be exactly strict, Checkmate 649 answers the question for both esophagus, G-junction, and gastric cancers. I think Keynote 590 for me primarily gives data for treatment of patients with squamous cell carcinoma with some additional support, because those were the majority of the patients included in that trial, with some additional support being given for adenocarcinoma patients.
And they have to be over 10% in that.
That's
Even
right.
worse.
That's exactly right. And you know, this is what is, I think, going to drive us crazy as medical oncologists, all these different biomarkers. I mean, now we're dealing with TPS, CPS, what's the best biomarker? And then, like you pointed out, there are different cutoffs that are used in different trials. So I think all of these are questions that need to be further studied. That's why I'm so curious to see more of these biomarker studies, which I think are coming.
Thank you.
From all of these studies. Thank you.
I'm not sure if there are more questions from the physical attendees.
I don't think we have any more questions here. So thank you so much, Dr. Kanan Shamari and Dr. Elena, for your time and expertise. And you left us with more questions than answers. So thank you for that.
Thank you very much.
So I would like to invite Dr. Falah Khatib to join me now. So now we're coming to a conclusion of today's event, and I would like to thank everybody who stayed till late. And certainly this would have not been possible without the support from our partners in the pharmaceutical companies. Thank you so much for your support for the activities, not including this conference, but also your research support is making a difference in UAE research and the region research as well. So first of all, we'll go to the next slide, please. Next slide. No slides? So we'll be announcing the winner of an iPad who had the most interaction in our virtual platform. Let me just pull the name since we are having technical difficulties here. Can you show the names of the names and the points? Anyway, the winner of the most actually the winner who claimed the most points, 3,500 points in the platform, is Lalit Manglani. And he will be receiving his iPad by mail. He should contact our team here by email. So he'll be receiving that by mail. So thank you, and Mabruk, congratulations, Lalit Manglani. Okay, so now we'd like to invite Novartis, our platinum sponsor. AstraZeneca, please. AstraZeneca. يعني جيك يعني حاضر. Anybody from Bayer? Anybody from MSD? We'll keep it then. Anybody from Roche? Servier? Vitaris? Next, please. Amgen. حالة ترقب طبعا. Who's next? Merck. Pfizer. Assalamu alaikum. Thank you so much for endorsing the Emirates Oncology Society by King Hussein Cancer Center. The mic is yours.
يعطيكم العافية جميعا. بالنيابة عن مؤسسة مركز الحسين عمان الأردن بحب أشكر الإماراتس Oncology Society والبروف دكتور حميد الشمسي for giving the opportunity to take part in this conference. وأكيد بحب كتير أشكر الأورجنايزرز على هذا التنظيم، وشكر كبير للسبيكرز بصراحة وللمحاضرات القيمة اللي سمعناها من حضراتهم اليوم وامبارح، وكل الشكر على هذا التكريم العظيم، ونتمنى لكم جميعا مزيد من التقدم والنجاح. و thank you so much again.
Thank you so much for your support and our best regards to everybody, and we look forward to see you in person, inshallah, in the near future.
Our great pleasure.
There were only 2 hospitals supported the Emirates Oncology Society, the Barjee Cancer Institute, and also the Gulf International Cancer Center. So thank you so much. So to this end, we're coming to conclusion. We had 2,874 total registration and 1,685 total unique online registration. So thank you everybody for making this success. And inshallah, we look forward to see you again in more activities in the near future. And thank you for everybody for staying till late today. And inshallah, we'll see you again in the near future. Assalamu alaikum wa rahmatullahi wa barakatuh.